good morning to everyone. Today, the session 7, we will be starting with radiology and interventional radiology. For that, I would like to invite the chairpersons, Dr. Venu Bhargav, Dr. Jagdish, Dr. Uma, and Dr. Sujesh. And I would like to invite the speaker, Dr. Sri Priya Srinivas ma'am, to talk about imaging in liver disease. They used to put. They used to put. They're not putting. One second.
Good Sunday morning, everyone. I'm Dr. Sri Priya Srinivas. First of all, thanks to the organizing committee for giving me this opportunity. Imaging in liver disease is it's a broad topic. So my aim here is, since most of us are not radiologists, to show you lots of pictures and explain them as well a bit as we go. And the running theme, I think this time, is about evaluating the complex liver recipient. So with a view to that, I'll proceed. So this is a brief overview of my talk. So no talk is usually complete unless we have a brief overview of the cross-sectional segmental anatomy, about how we estimate hepatosis, steatosis and fibrosis on CT-MR. Some salient features in CLD portal hypertension and some points that we need to keep in mind while evaluating an adult or pediatric child for transplant. So this is a cross-section of the liver. This is a section above the porta. So like we have on the pictorial image, when we see the CT image, it is a good practice to always map out the hepatic veins, the right, middle and left, because then we can, so automatically the segmental segments form in our mind. So in a section above the porta, it's the segments 8 and 7 on the right, segments 4A and 2 on the left. This is a section below the porta. Usually the middle hepatic vein, even if you don't see, but you can see the gallbladder in the gallbladder fossa. And even if you can't see the left hepatic vein, you'd see the falciform ligament. So again, on the right, you'll have segments 5 and 6. And on the left, 4B and 3. So it's always nice to have the segmental anatomy and map it out when you are going through a liver scan. Every liver is different, and this kind of tells you, it helps us localize lesions. We can work out volume redistribution. So it's a good practice to go whenever we look at any CT image or CT or MR image of the liver. A brief thing of looking at hepatic steatosis. So liver attenuation index is on a plain CT. It is calculated as the difference between the average attenuation of liver and spleen. So if it's anything over 5, liver is usually more attenuating than spleen. So if it's over 5, that's a good sign. And what happens in fatty infiltration, the fat in the liver brings down its attenuation. So liver starts attenuating less than the spleen. That's when it starts going in the negative. Less than -5 is not good. The same thing can be done by MR fat estimation. So the algorithm in the software, it calculates, there are specific sequences that we run that will calculate the fat percentage. MR fat is actually much more sensitive than CT. And the grades that we know, we are all familiar with it. So we can grade the fat depending on the percentage that it shows. MR elastography, what we are doing is we are sending shear waves into the liver, mechanical waves are sent, and depending upon the compliance of the liver, stiffness maps are generated. These are color-coded as well. So it is along the Budd-Chiari spectrum. So anything in the violet, indigo, blue range is okay. So once we start seeing areas of green, fibrosis has started to creep in. Green then goes on to areas of yellow and red as the fibrosis progresses. So the advantage of this is on a T2 image in MR, you might actually have a completely homogeneous signal intensity. You won't really know that there is fibrosis going on. CT also won't be able to pick up. And it's at that point that when we superimpose the stiffness map, you can see that there are areas of fibrosis that have crept in, and this is only seen only when you do the elastography. So this is that is the shear waves. This is which is then changed into stiffness map images, color-coded, and we can put a value on it and see what's the liver stiffness. So MR elastography is again very sensitive, reproducible, and a good estimation of fibrosis. This is a good going liver cirrhosis, so you can see the liver is now no longer violet and indigo, it's all yellow and red in keeping with fibrosis. Now this is how you work up a liver recipient. This is what we've been following at Global. I think it's probably the most important slide of my talk because everything in terms of a liver recipient workup is all to do with timing. So our first image, which is the arterial phase, should always be a late arterial phase. That's why I've circled these. So there should be some enhancement of the portal vein. Why? Because only then you can see any enhancing lesions in the liver against a relatively slowly enhancing liver parenchyma. Anything that's hypervascular will stand out. Any portal vein thrombus will stand out. So it's important to have this late arterial phase. Portal phase should show good opacification of the portal vein so that you're able to pick up any filling defects in the portal branches or the main portal vein. And always important to get a good hepatic phase so that you can see all the 3 hepatic veins and make sure that they are patent. A delayed phase can be done to look, in case there are lesions that are washing out, you won't see them as the scan is happening. So best is to do a plain late arterial portal hepatic and a delayed image and then look at the images at leisure. So this is for those of us who are especially not looking regularly at images. So this is some of the salient features of chronic liver disease. So this person has ascites. So this hypodense area on both sides is ascites. This is edematous bowel wall thickening, like a thumb printing it is doing. That is edematous haustral folds in the colon. You have splenomegaly there. And this is a cirrhotic liver. Now it is seen on a coronal section. So you can see a shrunken right lobe, a hypertrophied caudate in front of the IVC, irregular outlines to the liver, and we can make out the slight heterogeneous parenchymal enhancement that is seen in cirrhosis. I hope this is not the case when the surgical team walks into radiology to ask for a report. But there are specific things that the radiologist should be aware of and should mention. And these are the things that the clinician is looking for. So first thing is the portal vein. Patency of the portal vein are the branches patent. So we can see a filling defect here. That's a nice round filling defect. So we can be assured that this is a brand thrombus. We also need to see, is it just in the, what is the extent of so is it occupying part of the lumen, the entire lumen, and which portal branches is it involved? Is it the right and left main? Is it the main portal vein? Is it extending up to the splenoportal confluence? So here we can see in the main portal vein, you can see a partial filling defect which is reaching up to the superior mesenteric vein origin. It's important to look for this and mention it in the report because it helps the surgeon a lot in planning management while planning for transplant. So this is the Yerdel's grading. So it's the same thing what I said. So where there's a partial occlusion or is it a complete occlusion? Has it started extending into the SMB? How much is it extending into the SMB? And if there are any big collaterals that you can see, it's worth mentioning them. This is to differentiate a bland thrombus from I probably will put the next slide first. So this is the Avena criteria to look at a tumor thrombus. So it's very important that we know how a tumor thrombus will look like. So the main features in Avena that we will see in CT or MRR, that the vein gets expanded, the portal vein, with the soft tissue, and this can enhance and wash out. It can show new blood vessels. It may be adjacent to a site of HCC or a prior treatment site. So I'll go back to the previous slide now, as opposed to the bland thrombus that we saw in my previous slide. So here we can see, this is the late arterial phase, and that's the hepatic venous phase. So you can see both the portal branches expanded by soft tissue. The soft tissue enhances and washes out. It is adjacent to a small tumor site here, which is the primary. And you can see the neovascularity. All these lesions of vessels are the blood vessels. So the tumor is basically fully growing into the portal vein. And quite often, I'm sure most of our surgeons and hepatologists will be aware, this can be actually the first presentation of the patient itself. So the patient comes to us with, suspected CLD, and you do the CT, and this is your picture. So, it is possible that you are picking up an extensive HCC with invasion of the portal vein. So always when we look for tumor thrombus, the patient may be just being evaluated for pre-transplant, and you pick up a tumor thrombus. So is it bland or is it malignant is an important criteria to differentiate. I think this I'll leave to Gayatri. This is just to show that if there is a portal vein thrombus, unlike the nice portal vein that we see there, that's a normal patent vein, you can have a leash of vessels sitting at the porta, that's a portal carcinoma. When there is portal vein thrombosis like that, there will be invariably large portosystemic collaterals. So here we can see large linorenal and perisplenic collaterals, probably draining through the left renal vein into the IVC. So important to look for collaterals and mention, because again, they may need to be ligated before surgery, otherwise it will cause a steal phenomena. Cocoon abdomen, encapsulating peritonitis. So this commonly can happen in CLD itself because of repeated episodes of SBP or repeated paracentesis, or sometimes because of associated infections. So look for cocoon. So normally in the ascites, the bowel loops should be free floating. So here we can see the peritoneum is thickened, enhancing, and the bowel loops are all clumped in the center of the abdomen. So this is a cocoon abdomen. It makes for a difficult transplant. So as a radiologist, we need to look for it, mention it, because it helps a lot. And once, again with everything, once we know what the mind knows, we will look for it. So look out for a cocoon abdomen in somebody who's being evaluated for liver transplant. And mostly if it's caused because of CLD, the same patient, this is while he was being evaluated post-transplant for looking at the liver, we found that the areas of the thickened peritoneum had started de-leaving, and nicely now the bowel loops are opening up and they are filling the abdominal cavity. So that's cocoon, abdominal cocoon. Budd-Chiari liver. Now, Budd-Chiari, the thing is, sometimes patients will come to us as idiopathic CLD. They would not have, you wouldn't know they have a Budd-Chiari, so always nice to look at hepatic veins. So first of all, do a good hepatic phase. So you should be confident that hepatic phase should have picked up the hepatic veins, and if we can't trace the hepatic veins, it could be a case of Budd-Chiari. So what all do we look for in Budd-Chiari? So we can see this mottled enhancement. That's because of the differential drainage of the liver. The periphery is draining better, so that is more hyperattenuating. The central part is all congested. So you will see this mottled pattern of enhancement. You can, if there is any one hepatic vein that's draining, or if it finds one collateral, then you will see these intrahepatic comma-shaped collaterals that will be trying to drain through that pathway. And or if there are surface collaterals. So these are all nature's way of trying to get the blood out of the liver. So comma-shaped collaterals, surface collaterals, look for these. Most importantly, trace the hepatic veins, because if you can't trace them, then definitely this is a case of Budd-Chiari. This is another case just to show the caudate sparing. So this is obviously a very enlarged, engorged liver, a coronal section, and we can see the liver's weight is around 4.8, bigger than a baby. There is caudate sparing, so that's because the caudate veins usually drain directly into the IVC, so we can see that on this section. So I think this has been done to death yesterday with the Milan and the UCF criteria. So I'll just show, the main thing of this image was to just show that if you catch it in the late arterial phase, this HCC is nicely seen as an enhancing area that's washing out. This is the hepatic phase. So enhancing HCC, washing out in the hepatic phase. And look at this esophageal collaterals. You can see them. This is the hepatic phase, so you can see them. So quite a lot is obvious if you get the timing right. Now my next picture is so this yesterday Dr. Joy Varghese was saying, no, about when we have patients who have associated renal impairment, and he was talking about the renal impairment, but invariably that becomes a problem for us because, you can't give contrast for CT or MR. So what do we do? So quite often a plain MR with the T2 and diffusion images really helps in problem solving. So here we have, this is a T2 weighted image. So you can see the liver is dark, and it's a cirrhotic liver. This is it's hypointense on T2. Against this, there's a barely discernible, that's how HCCs will look. They'll be slightly hyperintense nodules. So, and when we go through the diffusion imaging, as the B value increases, so what we are looking for is restricted diffusion. So things like ascites, which are normally hyperintense, gallbladder fluid, the CSF, so they all get suppressed, and this cellular HCC will stand out in the diffusion images. I think I'll just proceed, just some more images are there to show. So this is again as how we can use MR equally to look for a pre-transplant evaluation. So here you can see that though we have not given contrast, this is just a plain MR. So you can see these slightly hyperintense, this is a shrunken right lobe. So this is all the right lobe, but there's a diffuse infiltrative HCC, the slight hyperintense signal. The soft tissue, again like the avenites, expanding, filling, so there's no signal void in the right portal vein. The better images are when you go to the high B value images, it's all showing diffusion restriction, which is extending up to the right main portal vein confluence. This is a few slides about pediatric transplant, just that when, it's nice to have a look at these images. So the indications are usually biliary atresia, hepatoblastoma, or metabolic liver disease. So biliary atresia, this is a slide that shows, so you have the background features of liver with chronic parenchymal disease. These hypodense linear areas are the dilated peribiliary glands. So this is how it will look. Other things to look for in a biliary atresia is the portal vein hypoplasia. It's very important for the surgeon because he may need to do an interposition graft if the portal vein is hypoplastic. Other gut anomalies, malrotation, IVC anomalies, that will help, they may need to manage simultaneously. So this is a normal portal vein. So anything over 4 millimeters is considered good by the surgeon. So this vein is around 5.5 millimeters. So important to make sure the baby is sedated well so that there are no movement artifacts and you can clearly measure the portal vein. So that's a normal portal vein, whereas that is a hypoplastic portal vein, which is around less than 2 millimeters. So you can see how significantly dilated these bile lakes are. Next, some of the syndromic variants that we can see. So this is biliary atresia with polysplenia, so multiple enhancing areas on the left side. This is annular pancreas, so some enhancing pancreatic tissue is there, lateral to the duodenum. Other things to look for, gut malrotation, so make sure the DJ flexure is crossing, the SMA-SMV relationship is maintained. The last is, maybe I'm still again venturing into Gayatri's territory. This is the pre and post staging of hepatoblastoma. Again, our segmental anatomy comes here into play. So we need to localize. So we have the liver as 4 segments. So this is the COPL staging. So this is the right posterior, right anterior, left lateral, and left medial segments. So we try to localize where the lesion is before, so it's all quite self-explanatory. We just see how many segments are free of tumor. So this is stage 1, stage 2, stage 3, stage 4. Why is this important? Because I think post-chemotherapy, if it's stage 1 or 2, they plan for resection, and if not, they go for a transplant. So here, this is a huge tumor. I mean, I think the contrast enhancement is different, but it is the same child, baby. So there's a large tumor. It's involved the anterior, posterior, and up to the segment 4. And only a bit of segment, left lateral segment is free here. And this is post-chemotherapy. It has shrunken, but it still involves I think the right anterior and segment 4. So this still remains a pretext 3. It was pretext 3 before, pretext 3 later on also. But we can see the good response to chemotherapy. And usually they tether towards the veins. So that's a point to remember as well. So I think I've already overrun my time, so I'll stop at this. No, I'm done actually. So thank you. Let's take care of our liver and eat healthy.
Thank you. It's a very wonderful presentation. Are we going to take the questions now or after the all 3 sessions? Now only. Any questions, anyone? Please ask.
I think it's too early for questions.
If no more questions, we'll proceed on to the next presentation by Dr. Gayatri.
Our next talk is on assessing response to downstaging therapies by Dr. Gayatri Senapati. She is a consultant and additional HOD radiology from KIMS Sunshine Hospital.
Very good morning to all. Thank you for this wonderful opportunity today to be on this platform on a topic like this, speaking on a topic like this, and a very good morning to chairpersons as well. All right, so assessing response to downstaging. So what do we define as downstaging? Now we have several loco-regional therapies for hepatocellular carcinoma. Now of these, curative is to completely eliminate where we are not looking at a transplant option, at least in the given scenario. Debulking and palliative is for the advanced ones, where often even systemic therapy is taken help of. Now, when it comes to downstaging, this is to reduce the tumor stage from beyond to within the accepted transplant criteria, where transplant is permissible. So one is outside Milan to within Milan, and now we also have a slightly expanded, a little more relaxed category of University of California's as well. So this is what we're trying to look at when we want to do a downstaging therapy. So either the size of the tumor is larger, but now we're even expanding into the territory where there is even intravascular extension, only barring extrahepatic spread. While bridging therapy is that where already the criteria within the transplant limit, but either the patient's condition or the availability of the organ is delaying the process of transplant. So we just try to hold the patient. Now, from the perspective of a radiologist, whether it comes to downstaging or bridging therapy or debulking or curative, our job is to assess response to treatment objectively, just to see how it was pre-treatment and post-treatment. So the common therapies used, those which are in practice now are ablative, which is percutaneous, radiofrequency and microwave. Transarterial is stays and tear, that is chemo and radioembolization, and external radiation, which is SBRT or EBRT. Now, even tear and SBRT, both these together come in a form of under a category of radiation when it comes to assessing post-treatment response. Now, though primarily we are looking at it, in the future, though there are no guidelines yet, we're also supposed to be evaluating the response to systemic therapy for downstaging with or without combination with these. So I will not be going into the post-treatment evaluation after immunotherapy because that's not exactly downstaging, it's more of palliative. So response assessment, we have multiple criteria which are used. Now, RECIST and WHO criteria look at the absolute size, which are generally for the other tumors. That is only looking at the size of shrinkage of the tumor, either in single dimension like in RECIST or 2 dimensions like in WHO criteria. But when it comes to hepatocellular carcinoma, we are not looking at the size, but we are looking at the arterial phase enhancing component. So we've seen the previous speaker show us as to how arterial phase hyperenhancement is a major criteria to determine whether a tumor is a HCC or not, especially in the background of chronic liver disease. So for HCC, it is either the mRECIST or the European, the EASL criteria, where the remnant enhancing tumor tissue is what is measured to assess treatment response. So mRECIST looks at it in single dimension and EASL in 2 dimensions. Now, when I'm showing something dark, it means that this was previously bright. That was the enhancing tumor. Like we've seen in the last case of hepatoblastoma, the whole of it would have been an enhancing tumor. But post-treatment, what you're left with is a smaller chunk of an enhancing tumor, which is what determines how well the tumor has responded to the treatment. Now, apart from mRECIST and EASL, what is again very popularly followed is the LI-RADS given by ACR. So LI-RADS post-logo regional treatment conventionally is categorized into 3. So pre-treatment HCC, when I'm showing you this image, it means that prior to treatment, the entire tumor was enhancing. It had enhancing viable tumor tissue component. Now after local regional therapy, we are trying to categorize it into either there is residual viable tissue or it is equivocal. We're not sure if there is some enhancing component or there isn't. And non-viable, where we are very sure there is no enhancing viable tissue remaining at all. So post-HCC, LRTR non-viable, you can see a completely white enhancing tumor in the arterial phase is now completely black and not enhancing. You might have a thin rim of peripheral enhancement, which is a normal response to treatment. Or there might be a mass-like enhancement, either within or along the walls of the lesion, which is considered as viable tumor tissue. So we're looking for nodular or mass-like enhancement here, not just rim enhancement. The other being equivocal, where along the wall there is some area of mild thickening, or maybe there is enhancement, maybe there is no enhancement. So we would want to follow this up before we conclude whether this is viable or not viable, or if it has progressed. Now what's important to remember is when it comes to comparing mRECIST versus LI-RADS. Now in mRECIST you can have a partial response where more than 30% of the tumor tissue is now necrotic. There can be a stable disease where there is more than 30% of the tumor remaining, but it hasn't increased. Or there can be progressive disease where it has actually increased. The enhancing tumor component has actually increased. But when it comes to viable LR-TR, all these three come under that. So there are some lacunae when it comes to LI-RADS, which is why often when it comes to treatment for curative intent, LI-RADS is often used. But when it comes to downstaging or for palliation, mRECIST is a better criteria to follow, because it actually tells you that whether the viable tumor has reduced in size, or if it's stable, or if it has increased. Now, both of these are interchangeably used depending on the situation. But in India, I've seen most people follow LI-RADS. All right, we look at a few examples. A 54 male, LR5 at diagnosis, that is LI-RADS 5 at diagnosis, a very cirrhotic liver background. You can see a arterial phase hyperenhancing mass lesion involving the left lobe, predominantly the left lateral segment. Now, post-TACE, this has been classified as LR-TR viable. Why is that? Now, we're looking at two different sections, one a little higher up, lower down. We can see that lower down, some part of the tumor tissue, this is the arterial and the portal phase, by the way. These two are the arterial and the other is the portal. Arterial, and these are the portal phases. So we can see there is still a significant portion of enhancing residual tumor tissue, which is continuing to enhance, so it is viable. And here lower down, you can see that there's still part of it which is enhancing along the wall, this small nodule, in both the sections. So only this part of it is actually responded and is necrotic. So this we would call viable. But on mRECIST, we would call this stable disease because there has been no increase. But it is not partial response either, because we definitely don't see more than 30% of the tissue having shrunken. Now another example, post-RFA. This would also be LR-TR viable. I am not showing you the pre-treatment image. This is only post-treatment. Now we can see that this is a pre-contrast. This is Dixon, which is why the artery appears a little bright. Dixon sequence as a type of T1 sequence. Now, post-contrast arterial phase, we can see multiple mass-like enhancing areas along the wall. Only the central part is necrotic. And in the later phase, in the extracellular phase, there is a rim enhancement. This rim enhancement is normal. That wouldn't be considered as residual. But this part, which was enhancing here, is actually also showing washout. So in this would be TR viable, again on LI-RADS. But on mRECIST, this is partial response because definitely more than 30% of the previously enhancing tumor has shrunken. So the take-home point here would be, we are looking for mass-like enhancement, not just peripheral rim enhancement, because this peripheral rim enhancement is a normal response, especially in the first couple of years post-treatment, and slowly tends to disappear. So on mRECIST, this is how we would measure the single largest dimension to look at how much of the residual tumor tissue is viable before deciding if it's stable disease or partial response or further increase. The 67-year-old male at diagnosis, HCC, arterial phase. I know it's not very brightly enhancing, a little hard to appreciate, but the washout is a lot more apparent. All right. So this is, so often larger lesions before downstaging to make them eligible for transplant require multiple cycles of TACE. So after first 1 or 2 cycles, if they don't respond, they look at switching over to an alternative therapy, but otherwise multiple cycles are given if there is good response in the first run. So this is one such. The same lesion here is now being assessed on MR. Now this is a type 2 hyperintense observation. This is post-contrast. You can see that there is a significant residual enhancing tumor. Now, what I want to highlight here is the role of diffusion. So, like our previous speaker had told us, diffusion is a very, very important part in assessing a tumor, both pre-treatment and post-treatment, because often the enhancement might at times get blurred in a background of hyperperfusion in the liver, especially post-treatment. So in such situations, if you can see, this residual tumor is showing definite restricted diffusion, bright on DWI and dark on ADC. Now there are some papers which also tell us about taking the ADC value to determine whether the response has been adequate or not adequate when it continues to restrict post-treatment, but we still don't have published papers on the values as yet. So the same patient now, after 2 further cycles of tests, we can see that there is absolutely no residual tumor tissue left. There's no enhancing component at all. Maybe a very thin rim of peripheral enhancement, which is acceptable and not taken as residual tumor. Now, one other point to keep in mind before calling something as a residual tumor would be a viable tumor, would be to look for perilesional perfusional changes. Like in this example, which I've taken out of this article, this APHE observation underwent microwave ablation, and we can see that this peripheral rim enhancement is all right, but here there's some nodular enhancement. We're not too sure if it's residual tumor or if it is just perilesional perfusional change because of the treatment. Now, on further follow-up, we can see that this has disappeared. So this stage, we would call it LRTR equivocal, whereas here, now we would call it non-viable. So on follow-up, it has turned into non-viable, but whereas in this example, another case, pre-treatment and post-treatment, this was after, microwave ablation again. So a similar confusion of perilesional enhancement, but this on further follow-up turned out to be actual residual tumor or viable tumor along the tumor margin. So this had actually progressed. So on MRESs, this would be progressive, whereas on LI-RADS, this would be viable. Okay, another example, post-tear 3 months for this lesion. This is one observation I want you to focus on. Now we do see still some restricted diffusion in this region. This is the contours of the tumor, and also the periphery is showing diffusion bright signal. And post-contrast, there is definite viable tumor. This is the enhancing tumor, which is also showing washout, enhancement in the arterial phase and some washout. But in addition, what we also see is this part of enhancement. So this is a common response post-radiation, something to be kept in mind before we call it as a viable tumor. So some points to note, peripheral rim enhancement is normal. Size of ablated tumor may be larger than the documented tumor size because it's not just the tumor that is getting ablated, but the post-ablation cavity might be larger than the actual tumor size. The other is benign peritumoral APHE, may be seen especially in post-radiation treatment. You may also see it in other ablation, but post-TARE, post-SBRT, it can persist even beyond 6 months. So watch for washout. If there is washout, we know we're not dealing with perfusion change, but with residual tumor. And follow-up, 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 that's the primary dictum. So post-SBRT, APHE may persist for up to 6 months. So we use other modalities and follow-up, such as diffusion or PET if there was a pre-procedural PET done. Now, LI-RADS is not used for systemic therapy, like even if it's an immune checkpoint inhibitor usage or sorafenib or any such, there we only use MRESs. Now, this is an important point to note because there can be something called a pseudo-progression post-SBRT. Now, one such example is from a BJR article. Pre-treatment, this is the size of the tumor, and post-treatment after SBRT, 3 months follow-up actually shows a large area of hyperperfusion where we'll be left in doubt is the tumor actually progressing. But a further follow-up actually shows that this is just peritumoral hyperperfusion, but the primary tumor per se has undergone necrosis. Now, we've seen downstaging for those tumors which were larger beyond either the UCSF criteria or the Milan's criteria. But there are more and more studies and publications coming on downstaging those with portal vein tumor thrombus. So what do we look for in such cases as radiologists? Persistent APHE in tumor thrombus means that the tumor hasn't responded. That is, the tumor thrombus hasn't responded to treatment. Diffusion restriction. So diffusion and persistent APHE are the main factors to look for. And if there is PET-CT, and if it has been PET-avid pre-treatment, post-treatment PET avidity means that there is residual tumor. So this is an example of one such case my friend from AIG shared with me. A large enhancing mass extending through the middle hepatic vein into the IVC. You can actually see the tumor thrombus extending into the IVC. Now this is the pre-treatment PET where you can actually see a large area of uptake. It was a very PET-avid tumor. Now, post-treatment, this is 6 months SBRT, EBRT, sorry, in this case, and then 9 months. Now, you can see, now this is a classic reaction where the tumor has undergone significant necrosis. It has responded very well, but you see a rim of hyperemia around it, but on PET, you find that most of it is gone. There's very, very good response. This was previously PET-avid, and now that's disappeared, including the tumor thrombus. Look at this. This is the tumor thrombus, which doesn't enhance anymore, and no uptake on PET either. Now, same thing after 9 months, you can also see a mild shrinkage in the size and no residual tumor. So these are, there are yet to be very authenticated publicized articles on PVTT treatment for downstaging, but I'm sure we'll see many more in the future. Now, the other thing, if there is no PET-CT previously done, apart from APHE, because there can be persistent enhancement in the arterial phase post-SBRT even up to 6 months. So in such cases, diffusion is something which comes to our rescue. You can see that this whole tumor has ablated very well to SBRT, but the tumor thrombus still remains. So it's restricting on diffusion, DWI, and ADC. Now, I would like to conclude with the latest guidelines of LI-RADS 2004. Now, based on what I've told you, you would have seen that SBRT behaves slightly differently post-ablation. There can be persistent perfusion, either in the enhancing tumor component or in the surrounding. So there are two categories for LR-TR, LR, that is LI-RADS post-treatment response. A separate one for non-radiation-based treatments, such as TACE or microwave or RF ablation. But for both TAR as well as SBRT, there is a separate category. So what does this do? It tells us that LR-TR non-progressing is an additional category which has been included. So we previously had only viable, non-viable, and equivocal. But this has an additional category called non-progressing, which is mass-like enhancement to any degree in any phase. It could be arterial venous, any phase, which is stable or has reduced in time after treatment. And we also take into account, so previously you would have seen that LI-RADS actually takes only APHE into consideration, but not diffusion, but now restricted diffusion, and even T2 signal are being considered. So one such example, yeah, this is from a very recent abdominal radiology article. So before treatment, LR-TIV, tumor in the vein, in the middle hepatic vein. 1 month after SBRT, though we're seeing that some of the tissue, most of it has ablated, there is still an enhancing component. So we would have previously called this viable. But now we're going to call it non-progressing because this is SBRT, we're going to wait and watch. Now 5 months later, still non-progressing because there's a very tiny enhancing component, but the tumor has overall shrunken in size. And there is no progress, no new lesion, no increase in size. But 4 years later, it now converts into non-viable. So a long-term follow-up is more important in SBRT. So this is my last slide. So what do we do with SBRT? Unlike the other ablative procedures, we have to follow up for longer. What happens is you can see a rim-like edema in the tissue around the tumor in the normal liver, which shouldn't be interpreted as positive tumor. Wait and watch, or take the help of diffusion and look for washout. And then over time, this perfusion reduces. It is replaced with fibrosis slowly, so it becomes hypointense. So initially, it would have been edema and some tissue necrosis, which slowly undergoes fibrosis. And with time, further reduction in size, and ultimately, you will barely see it. So SBRT requires a separate way of follow-up when compared to other tumors. So in future, I'm sure we'll be seeing a lot more cases of post-immunotherapy, post-portal vein tumor thrombus treatment for downstaging, but we do not have published articles as yet. So I think we should watch this space more closely. Thank you.
That is an excellent presentation, ma'am. We can take questions from the floor.
Madam, I'm from medical oncology. So we use a lot of immunotherapy of late. So not only liver cancer, other tumors also. We face with one peculiar problem of pseudoprogression and hyperprogression. Of course, many times clinical scenario help us. So in assessing a patient receiving immunotherapy, what are the features that we should take in differentiating these both? So
one of the things for pseudoprogression, just like in SBRT, one thing is we look for whether the enhancing component is also showing washout. A tumor tissue would show washout. It's very important to compare the imaging of the tumor prior to treatment with post-treatment. So one thing we look at is dimension. The other thing is we look at how it behaved, whether there's arterial phase hyperenhancing component along the margins and whether there is washing out. Because the pseudo-progressive part would never show washout, whereas actual tumor progression would show washout. If there is a pre-treatment PET, it helps a lot. If it was a PET-avid tumor, if it's not PET-avid, we can't take its help. The other thing which helps is diffusion. Now, there are more articles coming up on ADC value. So the tumor ADC value, which means that it is a very restrictive tumor, which means the tumor cells are densely packed. So the ADC value would be much higher in a tumor tissue than in the surrounding edema, which can also look bright. So these are the factors, but these can guide us. But very often what actually helps us is a short-term follow-up, like we've seen in the other example. We'll have to do a short-term follow-up unless we're really sure it's progression and it's showing washout.
We use iRECIST criteria in other solid organs. Is it followed in HCC also?
HCC, iRECIST, yes, it is coming up, but honestly, I'm not more familiar with, we use more of mRECIST, but I think immunotherapy is a separate ballgame in every organ. Like we recently saw a case of thyromegaly with a lot of inflammation, changes in the lung with all immune checkpoint inhibitors. I think we need to learn a lot more about it.
Thank you.
Good morning. I really enjoyed the talk. But my question is about LI-RADS per se, because right now we are seeing a lot more tumors, HCCs, arise in non-cirrhotic livers, in, for example, metabolic liver disease. So are we in a position to use LI-RADS to stage tumors that are arising in non-cirrhotic milieux? Because I know that there is a hepatitis B qualification.
Correct.
Is there something
Correct.
similar?
Only
for
only in the background of hepatitis B, even in the absence of cirrhosis, LI-RADS can be applied. But I mean, LI-RADS is a criteria given by ACR, so they tell us we shouldn't use, we cannot use it.
So not for metabolic liver disease-induced
No,
tumors?
not yet, not yet. It probably might come in MASLD in the future, but not yet.
Sure. Thank you.
Extending Dr. Sonal's question, ma'am, there is a gray, especially in resectable liver tumors like non-cirrhotic background, where there is a chronic hepatitis and child cirrhosis. There is another component that volume expansion is also required. So how to address this issue, especially in this group of patients?
Volume expansion of?
Volume hypertrophy in chronic hepatitis and child A patients, especially those gray area.
In terms of imaging?
Yes, ma'am. And overall, FLR to improve the functional liver reserve.
We're talking in terms of volumetry, right? We're talking in terms of volumetry.
Yes,
functional liver residue.
Yes, ma'am.
All right. So if it is not going to be an anatomical resection, one thing we look at is the tumor volume taking the contours of it and rest of the liver. So when we're talking about volumetry for the functional liver reserve, when there is a background of CLD, it becomes impossible for us to tell how much of it is going to be is going to be functionally efficient. So that is where elastography comes into role, like our previous speaker just showed us. In many cases, we are asked to do elastography to assess the background liver tissue stiffness and also look at the background liver's fat. Now, when there is fatty liver, especially if it's more than 20%, 30% liver fat, and if the background is showing F2, F3 fibrosis on imaging, we know that though anatomically we say there is the residual liver, say after left hepatectomy, the right lobe is going to be so much, or after right hepatectomy, the left lobe is going to be so much. We know that we'll have to take it with a pinch of salt because the functional efficacy of it is going to be less. So I think a procedural elastography and fat quantification might help us know that it's going to be much less than that. But how much less, I don't think we are in a position to quantify it.
Thank you, ma'am. If there are no questions, we can ask.
And I'd also like to just convey that many of the treatment cases that I've shown you are by Dr. Jagdish's team when I was in AIG, a chairperson.
Thank you, Dr. Gayatri. I mean, your talk was primarily about hepatocellular carcinoma, but now there's a lot of evidence for neoadjuvant therapies in intrahepatic cholangios and even perihilar cholangios. So, are the principles any different in terms of assessing the response with neoadjuvant therapy?
There we don't use LI-RADS, but it's more of a RECIST criteria because those are not arterial phase hyper-enhancing masses. When we often, so we probably the next greatest chunk we're looking at is either cholangios or metastasis. So we can't apply LI-RADS. We'll have to go more in terms of RECIST or M-RECIST, depending on whether it's a hyper-enhancing tumor or not that. But honestly, I need to read up more about it.
Any questions from the floor? If there are no questions, we can move to the next speaker.
Thank you.
So the next talk would be by Dr. Srinivas, intervention radiologist from Max Hospitals, New Delhi. And his talk is about intervention radiology in chronic liver diseases. I would like to invite him to stage.
Good morning, Hyderabad. It is always a pleasure being in Hyderabad. I thank the organizing committee for extending invitation to me and giving this opportunity to be here. It is an absolute pleasure at being here with such a lovely, pleasant place and weather. I like Hyderabad, especially yesterday when I arrived. It was breezy, pleasant, and I could feel the difference from Delhi. So, without wasting any further time, so I'm Shahnawaz. I work at Max Delhi, and my topic for today is role of intervention radiology in chronic liver disease. So, it is quite a vast topic. I would say it is most of what I do. So I will try to touch everything in brief, and I will emphasize only things which I think are relatively newer. So the role of intervention radiology starts with not just the treatment and the management part, but from the diagnosis. As intervention radiologists, we perform diagnostic workup also, like we do percutaneous liver biopsies, we do transjugular liver biopsies, we do HVPG measurements for establishing and measuring the severity of the cirrhosis. And then we do certain treatments which slow down the progression of the liver disease or sometimes halt the progression of the liver disease, like hepatic vein stenting for HVOTO, what we call as Budd-Chiari, or portal vein recanalization. Portal vein recanalization in non-cirrhotic EHPVO, which is something newer coming up lately. We'll be touching it. And then there are patients who have complications of portal hypertension, and we offer them TIPS or DIPS, BARTO or PARTO. And then finally, most of these patients ultimately will require a liver transplant somewhere down the line. And then after receiving the liver transplant, some of these patients may have complications related to liver transplant, and they will require again help from intervention radiology in terms of their arterial complications, portal vein complications, hepatic vein complications, are the most common, what is biliary complication. So I will not touch the post-liver transplant part, but we will do only the CLD part. So diagnosis. We know that liver biopsy is still an essential tool in diagnostic workup of certain group of CLD patients, especially where autoimmune hepatitis is suspected or other forms of liver disease where we need to know the histology of the liver. And percutaneous liver biopsy is the most commonly performed technique, and it is easily available, cost-effective. But sometimes percutaneous biopsy is not an option because of certain contraindications like coagulopathy or severe thrombocytopenia, which is uncorrectable, or there is severe ascites, or patient is very, very obese. Or sometimes we require an HVPG, and as part of the HVPG, we also perform transjugular liver biopsy. So all these contraindications become an indication for transjugular liver biopsy. And transjugular liver biopsy nowadays, we in our practice call it transvenous liver biopsy, because transjugular liver biopsy is not only done by the jugular vein, it is nowadays also being done from the femoral vein. I will be touching it. So this is a commonly used transjugular liver biopsy equipment, what is called as T-lab set or lab set. And transjugular liver biopsy is done like this, from the jugular axis, a long catheter, and then a sheath, and then the biopsy gun goes into the inferior vena cava, and from there it enters the hepatic vein, and from hepatic vein it enters the liver, and a sample is taken from this part of the liver. And in transfemoral liver biopsy, the access is taken from the femoral vein, the cannula and the set, and the biopsy gun enters inferior hepatic vena. It doesn't usually enter the hepatic veins. It is directly taken from IVC, and it pierces directly into the liver parenchyma. So it is something like this. Next, HVPG, we know that it is usually a part of diagnostic workup, and this wedged hepatic venous pressure gradient is the pressure which is transmitted through the sinusoids from the portal vein. So it basically reflects the portal venous pressure. I think this video is working. So this is how it is usually done. From femoral axis, we place a catheter and cannulate a hepatic vein, and we wedge the hepatic vein and make sure that there is no contrast leaking anywhere, and then we measure the pressure. And 5 mm Hg, more than 5 mm Hg is usually defined as portal hypertension. Then we come to the next, that is halting or slowing down the progression of the liver disease. And in this, we all know that Budd-Chiari patients are especially eligible for these, especially those who have hepatic vein outflow tract obstruction at the level of the ostia or suprahepatic IVC. And interestingly, HVOTO per se, to begin with, is not a liver disease at all. It is basically a vascular disease. And because of the vascular disease, back pressure changes, the liver disease follows. So if we catch this patient early and we are able to reverse the vascular problem, we may be able to prevent any further progression of the liver disease. And in this, we usually perform balloon dilatation, but often stenting is also required. This is the EASL criteria of EASL recommendations for the HVOTO management, Budd-Chiari management, which starts with medical treatment, then angioplasty and stenting, then TIPS, and finally liver transplant. But in our practice, we usually combine these first two, medical management and angioplasty and stenting. We don't wait for patients to go into the full-blown disease and then perform angioplasty. We begin the first two steps together. And this is a line diagram to show how it helps. For example, if there is suprahepatic part of the IVC is blocked, there is a web, and we are able to open it, so it will restore most of the flow. The congestion will be relieved. And if there is hepatic vein ostial obstruction, like here, so we can balloon it, we can pierce it, we can balloon and stent it, and this will restore the blood flow. Sometimes the hepatic veins are totally obliterated. In those, we cannot re-establish physiological blood flow. So in those cases, DIPS is performed, which is a variant of TIPS, like this, which connects portal vein directly into the IVC or the cavoatrial junction. These are a few examples from our practice. So this is a patient who had severe IVC stenosis right at the cavoatrial junction. And this is balloon angioplasty being performed, and this is the IVC venogram after the balloon angioplasty is performed. So this patient required just balloon dilatation. We didn't even require a stent placement for this patient. And but sometimes hepatic vein ostia are blocked, and they are very severely blocked. I have been blocked for a very long time. These patients usually require balloon dilatation followed by stenting, and they generally do well. Another case where there was severe hepatic vein outflow obstruction at the ostia level, we had to perform a stent, and the flow could be restored, and the congestion could be relieved. So going to the literature briefly, Reocclusion rates are significantly less in patients who undergo stenting compared to those who undergo only balloon dilatation. And when DIPS is required, for example, in this patient where the hepatic veins are totally obliterated, there is no length of the lumen of the hepatic vein which could be stented. So in this case, like for example, we have to place a DIP stent. But sometimes there is combined hepatic vein as well as IVC occlusion, like this patient. So we had to restore the IVC, which is the stent seen in the middle, and as well as perform a DIPS procedure. So this patient underwent a hepatic vein angioplasty followed by stenting as well as DIPS. It worked for him for more than 3-4 years. After that, he had to undergo liver transplant. And literature, we all know that there are excellent liver transplant-free survival of patients who undergo TIPS or DIPS for EHPVO. Next comes, I will briefly be touching the portal vein recanalization. This is a relatively new thing. Maybe not all of us have heard about it. So portal vein recanalization for extrahepatic portal vein obstruction. There are 2 ways of doing it. In our practice, we try to do hepatic vein angioplasty and stenting alone to open the portal vein, which has been blocked there for some time. There is another way of doing it. Some other centers are doing it. We usually prefer not to do it, is doing TIPS in these patients, which opens the portal vein and redirects the blood flow into the IVC like TIPS normally does. So this is a relatively new thing, and there is literature coming up in this area. Traditionally, EHPVO, we all know, is treated by managing the complications of EHPVO, not trying to open the portal vein, but to try to do the things which are resultant from the portal vein obstruction, like there are varices, we will do endoscopy, ligation, there is splenomegaly, splenectomy, there is portal cholangiopathy, we will do Recipient stenting. But this is something coming up new, that we open the portal vein, and this actually relieves all the, it reverses most of the problem. And like I said, certain centers are doing TIPS for EHPVO, but at our center, we prefer doing PVR alone, except very rarely when it is not possible. And there is a recent study which shows that PVR alone may be superior to TIPS in case of EHPVO. I'll give you a few examples. This is a gentleman from Bangalore. He had EHPVO for more than 24 years. And this is his CT scan when he met us first time. And he had come to do with this. He had large varices on endoscopy. So these are the varices. I think these are visible. So he had large varices. He also had large splenic artery aneurysms. So he had come to consult for this. And when we found when we reviewed his imaging, we found there is only a short segment of portal vein which is occluded, which is causing formation of cavernoma, varices, and everything, and splenomegaly. So we were able to open this portal vein. This is the portovenogram. We see that no blood flow is going into the liver. I hope it is, yeah. So this is the portovenogram, no blood going into the liver, and there are large collaterals which are leading to the paraesophageal varices. So we are able to balloon dilate this portal vein and restore a satisfactory amount of blood flow to the right portal vein. And following this, it has been more than 3 years. This gentleman is doing well. His varices are gone, and he didn't require any other form of the treatment till now. We haven't done any stenting. This is only balloon dilatation. She's a girl. She is 11 years old. She had her first episode of upper GI bleed when she was 5, and she was diagnosed to have portal cavernoma. After that, she is being regularly on endoscopy, getting endoscopy done almost every year. And at 11 years age, when we met her first, we found that there is a short segment of portal vein which is causing to this cavernoma formation. We performed a portovenogram. This was the cavernoma, multiple collaterals, and leading to. We were able to dilate the portal vein by balloon dilatation. We didn't require any stent. We placed her on oral anticoagulants. This is the Doppler image post balloon dilatation. We can see the portal vein excellent flowing. This is soon after the procedure was performed. And now it is 3 years follow-up. Her portal vein is working. She's on a regular follow-up, and she is taking the oral anticoagulants. This is a lady. She is an athlete. She has EHPVO for 20 years. She had her first upper GI bleed when she was pregnant, as was diagnosed to have EHPVO and portal cavernoma. When we met her first, she had a stent in her CBD for portal cholangiopathy. She had a massive splenomegaly. She also had cholecystitis, for which percutaneous cholecystostomy was done. This is the pigtail catheter. We were able to see that there is a short segment of portal vein which is leading to portal cavernoma. So we placed a stent in the portal vein. Following this, her portal vein is seen that excellent opacification of the portal vein branches. And once these collaterals deflated, and we were hopeful that there will be no major bleeding risk now, surgeons performed hepatico-jejunectomy on her. So her portal cholangiopath is, my time is up. I will try to quickly finish. So this is the image from the angioplasty when we try to, this is the portal vein branches. This is the superior mesenteric vein. We placed a stent across to restore the blood flow, and later HJ was performed. And it is almost 2 years plus now. She has been doing well. I think I have exhausted most of my time. So another patient, in this case, portal vein recanalization alone didn't work, so we had to place a TIPS. Portal hypertension in CLD, it is known to all of us. So TIPS is performed for various reasons. I will quickly go through it. The most common complication for, common indication for TIPS is varicose bleeding. The second most common is refractory ascites, but there are other indications like Budd-Chiari syndrome, portal vein thrombosis, hepatic hydrothorax, hepatorenal syndrome even improves with the TIPS, hepatopulmonary syndrome, and portal hypertensive gastropathy. There are certain contraindications to TIPS, and HE being the most often encountered and difficult to manage. And these are some images from the cases we have done TIPS for. And next is the BRTO. We understand the BRTO is basically done to knock off the varices, gastric varices, and the lienorenal shunt. So there are, this is video. I would have tried to run it faster. So normally the blood should go from splenic vein into the liver, from the superior mesenteric vein into the liver, but because of the portal hypertension, sometimes collaterals find their way through the gastric mucosa or gastric collaterals into the renal vein. There is how the BRTO works. A balloon or a plug is placed in the renal vein, right, where it opens into the renal vein, and then sclerosant or glue or other forms of embolic material are placed in this varix to completely obliterate it. So this is the principle of BRTO. These are few cases we have done. This is a classical BRTO, and this is PATO, where plug has been placed in instead of a balloon. This is the sclerosant cast in the gastric varices. There are variations of the BRTO. One is PATO. For example, in this patient who had undergone endoscopic coil placement, but there was a recurrence of bleeding, so we had to perform a BRTO. We can see this coil which has been placed endoscopically, and after that we had to perform PATO, and this is the cast of the sclerosant after BRTO. Sometimes retrograde cannulation is not feasible, so antegrade cannulation is done, like in this transjugular cannulation of the portal venous system and filling of these gastric varices. So antegrade embolization was done in this case. We didn't perform a TIPS in this case because the patient had a history of HE. ectopic varices, this is one of the cases from Dr. Kaushal Madan, sir. He is in the hall. So we have also published this case where there were ectopic varices in the colonic region. And we had to take transsplenic access because the patient's portal vein was also chronically thrombosed. So transsplenic access to the superior mesenteric vein, and then we found this colonic varix. We have published this case as a case report. You can find it online. So in biliary pathologies, I will not go into the PTBD details. I will only highlight the biodegradable stent, which is something which has come up lately. The only advantage of the biodegradable stent is that it doesn't need to be removed, so it reduces the number of hospitalizations. And is especially, we are using it patients who cannot come for follow-up because they are like international patients or other reasons. And the indications are expanding. Right now, we are using biodegradable stents for patients who have HJ, and they are unable to come, or they are unable to tolerate with the PTBD catheter hanging out from all the side, outside. And in our experience, we have done till now 8 cases where we placed 9 stents, 2 stents in one patient, so total 9 stents. Most of them, all of them were post-living donor liver transplant. HJ structure, 3 patients and 6 were duct-to-duct, and we had only 1 complication of major cholangitis in 1 patient. He had to take a prolonged course of antibiotic, and he is also doing well. These are some cases of the biodegradable stents. This is another biodegradable stent, duct-to-duct. We had to place 2 stents. And we might in future get drug-coated biodegradable stents as well. So I conclude that CLD is a disease which demands multidisciplinary management, and intervention radiology is contributing in significant ways to help manage these patients. This is our team at Max Delhi. Thank you so much.
Very interesting talk, Dr. Shanawas. I'm here. I mean, it was very interesting to see the case report the cases you showed for the recanalization of the extrahepatic portal vein. I'm a surgeon. We do a lot of shunt surgeries for these kind of cases. Shunt surgeries. Shunt proximal splenorenal shunt surgeries for these kind of cases. So my question is, how do you select patients who will benefit from this recanalization process?
Yeah, I wish I had more time to elaborate on this. That is a very excellent question, actually. So all these patients which I showed were very carefully selected. Like I repeatedly mentioned that on review of the imaging, we found that short segment of the portal vein is actually blocked. So what we do in selection criteria, we perform a Doppler ultrasound ourselves and review the CT images particularly. We try to find that splenic vein has to be patent, superior mesenteric vein has to be patent, and intrahepatic branches of the portal, either right or left or both, have to be patent. Okay, so splenic vein is very easily seen on CT, superior mesenteric vein is very easily seen on CT. In the portal vein, you will see ornicavernoma. Intrahepatic portal vein branches are very difficult to see, even on CT where they are open. The reason that it takes very long time for the contrast to reach there, and the portal vein is by that time gone. So we perform a Doppler to see that intrahepatic portal vein branches are patent. If on Doppler you are able to see intrahepatic portal vein branches, even in one lobe, you can think that this patient is a suitable patient for intervention.
And that one patient which you showed, in which you are recanalized, had a massive splenomegaly. So the spleen size and hypersplenism reverts back after the recanalization?
Yeah, again, an excellent question. So her spleen was, I guess you are, her spleen was like 23 centimeters. It is like now 17.5 centimeters. So it has regressed to some extent, but not completely.
Okay. Nice.
Thank you.
Yeah, in the similar lines, I have a question. How this EHPO is classically seen in small babies. Usually we see younger than 5 years. So what is your experience? Can we do portal vein stenting or balloon dilatation in EHPO in a small baby? That's my first question. Second question related to the same thing, whether they need multiple sessions or you just do it at one go.
So, pardon, your first question is?
Small babies, EHPO, is there a chance of doing any IR procedure and recanalizing the portal veins? Because classically, EHPO is seen in very young babies.
Yeah, so most of our experience comes from our liver transplant experience, to be honest. We didn't upfront start doing it on EHPBO. You are aware that we have a very large liver transplant team, Dr. Subhash Gupta. So it is quite common in babies who are post-transplant, not EHPBO, post-transplant to get portal vein stenosis. So we have done portal vein balloon dilatation and stenting in those patients even if they were like 6 months old. But for EHPBO, the youngest baby we have probably attempted was like 2 years, not less than that. We haven't attempted maybe.
Okay, would they need multiple sessions or?
Generally, single session for all these patients we have done. Until now, we didn't require a second session. But yes, there is one baby where portal vein recanalization was done, and both the right and the left branches of the portal vein were initially flowing well. In the follow-up, the left portal vein slightly got attenuated and then completely disappeared. But right portal vein is working well, so we are not bothered. So left lobe anyway can atrophy.
Okay, thank you.
Thank you.
Thank you very much. If no more questions, we'll conclude the session here.
Thank you so much. Thank you.
Next is a radiological case about recurrent HCC, and I would like to invite the panelist, Dr. Shanti Bhushan sir, nuclear medicine from Star Hospitals, and Dr. Abhishek Mathur, surgeon, Columbia University, USA, and Dr. Chinnababu, radiation oncologist from Star Hospitals. And again, I would like to invite Dr. Shanwas, intervention radiologist, to be a panelist in this session, and Dr. Santosh, medical oncologist, Star Hospitals. And I would like to invite the speaker, Dr. Rajgopal Acharya, from liver transplant surgeon from Star Hospitals.
Good morning, everyone. So, I will be discussing a case of recurrent HCC. So, welcome all the panel members. So, a 70 years male, diabetic, good performance status, no previous surgeries, evaluated for abdominal pain and malaise, was diagnosed to have a right lobe HCC. AFP was normal, PUCA 287 to start with. PET scan was negative for metastatic disease. So he underwent right hepatectomy preserving MHV. Post-op course was uneventful. Histopath showed moderately differentiated SCC with perineural invasion and lymphovascular invasion. No positive lymph node. He was initiated on lenvatinib 4 mg. Dose escalation was not possible due to GI intolerance. The follow-up scan after 3 months was unremarkable. AFP and PUCA were normal. 6 months follow-up PET scan showed a left adrenal lesion around 1 centimeter in size with an SUV max of 2.8, no other lesions. The AFP and PUCA were normal. So, what would be the treatment plan at this stage? So, the question would be directed to Dr. Abhishek, sir, please. Right lobe hepatectomy done moderately differentiated, no recurrence at 3 months. At 6 months, isolated left adrenal lesion, 1 centimeter, SUV max less than 3.
So, you know, the SUV is higher than what what you'd anticipate for a benign lesion. Just how it's related within 6 months to a large HCC, which you had lymphovascular invasion, so obviously not great pathology. It's probably a MET. I don't think we really need sampling of the lesion. You should have pretty reasonable idea that it will be a MET. in terms of the treatment options, I've historically pretty aggressive about going after these adrenal mets or after resection or transplant of an HCC. This is a very small met, so usually these are like 3-4 centimeters, and you need to take them out surgically, and you have pretty good long-term survival after that. But this is probably something the IR guys could manage even.
Okay. So, and what about the tumor markers, Dr. Santosh? A tumor which was secreting PIVKA high, and then follow-up PIVKA has been normal, but a low SUV lesion in the left adrenal gland. What would be your take?
So, as in this case, the markers normalized after the initial treatment, after lenvatinib and all. The size of the adrenal lesion is very small, 1 centimeter. The SUV max is also not high. So sometimes with small metastasis, sometimes the biology of tumor changes, and small volume of disease might not depict the elevation of markers. Also, as we know, the PIVKA is more to deal with the hepatic invasion. Suppose we have an extrahepatic mets, the proportionate elevation of PIVKA might not be there. So these are the factors that it depends on the volume of disease that is there, what is the site of disease that is there. Sometimes there would be tumor heterogeneity also. Sometimes the metastatic site might not be secreting. Multiple factors. The major factor in this case possibly would be the small size of metastasis might not have production of AFP and PIVKA.
And just to add on to that, I think probably like a very short-term follow-up is very reasonable in this situation.
So the patient was continued on lenvatinib, and a 9-month follow-up showed a rise in PIVKA to 1532. A MRI liver showed multiple hepatic recurrences. The left adrenal lesion was still stable in size. We did a PET scan which showed multiple FDG avid liver lesions and non-FDG avid left adrenal lesion. The adrenal lesion left side was still stable. So what would be your treatment plan at this stage? Dr. Santosh.
So,
multiple hepatic recurrences post-resection.
So basically, it is obviously a recurrence with both radiologically and also tumor marker wise. So also at this time, I would always look to see any of the local treatment possible, but extrahepatic disease that precludes any local treatment. Suppose the adrenal met was not there, still we would have considered if some local measures were possible. Because of the extrahepatic disease, systemic therapy is what I would choose. So the obvious choice in this case would be combination of immunotherapy and bevacizumab. But of course, we have multiple 2 other options in the form of double IO combination is also a reasonable option.
Okay. Any role of IR, Dr. Shanwas, where we can target both the liver as well as the left adrenal lesion?
Yeah, as IR, I would have been glad to see the imaging of the recurrence. We don't have the image right now. But yes, in our practice, we generally try to do locoregional treatment even after surgical resection when there is recurrence. This week only we had a patient, there were 3 new lesions in the residual left lobe of the liver, so we performed a TACE procedure. We plan to follow it with microwave ablation once in the follow-up we see any residual or anything. But yes, if there are multiple lesions and they are scattered throughout the liver, or liver is studded with the lesions, IR probably it doesn't have much role, maybe systemic immunotherapy or something.
And any role of a combination? There is some literature about combination therapies.
Suppose there is a dominant liver lesion that is very much symptomatic, about to rupture, or very dominant. In that scenario, we always try to use a combination. So,
I'd want to know like what the status of the liver is too. I mean, I don't know what you did a right hepatectomy?
Right hepatectomy, preserving MHV.
Yeah. So, I'd like to know what the status
there are multiple lesions. Repeat resection is out of question.
Yeah. No, and just in terms of a tear or a Y90 to that lobe, as long as your bilirubin's not too high, that's possibly something you could attempt.
Okay. The patient was planned for immunotherapy, 6 cycles. So he tolerated the immunotherapy very well, even though he was very elderly. So after 3 cycles, AFP was normal. The PIVKA continued to get elevated, and from 1532, it was 2921. So, Dr. Santosh, should the same immunotherapy be continued, or should we explore second-line options because PVCA is still continuing to rise after 3 cycles, even though there are no side effects or anything?
So generally, we assess the patient wholesome, not isolated on the tumor markers. How is the patient doing overall? How is his liver functions? And how are the imaging parameters? So the thing we see with immunotherapy is the responses are not early. Sometimes responses might occur at 4 or 5 cycles. And even in the clinical trial of IMBRAVE 150 and other clinical trials, marker elevation, that is only biochemical recurrence, is never considered as a hard point for changing treatment. Okay. So I would assess the imaging, the clinical setting, and this only elevation of PVCA would not warrant me of changing therapy. But of course, I would have a discussion with the patient that we should have a close follow-up, but I would tend to continue the same treatment without changing at this point of time.
Okay. We didn't do a repeat imaging at this stage. So we finished the 6 cycles of immunotherapy since the patient was tolerating well. AFP was always normal. The PVCA reduced slightly from 2900 to 2100. The PET-CT showed no significant change in the tumor status. So what are the treatment options at this stage?
I think there's somebody who has a, Dr. Sunil.
Hi, sorry. This is a non-cirrhotic patient, right?
Yes, a non-cirrhotic.
So there's 2 parts here, but because immunotherapy doesn't work very well in non-cirrhotic HCC. Firstly, because cirrhotic HCC and non-cirrhotic HCC are very different genetically.
Yes,
so non-cirrhotic HCC typically have an overexpression of the Wnt pathway, which is a proliferative pathway. And actually, cirrhotic HCCs typically have a repair mismatch pathway problem. So immunotherapy in general is not a very, very good option for non-cirrhotic HCC. The second thing is, for non-cirrhotic HCCs, Milan criteria does not apply.
Yes.
Okay, so you can actually offer liver transplantation for patients even with multiple metastases who are outside of conventional criteria if there is no vascular invasion.
Yes, sir. So I will come, sir, to this discussion again. We have a question for that.
Can I just make one point?
Yes.
So just to explain Dr. Sonal's, the patient was 70 and they didn't want a transplant. That's one thing. No, but the main thing is, I just had a doubt. No, we're talking about should we give immunotherapy or tear, and we also put an option of both. At least my impression was, if you do tear or TACE, does the immunotherapy work better? Because there's some theory that
there's some literature
the tumor gets lysed and that exposes the cells, the T cells to for further activity. Is there any real truth in that, or is it just a supposition that we do local therapy, immunotherapy works better?
Combination of nivolumab therapy plus tear is better outcome, sir. And phase 2 trial says, CA786 trial says, so synergism effect of both immunotherapy and tear, it has better outcome, and performance status of patient is very well.
So there's good data on SBRT, I believe, Metro, isn't it? SBRT and immunotherapy, there's good data on that. So
come.
I think we are interrupting your panel discussion very quickly on this point about tear actually causing significant tumor necrosis, release of tumor antigens into the circulation, and then that causes immune activation. Wherever your checkpoints have, wherever your tumor cells are evading your immune system, all those checkpoints are exposed. And so there is increasing literature that if you actually give tear, even for particularly for large tumors more than 5 centimeters, there are some trials showing almost equivalence to surgical resection and better microsatellite metastasis control with tear. You have a longer lasting response and reduced recurrence. Of course, these are all preliminary, but the mechanism is that your tumor antigens are exposed and your checkpoints are exposed to your immune system.
There are certain immune phenotypes where the immunotherapy actually works and tear causes that thing to get expressed. So,
and just to piggyback on those comments, the reason why dual therapy is probably better because immunotherapy only helps a small percentage of patients out of everybody who has these. So having tear, as a dual therapy that's just another rationale for it.
Okay. So at this point, I would like to ask that question. If we are considering tear in this setting, what about the left adrenal nodule? How to deal with it? I suppose immunotherapy will be acting on both.
If we suppose the left adrenal nodule is malignant, we can perform a radiofrequency ablation or a microwave ablation. In our practice, we have done it. ablation works very well in case of adrenal lesions. And in our experience, many a times we took biopsy and performed ablation at the same time. Later in the biopsy, we found that it was just an incidentaloma. But anyway, we went ahead with the ablation. So if we think it may be malignant, we can go for ablation.
That's a burning question. I mean, so does the panel think it's a malignant adrenal nodule, or are we thinking it's a benign nodule?
Usually, SUV is, literature says 3.43 is the cutoff, sir, usually.
Yeah.
And if normal liver FDG uptake, SUV will call it as a standard uptake value, if we draw that region of interest, if it is more than 1.5 times of the liver uptake, we'll call it as a metastasis.
No, the adrenal nodule.
Yes, sir, adrenal nodule.
So the SUV was 2.8 to start with, and from what we thought 3 is the cutoff.
3.43, we have to check it the liver surface, liver FDG uptake. It should be more than liver, like 1.5 times of the liver uptake. So adrenal nodule called as metastasis.
Maybe for radiology, do you think an MRI would be more helpful to like sort of define it better?
I think diagnostic radiologists will be better able to answer it. But you said the size of the nodule is like 1 point?
Less than 1 centimeter.
Yeah,
so
1 centimeter.
It has been stable over the course of 9 months.
It is very difficult on imaging to characterize a 1 centimeter nodule. And based on the history of the patient, you will presume it to be malignant. But if you want to be sure, you take a biopsy. And if you are scared of drop metastasis, then you ablate it at the same time.
Yeah.
So,
sorry? It was not there to start with. And as in practical setting, we gave the test of time to see it, and things, the PUCA and all got elevated, and we got liver recurrences. So at this stage, after 6 cycles of immunotherapy, no response, what are the treatment options? Should we consider palliative versus the intent is, what is the intent, palliative or curative?
So in this scenario, the imaging remains overall stable even after 6 months. There is elevation of PVTT, that is okay. Symptomatically, he's doing fine. I would consider the response a stable response. I would tend to continue these treatment. One interesting thing is, although the liver lesions increased, there was no change in the adrenal nodule.
Yeah, it has
It
always
makes
been
me
static.
think again whether it is actually metastasis or not.
Correct.
Because over past 9 months, there was elevation of markers, the liver, multiple lesions have cropped up, but the adrenal remains same. So there is some discordance and all. Really, that implies that we need to sample that before conclude. Because if it's negative, then in this scenario, we might think about even transplant also.
Okay. This question is important from the point of counseling the family. At this stage, a 70 years male post-resection, 1 year recurrence not responding to immunotherapy. And what second line immunotherapy would be preferred?
At this juncture, I would tend to continue the same therapy because I do not see any obvious progression anywhere. So I tend to extract as long as possible. The thing is, even in oligoprogression, we tend to continue the immunotherapy partner, change the background. Suppose he's receiving bevacizumab, add cabozantinib to it. Because there is an ongoing phase 3 trial. Post-atezolizumab progression, they have randomized of continuing atezolizumab, add on a TKI. So what we see is immunotherapy responses tend to slow and durable. So in this scenario, I would continue the same protocol. In future, if there is radiological progression, I would think of continuing atezo with change of TKI.
Okay. So this patient also had a incisional hernia which was never complicated, but there was also always a pressuring point from the family to get it operated. And because of bevacizumab, we kept on postponing it. So we changed to cabozantinib at this stage. We started on 40 mg. He didn't tolerate it in view of palmoplantar erythema. So we changed the dose to 30 mg. Post 4 months, the PVTT reduced to 18 from 21 to 30. So we did a PET scan. There was complete metabolic resolution and decrease, not very significant decrease, but the metabolic resolution was complete, and the adrenal nodule was still stable. So should liver transplant be considered as a treatment option at this stage? We have the same adrenal nodule after 1.5 years of everything. And should liver transplant be considered? And if we are considering, should adrenal nodule be sampled at this stage?
Yes, sampled, if positive, ablated by either radiation and proceed for LT. That's what I.
So, Dr. Shanwaz, less than 1 centimeter left adrenal nodule, how easy it is to sample after all sort of adhesions? after
Yeah,
the primary surgery?
technically it is not difficult to, because adrenal stays at a space where there is no adjacent immediate threat, so it can be ablated. If we want a simultaneous biopsy, then I would suggest that we take a coaxial system to the adrenal. From that system we take a biopsy, and from the same system we ablate it, so that there is one single track, and when we are withdrawing the ablation electrode, we not only ablate the adrenal but the whole of the track to avoid any drop metastasis, because the patient may be a future liver transplant recipient.
So,
Yeah. So, the more controversial question about liver transplant, yes or no at this point, right? So I think, I'm assuming that adrenal nodule is a met. Although it would be very unlucky to have two different things going on in the same patient. So you have extrahepatic disease, and you finally got stability or really nice response after 4 months of immunotherapy, and you've just now taken out the extrahepatic disease. I think this could potentially go to liver transplant, but I think you'd need to wait for a little bit to just make sure that there's not more disease blossoming everywhere else.
Okay. So the family never actually was wishing for a liver transplant to start with. So Dr. Chennababu, retrospectively, can radiotherapy be given to the adrenal lesion when it was first detected at 3 months follow-up, at 6 months follow-up?
So at 6 months follow-up, the size was 1 centimeter. Less than 1 centimeter. At that time, okay, it was very, I would say, because of background, very huge liver lesion and with LVSI positivity, and may suspect but okay, unless until we have to prove it histopathologically or cytologically, we can't give SBRT directly. Otherwise, we have to observe the lesion size, okay, imaging characteristic features, okay, over a period of time, 3 to 6 months follow-up. Whether if it is increasing in size and changing tumor characteristics, then we can consider. And third option is the SBRT can be given along with the immunotherapy. That's after 6 cycles of atezobev in this scenario, because as one of the audience said that okay, along with the SBRT or TARE, so much of tumor necrosis will happen, and from that necrosis, tumor antigens will come into the picture, and it will add synchronizing effect with the immunotherapy. It has benefit. So after 6 cycles of immunotherapy, it's the ideal time, okay, to hit that adrenal lesion from it.
So if there is a requirement to sample, I think, as Dr. Shanwas said, we can do RFA or ablate it at the same time. That's more practical. And Dr. Shanti, how to access metabolic response on the PET scan? Is a change in SUV significant enough to tell it, or there has to be a certain cutoff below which it has to go?
There are 2 criteria. For post-chemotherapy and post-radiotherapy, we see M-persist criteria. And for immunotherapy, we call it the M-persist criteria, immunotherapy persist criteria, that is PET response evaluation for solid tumors. And only difference between this immunotherapy and post-chemo and radiotherapy, if there are new lesions in post-treatment, it is called as progressive disease in post-chemotherapy and radiotherapy. If immunotherapy, you can call it as a pseudo-progression. That is the thing. And now in this case, it is complete remission, complete metabolic response, we call it as.
Yeah, wanted to ask, is there any delta SUV which is important? Or is there just, SUV should go below 3 or 3.4, whatever?
It's complete metabolic response. There is background activity you have to check. Okay. If it is less than 1 or 1.5 like that.
Okay, thank you. So, any questions regarding this? So, the patient is still on cabozantinib. So, what would be the panel define as the next treatment option? Such a nice response to cabozantinib. The tumor markers completely disappeared, complete metabolic response. Can sampling the left adrenal nodule, if it's negative, transplant be given as a curative option?
Maybe we should see the persistence of response for possibly, as Sir told, 3 to 4 months, reimage. If the things tend to be same, then of course transplant to be considered.
So should patient be taken on the same cabozantinib for transplant? We continue it. Or do we again give a test of time and assess the response?
I mean, you want a little bit of washout period just to like see what's going on.
So what if in the washout period the markers rise again and the response?
Then you have your answer. You don't go.
Okay.
I mean, just to make the reason why we wanted to discuss this case was, I mean, when there were 6 cycles of immunotherapy, there's no response. Okay. I mean, there's nothing more we can do. I said, okay, let's try cabinative because we never used it before, and the family would be happy that they were also happy that we are doing something, and then they suddenly disappeared for 4 months, and they come back and there's a response. And we don't really know how to go ahead with this because now the family is saying, okay, it's, response is his only complaint now is the hand-foot syndrome because of cabinative. He actually looks very good.
His performance status is
definitely
very well for
looks better than most of us at 70. So we're thinking, should we transplant him? Now, the problem is the adrenal nodule, I don't know really, so it's a 1 centimeter adrenal nodule. How good are we at biopsying it? Should we just burn it and then wait for 3 months and then transplant instead of trying to biopsy? I mean, that's a question.
Sir, if you see the biology of the adrenal nodule, irrespective of response in the liver or the markers, it remains same.
Yes.
I seriously think whether it's related to HCC or not, or it's an incidental loma. Although in background of malignancy, the high chance it is there. So rather than directly ablating it, sampling is much more important in our scenario.
Okay. So again, that same retrospective question, when it first appeared, should we have sampled it? Immediately after resection, when it appeared at 6 months of stage, everything was normal. We wait.
We would have waited.
Okay, thank you. Thank you.
Yesterday, due to short of time, we postponed on pediatric session to today. We will take the talk today. For that, I would like to invite the chairpersons, Dr. Metu Srinivas Reddy, Star Liver Transplant Surgeon, Star Hospitals, Hyderabad, and Dr. Azrar Iqbal, pediatric gastroenterologist from KIMS Hospital, Hyderabad. I would like to invite the speaker of the session, Dr. Somashekar, pediatric hepatologist from Rainbow Hospital, Chennai, and he will be talking about biliary atresia. When is the right time to transplant? And Dr. Kirti Vasan, pediatric hepatologist from Rainbow, will also be chairing the session.
Thank you for the opportunity. I think we are shifting from a 70-year-old to problem of small children. So we all know that biliary atresia is quite common, occurs in 1 in 10,000 to 15,000 deliveries. It's a progressive fibro-obliterative disorder of intra and extrahepatic bile ducts. Generally, its onset is within the first 3 months of life. So what is the treatment for biliary atresia is usually Kasai port enterostomy, first described in Japan. But we need to remember one thing, KPE solves only the extrahepatic issue. So intrahepatic bile ducts paucity or absence is not addressed. Majority of these children after KPE develop ESLD and require liver transplantation in the future. So what are the indications for liver transplantation in a child with biliary atresia post-KPE or a missed child who has missed the procedure? Late diagnosis, failed Kasai, significant malnutrition, recurrent cholangitis, progressive portal hypertension, severe pruritus, hepatorenal syndrome, and HPS and POPH. In the right side, I have depicted what all the complications these children can have. So the native liver survival comes down as they grow older and older, and the rate of complications increases. It's a cumulative complication. It is not that one complication occurs after the other, can happen simultaneously. So what is the current paradigm of management? We have a jaundice infant. We hepatologist make sure that it is a conjugated jaundice and obstructive pattern, the liver biopsy. So pediatric surgeons do an intraoperative cholangiogram and proceed with hepatoportoenterostomy. If they remain anectric or if there is evidence of bile drainage, we just follow them up with supportive treatment. Few children present late, around 25 to 30%. In Indian scenario, almost 40% present late presentation. They have cirrhosis at presentation. These children are directly taken up for transplant. So after Kasai, there are a subset of patients who doesn't demonstrate bile drainage. They also need transplant. Whoever have had successful Kasai, as I depicted in the last slide, they fail subsequently and they need liver transplantation subsequently. So what is the likelihood of successful rates of Kasai? It varies from region to region. So it varies from 26% to 47% at 10 years when we look at the native liver survival. So it's very important to remember that jaundice clearance doesn't ensure transplant-free survival. These children can have other complications, which I mentioned in my first slide. So I have depicted the 40 years native liver survival in children who have undergone Kasai as children. It is around 20 to 25%. So we have a child here who has been diagnosed to have biliary atresia beyond 3 months or at 4 months. What do we do? So late diagnosis of biliary atresia, it is a definitive indication for liver transplantation. So the benefits of early Kasai have been beyond proven doubt, are well established. Late Kasai is vaguely defined as, more than 90 days, more than 100 days, more than 120 days, have very long-term low native liver survival rates. You can see in this graph, the green line is just dropping. Those are the children who went Kasai beyond 90 days. So KPE should be avoided in children with cirrhosis and ascites, as it can precipitate decompensation. It worsens the liver disease. This is our own experience. Group 3, beyond 90 days, we did Kasai. They all had very poor outcomes with the native liver survival less than 25% at 5 years of age. So what is the timing of Kasai when you have a child who has missed a KPE? So try to look at the literature. Probably around 6 months of age, weight around 5 to 6 kilos. That's what everybody has been practicing. And the results are comparable to LT for failed KCE, LT with failed Kasai portoenterostomy. So probably we would wait for the child to gain some weight, probably around 5 and around 6 months. And we need to complete the vaccinations also. I would wait around 6 to 7 months and then probably take this child for primary liver transplant. Then we have a subset of patients who group of patients who have early failed Kasai. So the natural history of BA plus failed Kasai is equal to that children of unrepaired BA. So 2-year LT-free survival, we can estimate by the bilirubin at 3 months post KCE. If the bilirubin is less than 2, their 2-year LT survival, 84% of these children will survive with the native liver. If it is more than 6, unlikely that they will survive with the native liver. So children who does not clear jaundice by 3 months KPE, evaluate them for early Kasai portoenterostomy, ideally by 6 to 9 months of age. So we have another subset of patients where we call them as medium failure group. So around 40%, 45% we have early failure, they fail within 1 year. So we usually transplant them, as I told earlier, around 7 to 8 months of age. So then we have medium-term failure, around 40%. So the indications are varied. It is just not only jaundice, I explained in the first slide. It can be cholangitis, it can be GI bleed. As they grow older and older, the other complications set in. So these children also would need a transplant, probably, around within 2 years of age, between 1 to 2 years of age. Then we have something called long-term failure, around 15% fail for various reasons, Most probably it is portal hypertension, GI bleed, and hypersplenism and ascites. So these children also need transplantation beyond 5 years of age. I won't be able to give exact numbers, how many percentage would need transplant at particular age after 5 years, because it depends on what complications they have. So then we have a subset of patients who will have failure to thrive. So they clear jaundice, still they can have failure to thrive. They can have jaundice and malabsorption and failure to thrive. So they develop this malnutrition despite their clear jaundice. So for post-KPE children with significant malnutrition, we consider liver transplantation in case of refractory failure to thrive with despite aggressive nutrition support. We usually, these are all our children who have had Kasai with jaundice, without jaundice. We put an NG tube down and then feed them, irrespective whether they have clear jaundice or not, and try to correct it. If they are refractory, around 6 to 8 weeks, we try exclusive, NG feed nutrition. If they don't recover or if they don't gain weight, we consider them for transplant. Another important indication is these children are prone to have metabolic bone disease. Some few children present with multiple fractures. That is another indication for liver transplantation. Another complication is bacterial cholangitis. At least around 50 to 80% of Kasai children experience one episode of bacterial cholangitis within first 2 years of life. The good the biliary drainage is, the lesser the cholangitis. As you can see in this graph, more than 3 annual cholangitis episodes independently predict the need of liver transplantation. So 25% of these children will have multiple episodes of cholangitis. When do we consider recurrent cholangitis despite aggressive antibiotic therapy? So these children, if they have cholangitis, they need antibiotic therapy for 4 to 6 weeks. Multi-resistant bacterial organisms, episodes of life-threatening sepsis, and severe impaired quality of life secondary to multiple hospital admissions. Portal hypertension, little bit of gray area. Many children develop progressive liver fibrosis and portal hypertension. Around 67% of the children with post-KPE, despite clearing jaundice. 90% will have varices when we do endoscopy on these children, and 30% of these children will have one episode of bleed. Although we don't practice surveillance endoscopy, there are a lot of non-invasive markers where we can detect portal hypertension, and portal hypertension is universal in all children who survive into adulthood. So when do we transplant them? Prepare the family for LT as soon as one sign of portal hypertension is clinically evident or endoscopically evident. If the child has high-grade varices or first episode of bleed, consider LT immediately. So this King's looked into, children who were survived with native liver beyond 16 years, how many of them had portal hypertension? Those who had portal hypertension needed liver transplantation within 4 to 5 years. So portal hypertension also independently predicts the need of LT even beyond 16 years of life. So pruritus, few subset of children, despite clearing jaundice or even with jaundice, they will have pruritus. So it can be significant enough to impair the quality of life for both patient and family, because parents have to scratch them whole night. So generally we manage them with UDCA, rifampicin and naltrexone. LT is considered when there is severe impaired quality of life secondary to pruritus. Child is not able to go to school because of pruritus and failure of medical management. 7% and 3.5% of post-KPE patients develop HPS and POPH. These are self-explanatory. These children need liver transplantation at the onset. So every child who comes for follow-up in the OPD should be screened by a pulse oximetry. If there are new onset symptoms, we need to do a bubble contrast echo. We may feel a bit of a surprise, but these children are prone to have hepatic malignancy also, around 1%, and it can occur as early as less than 2 years. What I have depicted is the data from King's. 5 children out of 387 biliary atresia had hepatocellular carcinomas, and 4 of them were less than 2 years. Elevated AFP or concerning lesion should be evaluated further. LT is indicated in absence of extrahepatic disease or gross vascular invasion, irrespective of the size and size of the lesion and number of the lesions. So I highlighted what complications can happen. Can we base our decision based on the PELD score? So there's a UNO's data. Patients who had PELD of more than 17, more than at least 15, had considerable survival benefit in the terms of life years gained from LT. There are drawbacks of using PELD score for children with biliary atresia. They can often tend to have normal, PELD scores because they have near normal albumin or INR. Weight measurement is not reliable, artificially elevated because of organomegaly. They have a lot of ascites. And PELD doesn't account for complications of biliary atresia like refractory ascites, variceal bleed, and cholangitis, especially older children where they present with these complications. So there is a nice study, they tried to look at, to determine the optimal timing for liver transplant for biliary atresia using a Markov model simulation test. They divided into 3 categories: PEL less than 15, PEL between 15 to 25 with or without one complication, and PEL more than 25 to less than 25 with one complication. So there were patient survival rates after 10 years were 84% and 75% in moderate liver disease and severe liver disease. So there is a benefit of transplanting these children when the PEL score is between 15 to 25. Probably they have survival advantage. So I kept on telling, these children will have complications, they need transplantation. Why don't we avoid transplantation and consider them all for, transplantation when they present to us further instead of doing a KPE? So what are the advantages of primary LT rather than a salvage LT? So it can eliminate a potentially possible futile intervention with a 40 to 50% chance of failure within first 2 years of life. And there are a lot of advances in pediatric liver transplantation. We can do a safe transplantation. And major procedure before complications, like before having portal hypertension, before having cholangitis, can we do it? Yes, it can be done. I'll discuss in a couple of slides. So what is the disadvantages? Higher incidence of vascular complications or large vessel syndrome in smaller infants. I would have recommended, as a pediatric hepatologist, I would have recommended liver transplantation for all children with biliary atresia, provided they were not being exposed to immunosuppression and there was no risk of PTLD. This prevents us from, recommending primary liver transplantation. We need to postpone as much as possible the possibility of LP. So what are the arguments for KPE first followed by liver transplant? That is salvage liver transplantation. KPE has less operative morbidity. I think everybody would agree. KPE may avoid the need of LT at least in around 15 to 20% in the long run. In case of sequential liver transplant, KPE provides us an opportunity for children to put on some weight, better, it will improve their nutritional profile, they will have more stable liver functions, and it gives us an opportunity to vaccinate all these children. So this is a study. Group A had KPE, Group A didn't have KPE. So you can see their weight, their PEL score, the hemoglobin, albumin were all better in children who underwent KPE compared to children who did not undergo KPE. And sequential therapy, especially in our setting, has economic benefits. Universal primary LT, it will likely to drive up healthcare costs. KPE first allows for the postponement, possible LT, financial preparedness for the family, but we have limited data. We need to look into this more carefully. There is social aspect, it allows patients and family to mentally prepare for life-changing LT. Prior KPE experience of a jaundice-free interval will elevate their mental status. Caregivers reported significantly higher lower Hamilton anxiety scores after KPE. So primary LT, there are challenges, small recipients, few more slides, I'll finish. Portal vein hyperplasia, there are associated anomalies. Earlier reports said there are higher risks of vascular complications and large size syndrome, as I mentioned earlier. This I've shown in the previous thing. The complications rates are comparable or the outcomes are comparable, primary or salvage LT. So when we look at a larger group, LT results were better in older children who had successful KPE than in infants who had derived no benefit from earlier surgery. So what do we need? We need to we need some guidelines which we can, or when we need some parameters which will tell us whether this KP is successful in this infant or not. I've told earlier, age at presentation 90 days, no KP, because each 1 day increases in the age at KP increases by 2%, that likelihood of transplant-free survival. If at presentation a child with biliary atresia has PELD score of 9, unlikely that the KP is going to benefit. Ascites, nodular liver at presentation, APRI, a surrogate marker of fibrosis, all correlated with clearance of jaundice. Syndromic variant of biliary atresia have uniformly poor prognosis. Liver histology, the more fibrosis, generally most of the KPE children would have had a biopsy prior to surgery. That's what we do. So if it is a severe fibrosis, severe cholestasis, severe lobular inflammation, unlikely that the KPE is successful. There are inflammatory markers. There are newer markers which I don't touch because we don't practice them in India. So there is a nice score called infant biliary atresia liver fibrosis score based on patient's blood parameters. If IBALF score is more than 5.27, probably this child is a potential candidate for primary LT rather than a salvage LT. So coming back, so KP plus sequential LT will delay the liver transplant, helps in weight gain, stabilizes the diseases. It is a less morbid and cheaper procedure. Potentially can avoid in LT in around 20% of the patients. Social acceptance, yes, it's questionable. Whereas a primary LT, it avoids extra surgery, avoids long-term complications after KPE, faster surgery, lesser blood loss, less reoperation, bowel and biliary complications and infections. So, and lastly, primary LT and salvage LT for early KPE failure have similar results. So we need to predict which child has got chance of early KPE failure and then decide. To summarize, KPE, SLT or PLT, age less than 90 days, definitely KPE followed by sequential, plus or minus sequential LT if needed. The gray zone is what do you do if the child has got high PELD score at presentation, low GGT has uniformly bad prognosis after Kasai, high APRI and syndromic, where we're going to do KPE or primary LT, that is a little difficult to decide. Primary LT, definitely if the age of presentation is more than 90 days. If the child has ascites, nodular liver at presentation, definitely we're going to go for primary LT. So it's to conclude this part of the topic, BA, sequential therapy versus primary LT, it's complementary. They're not competitive to each other. Decision should be guided by the patient's age, liver tests, and the expertise what we have. Probably we need an RCT, which may not be possible. So this is the last slide of my talk. To summarize, when do we transplant a child with biliary atresia? Late diagnosis of BA, primary LT around 5 to 6 months of age, when the child has got reasonable weight of 5 to 6 kilos. Failed Kasai, you have an early failure, we transplant them around 6 to 9 months of age. Midterm failure, 1 to 2. Long-term failure depends on onset of complications and what complications these children have. Portal hypertension, I would say if it is a mild, introduce the idea of liver transplantation to the parents, evaluate them for LT. Moderate to severe, consider urgent LT. Failure to thrive, as I explained, failure to gain weight or poor growth despite aggressive enteral nutrition for 6 to 8 weeks, an indication for liver transplantation. HPS and POPH, at the onset we have to do liver transplantation. HCC at diagnosis. Cholangitis, recurrent cholangitis, MDR organisms, poor quality of life. PELD score, yes, we can use, but we should need to remember that it has got pitfalls in children with biliary atresia. Best outcomes when the PELD score is between 15 to 25. Thank you.
Thank you, Dr. Somashekar. Any questions from the audience?
Good morning, Dr. Somashekar. Being a pediatric gastroenterologist, I think the problem that we are facing these days is this 90 days criteria. So many times we come across children who are preterm, where we are calculating the corrected gestational age and even crossing the limit of 90 and going up to 100 days. And then the other set where we get across children at 74 days, 84 days, where we know their liver biopsy is 4/6, We know the liver is firm on palpation, probably there is albumin is 2.9. So at this individual approach, when you see, because we know biopsy is also somewhere a sampling error. You know, it's just one part that we are taking. So do you feel that a diagnostic lab would have a role to say whether a surgeon wants to proceed with Kasai, or he just does a diagnostic lab and he feels that no, probably the child has more risk of decompensation post Kasai, and let's leave the child at that stage?
Yeah, I showed you a couple of features in the histology. If there is a lot of fibrosis, you know, I will go back to that slide if you want. So, see, if the fibrosis is very severe, 4/6, what you say, and if there is a lot of cholestasis and there are a lot of lobular inflammation in the biopsy, look at for all these three features. If all these three features are there, it is better avoided. And especially if the child is presenting late, around 80 days or 90 days, it is better avoided. That's what I would say. Because Kasai in a child who is already decompensating will make them prone to get more cholangitis and they decompensate fast.
So would you
there
just
is
go
no
by
benefit.
biopsy, or would you also go ahead with a diagnostic lab and then take a final decision with the family?
You have biopsy with you, you don't have to do a diagnostic lab. If you are still, you know, you have biopsy which is equivocal and you have a low albumin, then probably you can do, you know, open up and see.
Because
then,
refusing a Kasai less than 90s is also controversial.
Sorry?
Refusing a Kasai just based on biopsy and LFT will also be controversial less than 90 days.
Yeah, this is definitely a gray zone, but you have to put everything together and see. I mean, if you're really confused, probably yes. Many times we also have opened up, we have felt that the liver is cirrhotic. Even at 60 days, 66 days, we have abandoned the procedure.
Yes. That was my point. Thank you so much.
Any other question? Dr. Sonal?
My question really was about how successfully have you ever managed to get people to put on weight? Because we get a lot of these kids at 4 to 6 months who've had a Kasai, who are decompensated. And we try to build them up, so to speak, over 4 to 6 weeks. It's not been successful in our hands.
These children won't put on weight just with oral nutrition. They don't eat at all. You know, there is ascites, there is portal hypertensive gastropathy. Even if you give them, you know, they don't eat. The stomach capacity is limited. What they eat is very, very less. On top of all these things, parents have, you know, you should not give that, you should not give this. So generally what we do is, when the child with post-KP either waiting for an LT or they present with low weight, we put them on an NG feed. We educate, we admit them, we educate the parents for a couple of days in the ward and then send them home. What is the main worry for the parents is social acceptance, and what we are worried about NG feeding is aspiration. So many clinicians are against NG feeding because there is a risk of aspiration. So we always use litmus papers to check the gastric pH. So we have been successful in that model. Many children have put on weight. At least they have put on 1 kilo or at least 900 grams, so that they have some weight when we actually take them for LT. We have established some model like this.
Sure. I mean, I'd like to know, because we've been very unsuccessful there.
Yeah.
Because every time we try NGs, they put on some weight. After that, they get one episode of cholangitis. Then you lose ground immediately, you know.
That's very much true. We give them enteral nutrition for 6 to 8 weeks. They're not gaining. They're proceeding with complication. Then we have to just go ahead with the LT.
Yeah.
Nothing else can correct.
Correct. So I mean, we have a low threshold for going ahead very rapidly. So
absolutely.
Can I have? Yes. Are there any studies, I mean, a primary LT, like everybody goes for transplantation versus waiting for Kasai and proceed for transplantation? Are there any random control studies like that doing primary, I mean, every patient going for a liver transplantation?
No, there are no RCTs, but I don't think ethically somebody would allow you to do an RCT if a child comes at 60 days and you say that I will take this child for primary liver transplant. Nobody would agree, because it is not possible. That's what I told, you know, it's a need of hour, but it is not possible to do an RCT. That's what I believe. I don't know what. Can we do an RCT?
Okay. Can I also answer a question if I'm chairperson?
Yeah, why not?
I think, see, just an answer to both the questions. I think Kasai is very effective in giving a lot of time for parents to actually think about transplantation. You know, a newborn child, 30 days, 50 days, you're talking about transplantation. It's very difficult to actually convince the parents, more actually the grandparents, because they'll say, it's not worth the effort. And a Kasai is very useful for that. And in terms of doing a biopsy and then deciding, personally, I don't think there's any point in doing a biopsy and then deciding whether you want to do a Kasai or not. Before 90 days, unless there is obvious features of chronic liver disease, I would just do a small laparotomy, take a biopsy, if there is, and try and do a Kasai, as long as there's no ascites and the liver is not hard. Because whatever it does, even if it delays the transplant by a few months also, that actually works in favor of the child and the parents. And that's my opinion. I don't know if anybody has any other ideas.
Yeah, fair enough, because you do the biopsy, you need a good interpreter.
Yeah.
That is always there, who's used to seeing this biliary atresia biopsies.
Yeah, but I mean, I would rather believe my eyes than the biopsy report. So, okay, if that's it, then thank you. Thank you.
Yeah, thank you.
I think, as usual, we are running a bit late. We're going to have a little bit of a flip around of the topic. So the next session is controversies and challenges. And it will be Dr. Sudhindran, Professor Sudhindran talking about planning late in time, and then Professor Madhusudan will be talking about hepatic venous thrombosis in the setting of HCC. I'd like to request the chairpersons, Professor Vora, Chief Anesthetist, Medanta Hospital. Is he there? Dr. Abdeep Chowdhury is Head of Transplantation at BLK and President-elect, LTSI. Dr. Nishant, he's Consultant HPP Transplant Surgeon at Medanta. And Dr. Ajit Mishra. Yeah, ILS Hospital, Raipur. Thank you. Where is Tom and Fanny? There's nobody here. Okay, that's fine. Can you introduce yourself?
For the next talk on the planning a late retransplant, I would like to invite Professor Dr. Sudhindran, Chief Transplant Surgeon, Amrita Hospital, Kochi.
Thank you very much indeed, Srini. I think a lot of interesting practical point discussions going on in this session. Thank you very much. So, late transplant. I think one of the first question is what is early versus late. There's no clear-cut definition on that, but then generally most consider more than 30 days after the primary transplant as a late transplant. Early retransplant, I think one of the things is it may be technically easier because a lot of the dissection is done and it hasn't not much of adhesions that happened. But then interestingly, the mortality is actually higher when you have an early retransplant. It's predominantly because of the causes that differ between the two. Early retransplant, I think majority are for hepatic artery thrombosis, but then now in the living donor scenario, because of lack of cadaveric donors, a lot of thrombolysis and stenting has been done. So that number has also come down a little bit. Port vein thrombus, I think often difficult to salvage. Same hepatic venous outflow obstruction. And then primary non-function or severe dysfunction is rare in live donors, but still it does occasionally, it does happen. Compared to that late retransplant, most of them are, I think, are probably because of the initial biliary problems, that is there in live donor liver transplantation, and then multiple cholangitis and secondary biliary cirrhosis. That's one of the common causes. Secondly, I think rejection. So once you go on to steroid-resistant rejection, salvageability becomes very limited, and then you probably end up with a transplantation. And chronic rejection, again, because of poor compliance, added on by recidivism, that can be a problem, and recurrence of primary disease. So I think preparation, unlike an early retransplantation, we have a little bit more time for a detailed evaluation. So cross-sectional imaging, of course, is a must, because usually we multi-phase CT. Occasionally, if they have renal problem, we may require an MRI, because we need to see where the hepatic artery is patent up to, where is the portal vein, how are the hepatic veins and IVC, etc. So any reversible causes like recurrent HBV, particularly if you go back and look at the core antibody of the donor, because sometimes that may be missed, and that could have caused the hepatitis B in the recipient, and often that's not looked into. Likewise, CMV and HCV, etc. should be addressed. And family counseling is probably the most crucial, because it could possibly be a third family member, because first two are going to be related, and then there's maybe another family member that is coming into it. So they need to be aware that there's going to be a much higher risk than the primary surgery, that they have to be cognizant of the much more higher blood transfusion load that may be required, prolonged ICU stay, perhaps need for dialysis, and of course, the costs are going to be so much more. So, and I think oftentimes the reason why retransplant doesn't occur is probably because of these costs that come in the picture in India. So coming to the technical aspects, I think there are 4 situations. So first is an LDLT, which is followed by a second LDLT, which is perhaps the commonest in areas where living donor liver transplant is predominant, like in India or Japan, Korea, etc. But then if there's DDLT available, it will be a second DDLT. Or it could be a first DDLT and then followed by a second DDLT, or rarely a second LDLT. And this situation, that is first DDLT, which is followed by a second LDLT, is the most difficult combination. So this is because when you have a DDLT, your vessels that we take is never as high as what we do in the living donor liver transplantation. So because we are a little bit more comfortable taking it lower down. And therefore, most likely, they all require conduits, particularly for the artery and the portal vein, and even the IVC. How was the original DDLT done? Was it a caval resection, or what is a piggyback? That whole thing makes it a lot more difficult. And if you look at the Japanese and the Koreans, they will say that never ever go for an LDLT after DDLT. It's always should be a DDLT after that. But then sometimes you don't have that luxury. We may have to go with an LDLT itself. So the graft liver, the donor, I think ideally go for a normal anatomy, because we don't want to end up with a type 3 portal vein and another additional reconstruction, because there will be another layer of complexity. Same with hepatic artery. We don't want 2 hepatic arteries. Ideally, another single duct, because one more biliary complications, which we know is much more common, we have multiple ducts. And always keep conduits ready, arterial and venous. Somehow, look at, because now there are cadaveric donors happening somewhere in the country, we are always able to get it. So make sure that we get that conduits ready, usually commonly iliac vein or iliac artery, or sometimes even superior mesenteric artery is a very good conduit to be used for arteries. Do expect difficulty. Read the operation notes, where was the previous things done, was the gastroduodenal liver divided, all those things. And the explant hepatectomy will probably be the most difficult because there's going to be a lot of vascularizations. The anatomy will be distorted because the previous LDLT. It's going to be a lot of hypertrophy. A lot of new collaterals will come in the area. And because of prolonged immunosuppression, the tissues are likely to be very weak and likely to be torn. So bowel injury is again, much more common. And you have to avoid bowel injury as much as possible because even the smallest of injury, the risk of infections post-transplant is very high. If you look at UK, and in Cambridge, you go for a retransplant, a venous bypass will be standard. They don't even bother with anything else. They'll go for it from the beginning. But then in India, we are never used to venous bypass. But perhaps this is one area where if you're anticipating a difficult thing, you can get help from the cardiac team and plan for a venous bypass if required. When you do the mobilization, I think almost always we go for the previous incision, and the colon is most often adherent to the parietal wall. And in a live donor transplantation, the stomach will be adherent to the cut surface if it's the right lobe. So mobilizing, I think you somehow get to the surface of the liver, and then you start from the top to the bottom of the liver, and then slowly mobilize that. So place the it'll be never possible to put the retractors early on. So slowly as you mobilize, place your retractors, slowly retract again, mobilize further. So take your time with that. And again, as we said, avoid bowel injury. So at the hilum, dense adhesions to the omentum and bowel is very, very common. So it's often easier to come from the right to left because you can access the foramen of Winslow and then slowly get to it. Stay away from the infracolic adhesions as much as possible. And go for the hilar dissection again as high as possible, very close to the liver, because you need to get as much vessels as possible for your implant later on. Even the bile duct, I think it's not a must that we have to go for a Rowan heparogenostomy. We can do duct to duct, and if possible, I would prefer to go for that. So duct as well, try to preserve it as a vascularized duct as high as possible. If the previous one was a left lobe, it will be stuck to the spleen. So there, dissecting away from the spleen can lead to damage to the spleen, pancreas, etc. So try to leave a sliver of liver tissue on the spleen rather than go between the liver and the spleen completely. So this will avoid splenic injury. You can use vessel sealers or whatever to dissect, leave that piece of liver tissue there so that there's no damage to the spleen or pancreas. Now, hepatic veins and IVC, again, usually that may not be as difficult unless there were previous inferior hepatic vein anastomosis. In that case, again, that dissection will be difficult. Or if the first was a DDLT where there's a complete caval resection was done. So that also will be difficult. So at that particular point, it may be useful to go for a portocaval shunt because that will actually reduce the size of the liver and give a lot more mobility to lift the liver up. But then, of course, you may lose a length of portal vein for the later anastomosis. So divide the RHV and MHV onto the liver surface so that proximal to the suture away from the cava, and then take the sutures off for the anastomosis. Otherwise, you may end up being short on the IVC. Again, at this point, it may be useful to dissect the diaphragm quite high because in case you need to clamp on the suprahepatic cava. So that dissection also may be required. After explant, make sure that we get hemostasis on the raw surface. We have a lot of raw surface because there may be coagulopathy later on. So it's very crucial to get hemostasis after the explantation. And then we prepare the hepatic artery. Sometimes we have to divide the gastroduodenal artery to get the adequate length. Again, portal vein preparation. If the portal vein is thrombosed, you may have to go to the superior mesenteric vein. Rarely, if it's a mesenteric vein is gone, and there's a lot of shunts to the renal vein, portal anastomas may be an option. So all this has to be considered. And again, conduits has to be prepared well. Rarely, if there's no conduit available, I think you could go for the Dacron or PTV as well in dire situations. Bile duct, although most centers advise HJ, I think duct-to-duct anastomosis, if possible, would be better. Post-operatively, anticipate again a prolonged ICU period, ventilation. If it's an early transplantation, this is definitely required because they may be already in encephalopathy, and they may be septic, etc. In such cases, maybe early tracheostomy may give better respiratory control and lower respiratory infections. Renal replacement therapy, if required, mostly go for CRRT. SLED is another option. TPN may be required because by the time they get back, normal diet also may be prolonged. Immunosuppression, because the risk of sepsis, we can keep it on the lower side, probably low-dose calcium inhibitor, low-dose steroids, perhaps basiliximab, especially if there's renal impairment. We normally give routine CMV and PCV prophylaxis in such cases. There's a high propensity for fungal infection, so you anticipate preemptive fungal treatment, things like beta-glucan and galactomannan from the bowel, etc., can be considered early for early diagnosis, because once the actual invasive fungal infection occurs, then you're losing. So I think this series from Subhash Gupta's team, where they did 29 patients out of whatever, it made up about 0.81% of their total transplants, which is actually much lesser than what will be reported in the West. Predominantly for two reasons. One is I think we just don't have the cadaver options for retransplantation. And secondly, the financial issues and the social problems. So I think because of that, the number of retransplant that we do amongst the one that is actually required is much, much less than what is there. In this particular series, out of the 29, they had a 30-day mortality of 27%, which is not bad. And they found the late retransplant had a significantly lower mortality, 16.6 versus 35% for early transplant. This is because early transplant, although it's technically easier, the patients are inherently bad because they would be septic and they would have a prolonged first stay itself. And that's the reason why the mortality is higher. And from multiple papers, the predictors of mortality, recipient age, above 50 years, even donor age also is predictive. Higher MEL score, recurrent sepsis, particularly just close to the time of retransplantation. So always, if you're planning a late retransplant, make sure that the patient is not septic at all. Secondary biliary cirrhosis, again, is another area where multiple recurrent cholangitis would have occurred, and the liver that we take out is full of infection. So that is a problem. And of course, technical difficulty where there's been massive blood loss. That is again another predictor of mortality. So I think at the end of the day, retransplant is definitely a viable option. I think we don't have to shy away from it. But then we must know that it is a much more difficult proposition than a primary surgery. So selection is definitely crucial, both the recipient and the donor. If possible, go for DDLT. And family counseling, of course, as in primary, but is very, very crucial. Thank you.
Any questions from the house?
Sir, nice talk. Late retransplantation, not early retransplant, late retransplant. The European study says that one is technical difficulty, that's you have clearly mentioned. But they also mentioned that the immunological changes are more because pre-existing antibody formation of previous transplant. They recommended, one of the European Journal of Gastroenterology, they says that they always use induction basiliximab or ATG. I don't know, we haven't done. So what's your Indian scenario? Because we know in Indian patients, whenever we use ATG and basiliximab, infection rate is very high. But in late retransplant, donor-specific antibody screening will you do in such patients? Like kidney transplant, where do you do LCM cross-matching, particularly in a late retransplant?
So with the literature that I looked at, none of this was mentioned. Of course, in kidney transplant, what you said is absolutely true. They will go for an ATG induction. But in the liver situation, particularly in Indian patients, I think I will be extremely wary to go with an ATG. Basiliximab is okay, but then as an immunosuppressant itself, I don't know how useful it is. So I will not go into ATG. I think I'm really scared of it because the risk of infection is very, very high. As it is, these patients are going to be sick, malnourished patients, and recurrent cholangitis, etc. So I will not. Basiliximab, definitely, I think that's probably good. But now the cost is so much more. It's 1.8 lakhs for 2 doses of basiliximab.
Yeah.
So, but I think that may be a safe option, I think.
Thank you.
So my question is actually, would you prefer a patient with low MELD and high Rosen score on background of liver
High
abscess?
what score?
High Rosen score.
Okay.
Yeah.
On a background of?
For a DDLT. With a background etiology of multiple liver abscess because of HAT.
Yeah, DDLT is definitely better. There's no doubt about that in any which way you go. But you mean it's a marginal liver, you mean?
Yes.
Yeah. Good question. I think it's still prefer to go for a DDLT, I think.
So I'm actually glad we are talking about retransplant, and that's a reality. If you look at the UNOS data, so 9% of the patients would be relisted for transplant. And the kind of numbers which we are doing in this country, we'll see more and more retransplants happening, and that is something, a reality which should go to every physician who's actually treating liver patients, that it is not just liver transplant, primary liver transplant. 10% of the patients might require a retransplant as well, and these are definite challenges. And in terms of Dr. Madhu, that article basically mentions about the graft failure because of AMR or steroid-resistant rejections. For other viral-related or other reasons of graft failure, it is not mandatory to do that. That was a suggestion on that paper. And secondly, in terms of early and late, there are various papers talking about different timelines. Like the Japanese multi-center survey we looked at last year, they divided the transplant period within first year and after 1 year. And they found out there is a significant difference in survival. And more so when you deep dive into that, most of the loss of lives are happening because delay in doing transplant. Particularly an example which was taken up, early allograft dysfunction. The trial of doing medical management goes so long that by the time you do transplant, as per that article, the mortality was 100% in transplants done for EAD. So we have to look at, so retransplant is a reality. Earlier it should be done. I mean, when we know it is graft failure, like we are talking about the MELD does not work that well in retransplant, but then if we know it's a graft failure, earlier if it is done, you can get actually the results similar to a primary transplant. That is also published. There's an article which last year it came out in December, 25 cases, close to 95% long-term survival after retransplant, which is as good as a primary transplant. So important is timely doing it, accepting it. Most of the problem what we face is, as sir has rightly pointed out, third donor, family to understand, and that delays the overall process. The patient starts to go into sepsis and the multiple problems are happening. That is what is causing main loss of life rather than the other reasons.
I couldn't agree more with what you said, all the points you said. Number one is, I think, because we're young in terms of transplantation, the last 10 years, so we're going to see more and more transplantation. And I think really we should consider early, so rather than, because we tend to wait and wait and wait and wait till the patient gets really sick. So if you think, it's going to happen, I think we should do it early. And this thing about rejection, retransplant rejection, steroids rejection, the problem is they would already have had ATG. So, and then, you can't give ATG again, so it'll have to be ALG or something else. And the patient is, will be really immunosuppressed at the time that we're going for transplantation for rejection. So that's a really difficult thing for us to do.
That's exactly what I was going to say. Especially when we are doing a retransplant, we tend to give them low immunosuppression, like you said. But if you are looking at, like say in LDLT, how many times do we see PNF? Primary non-function mostly. Rare, yeah. If there is no surgical issue, then we are looking at AMRs also, correct, which has recently come up, and they're saying that probably that is the reason. So if you're doing PNFs, retransplant, or chronic rejections where we are not sure, like Abhidip said, that it could be antibody-mediated rejections, which are not so well evaluated in terms of immunological aspects in our country mostly. So I would think that we should look at donor-specific antibodies in these patients, when we are doing retransplant. That specifically will help us to understand the reasons why there is a graft failure, and also to look at the post-op immunosuppression in these patients if need to be changed accordingly. Thank you.
So donor-specific antibody, yes, you're absolutely correct. But then again, it's not like it's absolutely proven, because patients with no donor-specific antibody do have rejection, and vice versa also. So, but yes, you must definitely look.
That would give us a roadmap to see where we are going, especially in these early cases of PNF. Yes. Thank you.
And just to add for that comment about late rejection, we generally get with longer survival, mostly they are graft failures rather than, and some recidivism. And we have never used basiliximab or ATG as induction.
Yeah, I think in your paper,
you just go ahead and do it.
Sir,
I mean, like you said, in the retransplant, the need for grafts and venous conduit, all that would be required. And DDLT, you have the advantage that you have fresh vascular grafts available. Is there any clear-cut data showing that within 48 hours, freshly used vascular grafts are better than cryopreserved grafts?
Yeah, definitely. I think, yeah, definitely, because cryopreserved grafts, two issues. One is they also have arterial grafts, the risk of aneurysm formation is actually higher. And I think infection also is slightly higher compared to freshly used things. So that is recommended compared to cryopreserved grafts.
And sir, overall in the literature, what a little bit I'd gone through, it says that LDLT is the general preferred thing in retransplant. I mean,
No,
because the donor factors can be controlled, young donor, and complex surgery in the elective scenario. So what are your thoughts on that?
I mean, of course, the quality of graft will be better that way, but then technically it will be difficult. So the Japanese and the Koreans in their articles say, do not do LDLT after as a retransplantation. Okay. So particularly the first one was a DDLT, just do not think about it. DDLT, I think if it's a reasonable graft, definitely I think you can wait for that.
Just to add to that, if you look at the data, the outcomes after re-LDLT or re-DDLT, the survival is same. Exactly, but as sir has rightly pointed out, if someone has got a DDLT done before and you are doing a LDLT after that, Assan's paper in 2017 actually said the same thing, that is something should be contraindicated. But then as the experience gained, more and more centers started doing it. So it can be done, but first DDLT, second preferably should be DDLT. But if you talk about retransplant in toto, where primary is either LDLT or DDLT and secondary is LDLT or DDLT, the survival outcomes are same. Statistically, there is no difference.
Thank you.
Practically speaking, getting a DDLT in time for a second transplant in our country, it's I don't know,
yeah,
it's not
possible.
And we are stuck with LDLT. So, most of the times, patients wait for. It's easier to convince them for a re-DDLT, for a second DDLT. They'll be ready to, but if you say one more donor in your family, then it's a problem.
Correct.
And we'll never get the ideal second LDLT donor, because the ideal donor would have been used for the first transplant. So there's always a problem there also.
Yeah, I mean, these are the very reasons why, retransplants just don't happen as common as it should.
Well, thank you. I mean, actually, you talked exactly what we hoped for.
Thank you so
much. A lot
much.
of practical tips and
thank you.
Thank you.
Thank you.
Thank you, sir, for highlighting the challenges involved in the retransplantation. It is difficult both for the family and for the surgeon. Next in controversy today is hepatic vein tumor thrombosis. Yesterday in Prashant Bongushar's talk, he said hepatic vein tumor thrombosis is close to a systemic disease. But when we have a patient right in front of us, it is very difficult to treat. To talk about that, I invite Dr. Madhusoodan, HOD and liver transplant surgeon at Osmania. We'll talk on options for HCC with hepatic vein or caval tumor thrombosis.
Good morning, chairpersons, senior colleagues. And first of all, I will be thankful to Srinivas Reddy for giving this opportunity. This is definitely a total controversial topic. Basically, there are much described about BCLC advanced liver cancer, where it included two groups. One is extrahepatic disease, another is major vascular invasion, MVI. But majority of the talks are concentrated on a portal venous tumor thrombosis. There are very few literature about hepatic venous tumor thrombosis or IVC tumor thrombosis. So even if you take TACE or immunotherapy, or if you take
tear, whatever the multimodality treatment, they are all generally concentrated on a HCC with a major vascular inversion. So there are a lot of club between portal vein tumor thrombosis versus HCC. And if you do in subgroup analysis also, so there is a recent meta-analysis. Everybody is saying that systemic immunotherapy, which is totally game changer for HCC with the advanced disease. But if you see at major vascular inversion, there are clearly dropping of survival rate. So this Japanese cancers group, so they first tried like portal venous tumor thrombosis, PVTT 1 and 2, that is sectoral branch and segmental branch portal venous tumor thrombosis. They tried, depending upon the pre-existing liver function, some cases they did it as a multimodality treatment, resection, or some cases did a transplant. They given a good results, but they never recommend PVTT 3 and 4, that like major portal venous tumor thrombosis. Like that scenario, there is Kokuda and Professor Chen. These are the two people predominantly did extensive study on what is happening. So they have classified it. So HCC with hepatic venous tumor thrombosis. So I look at into the specific, some of the landmark papers, meta-analysis, systematic reviews. So only concentrating on hepatic venous tumor thrombosis or IVC tumor thrombosis. So what is happening these patients? What is the natural history about these patients? Average survival is 6 months in these patients. So the 5-year survival is hardly less than 4% in such patients. So there are maybe coexist with hepatic venous tumor thrombosis with portal venous tumor thrombosis. There are lot RCT trials starting from sorafenib, lenvatinib. So IM BRAVE, that is a landmark trial for immunosuppression. They all say as a common group, HCC, Barcelona, stage C, that patient, which is a heterogeneous group, which also have a extrahepatic disease, it also have a major vascular disease, never subgroup analysis about hepatic venous tumor thrombosis. So if you look at that way, sorafenib group is 10 months survival benefit, whereas non-doing any treatment is 6 months. If you add a lenvatinib, it's giving a 13 months. If you add a Atezo with bevacizumab, that is landmark trial published in NEJM, they says 19.2 months. Whereas if you see same group, if you see, you have a point. I don't know this point. If you see, sorry. If you see this IM BRAVE trial, the overall survival 19.2 months, whereas if you have done a subgroup analysis in that group with the major vascular inversion, it is falling into the 7.6 months only. So you cannot say that immunotherapy is a game changer for such cases. Same way, even if you use a systemic therapy like lenvatinib and sorafenib also, whereas a common group 13.6 months, when you make a subgroup analysis for a venous thrombosis, it's falling significantly. So as you know, BCLC, okay, this way. Yeah, this is after 2022 because they said that systemic immunotherapy is the only treatment of choice. Never mentioned about surgery for such cases. So the main controversy, East versus West. West believes BCLC and East believes in a different way. The reason is etiology and presentation of our cases are totally different. West predominantly cirrhotic background and usually HCC diffuse multiple lesions, whereas East we see not only Indian patients, we see even Chinese, Japanese, Koreans also see that less severe cirrhosis, HCC with the bigger lesions. Last World Congress, IHPBA, in South Africa, Cape Town also, they have presented African way of presentation. They say that big liver tumors of HCC in the normal liver background. The reason they express is hepatitis B endemic in this age. So you know hepatitis B sometimes causes de novo HCC without causing a liver disease. So that is why the Japanese says that treatment has to be individualized. There are some group of patients, surgery will give us a good results. So they have made a consensus meeting in 2023. They says that borderline resectable groups like PVV, portal venous tumor thrombosis 1 and 2, hepatic venous thrombosis, not IVC tumor thrombosis. These are the groups in selected patients as a multidisciplinary, not to saying that it's only treatment option, because they say that by removing obstruction, if it is a IVC obstruction, Budd-Chiari syndrome, you can prevent. So that next immunotherapy or next tear, it can facilitate. So that's why surgery makes, as a multidisciplinary option, it's a good option. So as you know, definitely, tumor with a major vascular invasion is biologically aggressive. So why? What is the importance of hepatic venous tumor thrombosis in HCCs? It sometimes causes acute Budd-Chiari syndrome. It sometimes thrombus dislodges, causes right heart failure and thromboembolism, and it increases intrapulmonary metastasis. What is the incidence? They said isolated hepatic venous thrombosis is 3.7, whereas combined HVTT with portal vein thrombosis is 9.7. Isolated only portal vein is 26.9. So when you want to compare any treatment between one treatment to another, you always to make it like apple to apple, oranges to oranges. So for that, you need staging of HCC. Some patients comparing with IVC tumor thrombosis with hepatic venous tumor thrombosis treated by a TACE or TACE, you cannot, because they are different grades. So that's why when you want to compare, you need a proper staging system. So that is why this Japanese group, Cocoon, who is pioneered in that, they made it like HVVT 1 and 2, they predominantly confined to the hepatic veins, and when it is extending into the IVC, it is 3. Same way, Professor Chen from China, Hong Kong group, he is also differently classified it. And survival rate also he has shown, VV1, it is a 5-year survival. So there are, I look at it, not only Chen and Kokudo, is there anybody did it surgical resection for such tumors? There are studies are there. So what are the other treatment options? Resections, TACE, hepatic arterial infusion chemotherapy, radiotherapy, and systemic therapy. So what is the TACE versus hepatectomy? I look it into that. So overall, equally gives the same median overall survival, but TACE with, it is giving a surgery gives a better survival first 1 and 3 years, but when you look at into the 5 years, it is equally giving the same results. So there are some of the things, radiotherapy, because we have experience with the portal venous tumor thrombus, external beam radiotherapy, 3-dimensional or 4D confocal radiation, with decreasing the venous thrombosis, particularly portal venous tumor thrombosis. Some of the case reports were there following that downstaging and waiting for a biological stage. If stable disease, they did it, went on for a transplant. Is it can be done in a HVTT or IVC-TT. So some of the people, they first lipid oil-based TACE followed by radiotherapy. The tumor decreased, but overall survival is 16 months only. So same thing, outcome of resection with radiotherapy also. So there are landmark trials, it's going on, starting from sorafenib to lenvatinib, bevacizumab, like that. So immunotherapy, if you look at into this, just now I told, the landmark trial, NEGM says overall 13.5, but if you look at it, major vascular invasion is only 16.1. So then meta-analysis of immunotherapy says that patient with the immune check inhibitors, if you use as a sole therapy with a major vascular invasion, there is a significant failure of rate. So always add a combination therapy like radiotherapy with immunotherapy in such groups. So this is our Usmania experience. 3 patients HCC with hepatic venous tumor thrombosis. We did one ALPS, One is central hepatectomy, one we did a living donor liver transplant. The living donor liver transplant fellow was hepatitis C background with a tumor thrombus in the right hepatic vein. We first not given any option of transplant. We given a TACE with the EBRT. The tumor in the right hepatic vein disappeared. Then after 3 months, significant decrease of AFP, patient went on requesting for a transplant. Brother donated, but unfortunately after 2.5 months, 2 years after 3 months, we developed recurrence first in the neck, then followed by in the liver. So we have done in 4 cases, transplant oncology principles, that is in situ hypothermia with right atrial and IVC tumor thrombectomy. I will show you some of the cases. These are HCC central lobe we have done. If you PET also shows IVC tumor thrombosis. So this is the case HCC with hepatitis C virus. We have done transplant, but we have not got a good survival benefit, only 2 years, 3 months. So this is the case we large HCC with right tumor thrombosis. So we have done so all procedure, initial stage 1, we did it laparoscopic, right portal vein tumor. So right portal vein ligation followed by partition. Then second stage we removed in a large HCC also. So this is the one case. This is I have presented in a Geneva, ILTS. So this is the case of hepatitis B background patient with left lobe HCC. So what we have done is this patient was planning for a radiotherapy, suddenly developed severe chest pain without MI. Then right 2D echo was showing a right atrial tumor thrombus. So such cases previously I look at in the literature, they used to do sternotomy. We have avoided sternotomy. We divided the diaphragm transpericardially. So just another 2 minutes. So after parenchymal partition, we always apply IVC clamp in the intrapericardial portion of IVC so that it will prevent your thrombus letting into the systemic circulation and patient may die of on-table thromboembolism. That's why we keep it that way. And we always use transesophageal echo. We first removed the hepatic venous outflow obstruction by removing a tumor thrombectomy with the use of total vascular exclusion. If you want to use a total vascular exclusion, you can use up to 60 minutes only. So some of the patient may needs more time. In such scenario, we have used in situ hypothermia techniques. So in middle hepatic vein, we have reconstructed because that portion of MHV was involved by the tumor. So that patient was lived almost 3.5 years. So then he succumbed. So I told you, total vascular exclusion, not possible in all cases, 10 to 20% hemodynamic instability, splanchnic congestion. In such scenario, we have used just 2 minutes slide. So we have used in situ hypothermia anti-CETA method. So what we do is, when you apply a total vascular exclusion, because patient may not tolerate hemodynamical stability, so we have used veno-venous bypass and also mesenteric venous decompression by IMV cannulation. And we have used remnant liver cooling with the UW solutions. So this is the 11 years boy with the large HCC. In spite of receiving chemotherapy, he presented with a Budd-Chiari syndrome. You can see that abdominal wall, collaterals, all these were there. So patient was progressively deteriorating. We are forced to do it. So we have done a veno-venous bypass setting by femoral line and IVC, and also splanchnic decompression with the IME cannulation. Look at that. Liver is congested, totally outflow obstruction is there. So what we have done is right extended apopectomy with the cava resection. During meantime, because it is taking a parenchymal transection more than 60 minutes, we have used in situ hypothermia of the left portal vein by using a UW solution with continuous cooling. So most important thing is when you use in situ hypothermia, always disconnect all collaterals to the IVC, otherwise your UW solution will have a high potassium, may go into the systemic circulation, patient will die of cardiac arrest. So that is important thing when you use in situ hypothermia. So we have applied a portal vein clamp, and distal to that we use a portal vein perfusion cannula. Through that we have used UW solutions. We already ligated right portal vein, so fluid will be preferentially go to the left lateral segment, that is future liver remnant. Then we have used anticitum because the tumor thrombus is occupying dam into the middle and left as well as right. So by doing anticitum, flipping off, you will know clearly where it is tumor. Sometimes you may use it Fogarty also for embolectomy, such cases. So then traditionally we have done a liver splitting like XC2 splitting of the liver. Remove the tumor. Then we have used the PTFE ring-coated graft for cava replacement, and left hepatic vein is re-implanted into the PTFE graft. So this is the transplant oncology, extension of liver transplant principle using for previously unresectable tumors locating at the hepatic veins and cava junction can be resectable by extending a liver transplant principles. So this is the method we always follow. Intrapericardial portion of IVC exposure without doing a sternotomy decreases lot morbidity. So the one slide. So if everything is reasonable, you can resect, then what is the problem? Because as you know, any tumor, ABC, anatomy, major hepatectomy, biology, so aggressive disease. So that's why, is there any way, what is the problem with the resection of these cases are, they are all suffering with the recurrence rate is very high because of vascular invasion. Is there any way to decrease the recurrence rate? There is IM-BRAVE study. Initially 150 was the systemic therapy. Now they have started IM-BRAVE 50 study, which is for adjuvant therapy. Following a resections, can you add adjuvant systemic therapy to see that any recurrence-free survival benefit? They have used more than 5 centimeter lesion or multiple lesions or macrovascular lesion invasion. Such cases, they have controlled versus systemic immunotherapy, atezolizumab with bevacizumab. They have shown that there is some survival benefit. There are some people, LENS trial, initially unresectable tumors, making a downstaging by giving a lenvatinib and downstaging and going for surgery. There is a randomized trial is also going, neoadjuvant, such cases, HCC with the tumor thrombosis in IVC and hepatic veins or portal vein thrombosis. Instead of doing a surgery, give a neoadjuvant in the form of atezolizumab, bevacizumab and good. So this is ongoing trial, results were not suppressed. Thank you. So always remember, biology is the king.
Thank you, Dr. Madhu, for that excellent talk. Any questions from the audience or comments?
Thank you, Dr. Madhu. I think it's beautiful videos actually. And I think what you say is right. Nothing can beat good surgery. You know, if you can take the tumor out safely, there's nothing that's much better than any immunotherapy or whatever we can throw the patient on. I think one point is about the role of adjuvant loco-regional therapy after this kind of resections. Now there's a lot of data from the Chinese papers where if you're doing a major resection for this kind of tumors, you do an adjuvant TACE for the remnant liver, and that's supposed to reduce the risk of recurrence a lot actually.
Yeah, that's actually basically our Osmania patients are socioeconomically very low, not offered of immunotherapy. Either we have two options, either you give a lenvatinib and radiotherapy versus surgery. Some of the cases where they are dying like child is coming full Budd-Chiari. So we forced to do it. We lost one patient also, honestly, I'm not saying that every patient. Some of the cases selectively. I look at into the other people also, I discussed with the Kokudo, Japan people, they also said some selective groups you can still try. So we are going on. Thank you.
Madhu,
just one query. You said use of veno-venous bypass. So I suppose you're only using the venous side, not the portal circulation. That wasn't going into the veno-venous bypass.
No, sir. We have used portal also. What we have done is we put a cannula into the inferior mesenteric vein. Okay. Anyway, portal vein is clamped. That we are using for a perfusion of preservative solution. Once you apply portal vein clamp, splanchnic congestion will occur. So that's why we are decompressing through the IMV. I have shown inferior mesenteric vein. So IMV with the Y connector, we are joining to the femoral vein.
The typical veno-venous bypass. So you do your inferior mesenteric for the portal and then of course.
This is, we learned from Pittsburgh, where they do regularly retransplant veno-venous bypass, both portal vein decompression with the lower limb decompression with the bypass. So we have used same principle.
I mean, of course, here there is a concern because of the tumor. If there wasn't a concern about the tumor, again, you know, you could probably take the main vein.
Yeah, in all cases, we did not require. So some cases, we applied trial total vascular exclusion. We have seen that some patients long-standing obstruction, they already established collaterals, photosystemic. So they have tolerated, we went on doing upfront without any veno-venous bypass. There are two cases we faced it. Anesthetist said, sir, BP is not maintaining. And our bowel is also increasing. So that time we have used it, mesenteric and veno-venous bypass.
I suppose if you have access, you can always do a shunt. I mean, this of course won't be possible in this particular patient.
Yeah.
But shunt and maybe a partial clamp. But again, you had to do a complete venous clamp here.
Yes, sir. Yeah. So what happened is, some of the cases with the portal venous tumor thrombus are inflow not reconstructable. What they have done is, they have removed the entire liver. They have put a PTFE graft. In that, they have done a portocaval shunt. Then, extrahepatic, their liver, they did a resection of the tumor portion, reconstructed the vessels, and autotransplantation. The problem is, with that autotransplant and extrahepatic liver resection, LRA we call, the disadvantage is, such cases, we are talking about hepatic veins and IVC tumor thrombus, where portal structures are normal. You need to do additional portal anastomosis, hepatic artery anastomosis, bile duct anastomosis, which is not required in our context of cases. Whereas if it is portal inflow is also tumor thrombus, such cases definitely LRA better.
Thank you.
Thank you, sir.
So, Madhu, in all your antisystem, you go for veno-venous bypass?
No, sir. If your parenchymal transaction is going to be within the 60 minutes, we'll finish it off. Yeah. So when we are thinking extended hepatectomy and little bit of background of chronic liver disease, we think that liver will not tolerate ischemia, then we are using for in situ hypothermia. Thank you.
Thank you.
Thank you, sir. Thank you, chairpersons. In the previous talk, Dr. Shubhendran has showed how difficult the retransplant is. To continue with that, we now have two case-based discussions. For the case-based discussion, I invite the panelists, Dr. Sumana, surgeon at AG Hospital, Dr. G. Srinivas Reddy, Star Hospital hepatologist, Dr. Smith Kakadia, anesthetist from KIMS Hospital, Dr. Fani Krishna Ravla from KIMS Hospital. Yes, sir.
Good morning, everyone. Yeah, after the extensive discussion regarding retransplant, I'm going to present a case scenario, a challenging case in fact, which we have dealt a couple of months back. So coming to the history, she is a 27-year-old female. Index presentation at 18 years of age, she had complaints of pruritus, weight loss, pigmentation with progressive jaundice. She was evaluated. She had PSC, biopsy proven. It was a large duct disease. There was no autoimmune overlap and no IBD. Since her disease condition was worsening, she underwent a liver transplant. DDLT was done, a split left lobe was done, and they have done duct-to-duct anastomosis. A year later, she developed anastomotic biliary stricture, for which she required multiple times ERCP and stenting. Almost ERC was done 10 times, more than 10 times. And 3 years later, she landed up in graft failure with progressive jaundice, ascites, and recurrent cholangitis. They have labeled it as query recurrent PSC, bar secondary biliary cirrhosis, but her condition was not improved. So she was offered a retransplant. The retransplant was done last year in April. This time again, she underwent a DDLT. This time they have done hepaticojejunostomy. She was doing well for the first 3 months after the retransplant. But 3 months later, she started having recurrent episodes of fever. Every time she has a fever, she also has hypertension. And later on, she developed progressive jaundice with itching. And she required multiple admissions in the next couple of months, almost more than 6 admissions. And every time she is getting admitted, they were inserting PCDs in the liver abscesses. And at one point of time, when she came to us, there were 4 drains into the liver, draining minimal amount of biliopurulent fluid. So she came to us in December last year. At presentation in ER, she was having obvious fever with hypotension, required inotropic support, with worsening jaundice, pedal edema, with 4 drains into the liver abscess. So, question to the panelist, Dr. Sumana. What are the possible causes of such clinical picture wherein after a retransplant, 3 months after a DDLT, a patient developed recurrent episodes of fever with progressive jaundice and multiple liver abscess? What are the possibilities, clinical possibilities?
So in this scenario, I think we should look at 2 things. Importantly, one is a biliary issue and a vascular issue. So you look at, you know that it looks like a picture of cholangitis, and with liver abscess, you have to look at the artery also. So either you do an MRCP or a triphasic CT or a Doppler should be enough in the initial phases.
Yeah. So just to summarize, artery problems can cause multiple liver abscess. Obviously, we have to do a CT. any problem with hepatic ostomy can also present the same clinical scenario. Anastomotic stricture causing recurrent cholangitis. Some rare cases, a reflex cholangitis is also a possibility due to, in case she has a short limb. Any medical causes can cause such clinical picture.
You could think of recurrence itself, like say she is PSC, and in the past also she's had a retransplant. That also was mostly because of biliary stricture, isn't it?
Yeah, they have labeled it
So
as
then
PSC.
is it a recurrent disease causing these, is also what we need to evaluate, I guess.
Yeah, but recurrent PSC within 3 months is quite not
It's
that
not, it's
common.
not known, I agree, but at least minimum, I think 6 months at least you should, the earliest that I have seen a recurrent PSC is 6 months.
Yeah.
Though I think literature says even little more than that.
Yeah, what else can cause, medical causes can cause such scenario after a DDLT?
Donor infections or donor diseases, is there, you'll have to look at that also, I think. Medical issues.
A prolonged cold ischemia, a prolonged warm ischemia, severe IR injury.
Why would you look at multiple liver abscesses in those?
They also can develop non-anastomotic biliary strictures. It is a relatively less possibility, but still just to consider a list of options which can present like this.
Yeah, I mean, I think in a DBD, if you're looking at a DBD and then prolonged ischemia and all that, they would, I would think more of, you know, they may have some transaminitis and these kind of things. And biliary strictures, yes, if it is a DCD donor, they may have intrahepatic biliary strictures which can lead on to these kind of pictures. I can't think of anything else.
Yeah, just to complete the list, I wanted to add something else.
Okay.
So this was a CT scan when she presented to us. We can see in the scout there were 2 PCDs. We have removed the other two just because they are not draining anything. There was also portal vein kinking. And what was more relevant in this case was there was a linear calcified structure in the donor graft artery, probably a stent or probably calcification in the hepatic artery. We can't say. It was no flow in the hepatic artery. There were multiple liver abscesses. This was actually scanned done 1 month prior. There was only 2 abscesses in the liver which became multiple confluent abscesses. And what was also shocking was that multiple arterial collaterals were also there, which we did not expect. What was the reason behind this? They have ligated gastroduodenal artery and splenic artery, both. So there are multiple peripancreatic collaterals. Maybe they might have done it to improve the arterial flow to the graft. That might have been an issue intraoperatively, which we can't say. We don't have the intraoperative details exactly. And this was the LFT when she presented to us. Bilirubin was 15 and albumin was 2.2. So my question to Dr. Funny, do you think this graft is still salvageable or do you want to go to retransplant directly?
I mean, this is a probably relatively early hepatic artery thrombosis with bile duct ischemia with multiple abscesses. So in this situation, definitely it not be salvageable.
Yeah. So when we consider retransplant, we had a discussion just prior to this session, whether do you prefer a DDLT or LDLT? I want just to summarize the session.
I think we had the discussion in Dr. Surendra's presentation. Both are options. I mean, pros and cons are there. LDLT in this kind of scenario, obviously she's a septic patient and she's pretty frail, so you can optimize and do an elective surgery. And then you can only decide that you get a young graft, a single duct. So if you can control those factors, LDLT is good, is preferable. But technically, DDLT will be better in her case because your artery is long calcified streak. So if you, in case you need to use grafts or something like that, DDLT is better. So I think both are options.
Technically, definitely DDLT is better. LDLT provides a chance to optimize the patient clinically. So do we transplant at the best possible time? And one more controversial question I want to ask, because the patient attendants mentioned this point. Someone told them that LDLT has more chance of recurrence of PSC after transplant. So any comments regarding this?
In that there's clear data that LDLT is equally good compared to DDLT in PSC. So there's nothing, that's not a problem at all.
Yeah, I want to just make this point because they were clearly told that just do DDLT, don't go for LDLT. So they had come to us in this clinical state. So my question to Dr. Srinivas, what would you do to optimize the patient so that she becomes fit enough for retransplant?
So this patient has multiple cholangular abscesses are there. So first thing is we need to drainage the biliary system. So we can keep PTBD drainage, and we can give culture-based antibiotics before going for transplant. And she has prolonged cholestasis also there. I think nutrition also should be optimized with vitamin K and fat-soluble all vitamins. If she is orally taking is good, we can increase the oral diet. If not, we can keep NJ tube also to increase the nutrition part. And to see any infections previously, like any CMV infection or EBV viruses, sometimes within 3 months they may cause non-anastomotic strictures with cholangular abscess, very rare. We need to look into that also.
Yeah. So definitely the points to consider where we can optimize this patient is sepsis first. So she already had multiple PCDs. Do you still want to insert one more PCD or just PTBD is enough?
So as there is a non-anastomotic strictures are there, even you try to keep one PCD in abscess, it may not help. So better if you drainage the biliary system, so it might help to other cholangular abscess also to go down.
Yeah. And regarding culture-based antibiotics, definitely due to her prior hospitalization history, the bug she grew was Klebsiella, which was XDR. She was sensitive to Zivsefta, Aztreonam, both PTBD cultures and blood cultures grew the same organism. So what is the minimum duration of antibiotics you want to give to her before considering a retransplant?
So ideally, maybe if it is XDR bug, we need to treat at least 10 to 14 days before going for transplant.
So we have given 14 days of Zivsefta, Aztreonam combination synergy because it was resistant to everything else. What would be the immunosuppression protocol in this case?
So here the patient has already primary autoimmune disease also there, and history of sepsis and multiple transplants also there. So for this case, I'll start with the low dose initially, and maybe within 2 to 3 weeks, I'll build up with the TAC of 6 to 8 with the triple immunosuppressive
I
drugs.
want to concentrate more on the preoperative immunosuppression because she was already on TAC, Cellcept and Visolon when she had come to us, and she's in active sepsis with hypotension.
So we'll stop all immunosuppressions. We'll keep low dose of steroids. Maybe helpful.
As long as she was in hypotension, we continued hydrocort, then we changed to Isolone minimum 5 mg OD. And nutrition obviously has to be taken care. So the good point regarding her was she was quite motivated and family was also quite motivated. They had come to us for a retransplant. So we took care of nutrition, and incidentally, she was also had CMV viremia. There were 20,000 copies, we treated it, and CMV was already discussed in detail yesterday. I'm not going to details. So my question to Dr. Smith, what would be the endpoints of optimization? So how long would you want to wait so that you can say that she is fit for a transplant, retransplant actually?
Ideally, it has to be a multidisciplinary approach out here. Being an LDLT as an anesthetist would be much more preferable because we'll have ample time to optimize this patient. And as you rightly said, that she was optimized on grounds of sepsis, she was optimized on grounds of nutrition, as well as the only thing I just wanted to add is any support system required at that point of time. Support system here includes circulatory and the renal support system, which is not mentioned actually. Yeah. So if that is also required, we can just support it and take it whenever the surgeons are comfortable. But we are generally comfortable once the optimization is adequate. Our concerns are only when such kind of cases come for DDLT, because as I asked the question just before, because we go through the Rosen scores and all for the risk stratification part, but that is only permitting if the surgeon allows. That's the most difficult part to convince him. Because if time permits, we had done a case, as Naeemson is here, we have done a case together, a retransplant case, a similar one, 45 years old. Patient underwent an LDLT followed by a DDLT. He had hepatic artery thrombosis immediately after LDLT, first one. And then thereafter he had biliary complications, and then he came to us after 3 months where he had all toxic symptoms and he had multiple liver abscess. We had put PCDs for him, multiple PCDs. It didn't work out, and luckily he got a call for a DDLT. We took up the case, but unfortunately we didn't have time to optimize. There was a risk of bacteremia. The CT finding showed like liver was just like a cocoon in it. So as soon as sir opened it, we had something where we didn't want to face it. That was something like vasopressor resistant hypotension, and we unfortunately lost the patient. So I would still say we have to put our foot forward and convince the surgeon whether risk stratification is actually required for a DDLT case purpose.
So that is where LDLT has a big advantage, what I feel. And regarding optimization, we need to have realistic goals, because in this case, liver is the source of sepsis, and we have to control it as possible. So clinically, we choose a time after we have given 2 weeks of antibiotics, culture-based. We have decreased the immunosuppression. We optimize the nutrition. And so practical point of view, when she is 48 hours febrile off antibiotics, is the period which we'll consider retransplant. Also, due to motivation and removing all the PCDs, she was feeling better, and we could improve her nutrition with proper counseling. So this was the labs pre-transplant. What happened after PTBD? Bilirubin had transiently improved, but it did not reach baseline. Obviously, it again went up. The cholestasis was persisting. What was significant was albumin went up. We did not give any intravenous albumin for it. Albumin obviously went up. So regarding retransplant options, what are the technical challenges faced in this case? I want Dr. Sumana to answer this case surgically.
So now that you have a liver filled with abscesses, that is one major thing that is going to be a problem during surgery. I think Dr. Sudhindran sir has already stressed on most of the points. That for this particular case, I will say that the recipient hepatectomy is going to be really difficult. Secondly, now that the arteries, you said the GDA was ligated, or?
Yeah, GDA is ligated, and
splenic artery also was ligated. Probably they have done it during the first LDLT. I don't know if they have done that.
We can't say exactly.
So now the other issues are the inflow. That how do you get the inflow is another question. Recipient hepatectomy, like I said, is a major issue here. So there are particular things that we need to take care while you're doing the recipient hepatectomy here. I know there are PCDs, there are PTBD also you have put. So we have to see the spillage of this abscesses into the peritoneal cavity, which I think many a times we don't really look at it. But if you see in the post-op cases, in the post-operative period, if there is peritoneal infections, like sort of peritonitis, there are other things which turn out like a sort of a pseudo obstruction, people having constant, you can't treat them with any kind of antibiotic. These things is also a concern. Yeah, so recipient hepatectomy should be done with less spillage of the abscess contents, see that it's less blood loss is there. I would suggest that in such cases, using hand dissection should be avoided very, like say, use cautery everywhere, and because there is a HJ there. Plus, you have to avoid your bowel perforations, and blood loss can be avoided mostly by not using hand dissections, which tend to happen with surgeons when you, especially after you have a graft there, you try to lift it. Those kind of things you should avoid. And obviously for hepatic artery inflow, you will have a planning before. Like say you have a triphasic CT, you will know which artery you would try to use. So here I think if you're going for a DDLT, you don't have any other options. Like say you don't have the hepatic artery, GDA is also gone, you're saying splenic artery is also gone. So going down, lower down is an option. Or you can look at other options, like if there is a left gastric artery, that can be used. If that's a good artery, you can think of that. In very like as a salvage, then you can think of like a gastroepiploic and those kind of things, which is like a salvage procedure. Which I think when you are having a planned surgery, that should not be a problem.
As you mentioned rightly, left gastric artery was suitable. Other backup options were middle colic and gastroepiploic.
If you're going to gastroepiploic and middle colic especially, I think that is like you're losing the battle there. Yeah.
So what we have done transplant on 13th of January. 1 month after she presented to us. As expected, liver was cholestatic. There were dense adhesions. There were multiple cholangitic abscesses throughout the liver. There is one large abscess here, subcapsular. Dissection was quite difficult. We had to be very meticulous, and fortunately we had got control of the left gastric artery. We mobilized it further till its insertion. Then we have done artery anastomosis with the left gastric artery. This is a post-op CT after 3 months of transplant. This is the graft inflow from the celiac, the left gastric artery supplying the graft. There are multiple bunch of arterial collaterals around the pancreas. So, to conclude, multiple liver abscess after liver transplant, rule out hepatic artery problems, and in case there is a problem with artery, advise early retransplant instead of just wasting time putting PCDs and all. And sepsis control before surgery with PTBDs, culture-based antibiotics is definitely helpful, and this is where LDLT scores a point. And we should have realistic goals for optimization because liver itself is a source of sepsis in this case. Thank you, everyone. Any questions for the audience, from the audience?
So was your patient culture negative when you actually transplanted them?
So we haven't repeated cultures as of now because after 2 weeks course of Zavicefta aztreonam, she remained afebrile later on.
Okay. No, because
we did not require further hospital admissions also.
There's a recent Korean paper on a nomogram for predicting futility, and in that bacteremia is actually a predictor for futility in nomogram.
Yes.
So we have a similar patient right now who's who are not able to get culture negative actually. He's had repeated courses of antibiotics, but our problem is that every time the culture grows something. So would you do the same operation if there was culture positivity as opposed to culture negativity? Would your plan change?
Yeah, if culture is positive, we would start the sensitive culture-based antibiotics, and once it's afebrile 48 hours, we will go ahead with the transplant. We just can't keep waiting because in this case, specifically, liver is the source. Unless we remove the liver, we can't get control of the sepsis.
Okay, thank you.
Antifungals and the fungal cultures is also like something we should, especially with multiple abscesses and biliary issues, probably give them higher antifungal to start with and see if there's anything growing, and that should be also taken care of, especially CMV viremia being so high.
And Dr. Dharmesh also mentioned the same point yesterday. A patient who has CMV positive, always chance of invasive fungal infection. So perioperatively, we have given 10 days of liposomal amphotericin, then switch to fluconazole.
Okay.
And also the point we discussed about draining all the larger abscesses, even if it has to be a few extra catheters, it's important because not in the setting of retransplant, but in high local angios, I've seen that when you have a liver studded with multiple abscesses, all the handling you do during the surgery leads to a lot of bacteremia, and they go into resistant, resistant hypertension post-op.
Yes. Yeah. Thanks everyone. Thanks all the panelists for their inputs.
Thank you, panelists. So moving to the next session, it's about anesthesia and critical care. And I would like to invite the chairpersons for this session, Dr. Srikanth, cardiologist, Star Hospitals, and Dr. Sashidhar Reddy, surgeon, Continental Hospitals, and Dr. Rajesh Dey, surgeon, Max Hospitals, and Dr. Ganesh Chauhan, anesthetist, Gleneagles Hospital. And I would like to invite the speaker for this session, Dr. Vijay Vora, sir, liver transplant anesthetist. Okay. And I would like to invite Dr. Anand Gupta, sir, from AG Hospitals.
First of all, thank you for the kind invitation. It's always nice to be here in Hyderabad, coming from sultry weather of Delhi. It was such a pleasant surprise. So, before we move on to really coronary artery disease, which is the topic, I thought, this slide should come in first. Don't think it's just coronary artery disease, but just keep it somewhere in the back of your mind. These guys have other issues, cardiomyopathy, portopulmonary hypertension, etc. But yes, we are going to concentrate on coronary artery disease. So discussion plan is the relationship of CAD with the end-stage liver disease, risk factors, etiology, and it's changing its relationship to coronary artery disease. I think you are aware of that. What intervention? That's the gist of the topic. And safety concerns regarding coronary artery stents. Are they safe enough, good enough? How to use them? And are there any newer insights into it? So we'll go a little up and down with it, but more or less these will be things we will be discussing. This was the paper, I think, which created a lot of chaos in the circles. 50% mortality, everybody was so worried. This was 1995 or, yeah, somewhere around that time. And, everybody was worried, coronary artery disease. Till now, the understanding was liver disease, good peripheral vasodilatation, patient can get through. Liver disease is protective. That used to be some sort of a feeling going into end-stage liver disease. But then this really, I think this is the one that woke up everybody. Look, come on, this is an issue. And then, of course, many papers started coming out. The incidence is, look at this, is pretty high. End-stage, some people, put it in single digit, but as much as 28% in end-stage liver disease. So again, the incidence is pretty high. In our study, in our hospital study where we had a look, it's about 18%, which is quite significant. Of course, etiology is important, like I said. And etiology is changing. Now, this is the recent data. I think NASH is taken over. But I think when we started off earlier on, the important indication used to be, number one used to be hepatitis B. Then we got hold of that. Hepatitis C was always there. It's still there, but it's again coming down. Alcohol is held its place, but coronary artery disease and NASH, as we stand today, it's really on an upward curve. But do we have more knowledge about NASH? Yes, I think many studies are saying that. NASH coronary artery disease has much higher incidence. Again, it's both obstructive and non-obstructive. And what is really come out a bit more is there is probably some element of inflammation, so which we have not been looking at it critically. So this study again said NASH, if you look at it, NASH with inflammation, maybe they have more incidence of coronary artery disease. So this is a study from this part of the world only. I think it's from Tamil Nadu, published in Libyan Journal though, and they found CRP and ferritin. They had a huge correlation in patients with coronary artery disease. So NASH may be a accompaniment with it of inflammation, probably has more pointer, a greater pointer towards developing coronary artery disease. These are the typical risk factors Susan Mendel had initially proposed. Again, she also said NASH in the beginning. This is 2008, but I think they all hold good even today. And this was the cardiac evaluation protocol which she had suggested, and keeping these risk factors in mind. We'll talk a little bit about calcium score later on. Firstly, stress testing. I think whatever you might say, we've still not been able to shake off the stress testing in our assessment. Give increased stress and see this is how it is done. You can do both dobutamine and perfusion thallium scan. But what is it? both of them have good negative predictive value to show you, whether it has got whether if they don't have a coronary artery disease, but very poor predictive value. Again, traditionally, a score of 400 is seen as a high risk of developing coronary artery disease or seeing significant obstructive lesion in the coronaries. So this is a non-invasive method. So this can be used as well. But having said that, only good predictor in this is if you have a score of 0. If you have a score of 0, then you can be rest assured patient doesn't have any significant coronary artery disease. I think beyond this, it's really a kind of a graph. So 0, good. 400, probably, these are two good endpoints. In between is variable. Again, it's looking at calcium deposits. Now, this study said more than 100 have increased chance of coronary events. And we carried out a retrospective analysis in our patients, and this is what it said. We also came to the conclusion that more than 100, at least in our subset of patients. Again, this is going back some years, 2013 to 2015. So more than 100 coronary artery calcium score, they had more incidence of cardiac mortality and complications. So I think in our subset, this is again, like I say, disease pattern has changed. We are not looking at etiology here, so maybe it might look different now. So this is what our protocol used to be. Look at the risk factors, DSC for all patients, ECG, DSC, coronary artery calcium score, risk factors more than 2, maybe do another test and see what it is. And if you have calcium score more than 2, then you probably do for conventional angiography. This is another similar algorithm, I think more or less the same, not much of a difference. So coming to the topic which we have is coronary intervention. What do we have right now? Bare metal stents, drug-eluting stents, angioplasty, and coronary artery bypass graft. I think bare metal stents are probably now going out of the way. More and more we're using drug-eluting stent. We'll talk about why a bit later. And angioplasty. Angioplasty was there, it had gone off. But again, it's all resurfacing again. We don't have enough data as of now. What they're using now is drug-coated stents to do angioplasty. So apparently, they do not cause so much of restenosis. So we are again doing angioplasties in our patient with coronary artery disease, which we had given up. So again, we have very few numbers for that right now. But then, of course, the next thing is you have to be very selective about which patient do you do coronary artery bypass graft along with your transplant. So again, indication when? Major vessels, proximal disease, 70% or more block, greater than 12.5% increase in ischemia on stress test, which could be stress thallium or some other means, or multivessel involvement. So again, this study where they carried out interventions, stenting, angioplasties, they found in this cohort, doing the interventions, the outcomes were more or less similar. This is the further evidence of from the same study. What else that has come out in coronary intervention is studying of fractional flow reserve. So what is it? This is the pressure proximal and distal to the lesion. So you see the aortic pressure and you see the pressure beyond the lesion. And they try to see this flow after giving maximum dilatation, in the sense so that if it has to increase, it will increase in different circumstances. So they use nitroglycerin or they use adenosine. Both the drugs, they can be given locally or they can be given intravenous. And they look at the pressure difference before the lesion and after the lesion. And this is the meta-analysis carried on FFR, and basically looked at a lot of studies, but 7 were included, and did find FFR guided management did lead to better, less adverse effects. So what did they say in the end? Current guidelines advise do the FFR guiding your PCI strategy, and they should be performed when you have seen the hemodynamic differences doing FFR. But again, I think this is not the final word. We still have to do more work on that. So what is the guideline? FFR is 1, that means the pressure is the same, that's fine. FFR greater than 8, again you have to be careful, but if FFR is less than 0.75, I think those are the patients, they must be intervened. So whatever you do stenting or you do CABG, that's again kind of vessels that are involved. So when to transplant after PCIs? This is the old saying, 4 to 6 weeks, bare metal stent, drug-eluting stent 6 to 12 months. But having said that, of late we have been using newer drug-eluting stents, and 4 weeks after that is good enough to, 4 weeks, drug-eluting stents, dual antiplatelets, they are good to do transplant. And obviously you are looking at strength. This is the nomogram for using bare metal and drug-eluting stent. Having said that, it's been proved in liver patients, PCI is safe. Again, very few complications in this particular study, although the platelet counts, if you look, are from 23,000 INR up to 1.5 or even 1.9. So again, it's pretty safe. Quite often they are able to go through the radial artery. And, but you must keep in mind restenosis, stent thrombosis, contrast-induced nephropathy, bleeding. They are possible. Rare are arrhythmia, dissection, distal embolization, and infection, of course. Keep in mind. Again, last slide. CABG and transplant, again, not a great option. You really have to consider it carefully. We've had an experience of about 8 patients. It's not without a struggle. They stay in the hospital longer. Again, CABG has to be done first, followed by transplant. 2 patients had tracheostomy, 3 had re-exploration, and 2 out of 8 did not make it. Really, to sum it up, coronary intervention has significant implication in transplant patient. Calcium score, I think, should be a part of the normal protocol. Inflammatory markers, I think one should look at it. I think we still not, there are some indicators, but we should really look at it, especially in the patient with NASH. And FFR, I think, has a role to play in borderline cases, and really combined CABG should be reserved for very, very selected patients. Thank you.
Thank you, sir. That was a lucid presentation, but like I'm a cardiologist, so I keep seeing these patients, and this talk has, I think it has come up with so many questions which can be debated.
Yeah.
And I'll let the floor ask some questions, before I take up few later.
Yeah, thank you, sir. Nice lecture. We are facing some of the patients, ACLF type, don't have a much time, near emergency, and DSC positive and cardiologist significant stenosis, more than 70% need a stent. Thing is argument. Dual antiplate cannot be stopped at least 6 weeks, then what? So ACLF already coagulopathic. So bare metal stent versus these drug-eluting stents. Previously, our senior cardiologist used to agree for bare metal stent. Now, the present generation cardiologist says that we won't use it. I don't know. The cardiologists need to tell us because the patient will not have a time. We have one case of HCC. So patient had this type of situation. So we forced to postpone surgery by doing a TACE and we buy the time. But not all cases, ACLF type of patients with the coagulopathy as a background, I don't know what to do. You tell us.
So coming to the bare metal stents, now we don't have bare metal stents on the shelf. They're not there in the hospital. So, and I mean, we have to look at it this way. For example, why we switched over to drug-eluting stents were the long-term outcomes of patients were better with drug-eluting stents. So we put in a bare metal stent, and then you do your transplant, and the patient comes back to you after 3 months with restenosis, right? He has a cardiac event. So we need to see the patient in total. And if you look at the antiplatelet strategies for bare metal stents, it used to be dual antiplatelets for 1 month. With the newer generation stents, we have cut it down to 3 months of dual antiplatelet therapy. And now we are doing biofreedom stents where, we have one trial which clearly showed that you can use DAP for 1 month even with drug-eluting stents. So we don't see any advantage of bare metal stents over drug-eluting stents.
No, my worry is when to stop antiplatelets because per se liver transplant is a coagulopathic low platelets fellows, bloody surgery. So you want insisting for a dual antiplatelets.
Right.
We can, one antiplatelet like clopidogrel, we can proceed.
Right.
But dual antiplatelet, can we stop in 4 weeks?
Yes. So we need to give at least minimum of 4 weeks. So
I agree. I think he's absolutely right. We are now doing routinely, like you say, bare metals are not there. I think the last we used was probably 2012 or something. So we not use bare metal after that. And drug-eluting stents are there, 4 weeks, dual platelets, and then they stay on aspirin. Is that protocol you do?
Yes, yes.
Yeah.
This is exactly the protocol which we use.
Yes.
4 weeks of dual antiplatelet therapy. So we need to be little specific with the stents which we choose.
Yeah.
So if the newest generation stents, so I mean like the biofreedom stent actually has some data, reasonably good data with 4 weeks of dual antiplatelet therapy.
Yes.
The collateral supply. Did you say collateral supply, sir? So basically, what we are looking at is the blockages which are not 100%. So collaterals develop when the vessel is complete. The collateral supply is important. For example, if the vessel is completely blocked, and if it is well collateralized, we think that those patients are relatively stable. They're stable blocks, basically. They won't usually cause problems. So whenever we understand, I mean, this again, I keep having this discussion with the surgeons. The cardiac events are 2 types. When if somebody is undergoing liver transplant and patient has some narrowing, so he can have type 1 MI or type 2 MI. So type 1 MI is where there is a plaque, 10%, 20% narrowing, which can rupture and cause a heart attack. Right? That can happen to anybody. Even you do a stress test, any stress test, any patient can develop a type 1 MI. It's very hard to predict those events. What we are looking at is basically type 2 MI, where somebody has 80% narrowing in one of the coronary vessels, and that patient has significant hypertension in the peri-op period, and then he develops MI. That is because of the demand-supply mismatch. That is what we can predict accurately with angiogram or whatever we do. So it's very hard to predict a type 1 MI. It can happen to any patient. So we do a stress test, and then we say that, in one of the slides you mentioned less than 12.5% of myocardium. So we are a little generous. We take it as 10%. If there is more than 10% of myocardium is a jeopardy in a stress scan, then we say that, okay, this patient can deteriorate hemodynamically in the peri-op period. If the myocardium at jeopardy is less than 10%, we say, okay, there's less chance that this patient can have hemodynamic instability. Still, they can have a MI due to type 1 MI. So the question again, it comes to that, if somebody has a total occlusion with well collateralized vessel, the chance of them developing type 1 MI is less. It's not different. But the chance of developing a type 2 MI is still there. Because collateral supply, collateral vessels, we take it as they are equivalent to 10 to 15% of normal vessel supply. So for example, if the vessel is flowing normally, or the same vessel which is blocked with collateral supply, we say collaterals, they work like 10 to 20% of the blood supply of a normal vessel. So still they can have some myocardial injury in the peri-op period.
The other thing is, nobody has really worked out giving it less than 4 weeks. I don't think it's probably possible at this stage in the stopping dual platelets less than 4 weeks. I mean, our like liver patients, they are partly anticoagulated, anyway. But still, I don't think, we will be able to do any study giving antiplatelets for less than 4 weeks.
Yes, sir. I think this.
Yeah.
Something done, stenting or something done 10 years ago. And the cardiologists will refuse to stop their aspirin or clopidogrel at all. And we keep fighting with them, and they'll say, no, you have to take forever, in spite of them having GI bleeding, low platelet count. So how do you correct that situation?
Change the cardiologist, why?
Right.
Yes.
I mean, most of the cardiologists are similar. So the next cardiologist also will give you the same advice probably. So changing cardiologists may not help. So this comes up with data which shows that if somebody had a cardiac event under stent put in, who is on single antiplatelet versus no antiplatelets, continuing one antiplatelet is beneficial with decreased events, even over long time. But in somebody who has some coagulopathy, or we say chronic stable ischemic heart disease, either stented, non-stented, who has a need for anticoagulant, we stop antiplatelets in them. We continue only anticoagulant. So probably this subset of patients is similar, where they have some coagulopathy, hepatic dysfunction, coagulopathy. So there is no wrong in stopping antiplatelets, but this is not backed by data, basically.
Yep. See, there are some situations you can't be sacrosanct that you should always give for certain duration and other things. So you see the risk-benefit ratio and convince the patient to take for surgery. If emergency surgery is there, ALF pending, so we just can't insist on the angioplasty and this thing. You need to balance it out, which risk is at that point, and then take the clinical decision.
I totally agree. It's actually, most of the times, the cardiologists won't stop the procedure. The surgeons are more worried.
I don't think so. You ask Madhu.
Sir, I just wanted to ask, suppose you have a patient who has liver disease, decompensated, there's a donor ready, and you really can't wait till you put in a stent and all those things. What will be your strategy? And you have to take him for transplant. You are doing it. So what do you do intraoperatively, postoperatively to make his
depending what kind of CAD does the patient. You still have to investigate to see the extent of, like I said, stress test is no good, really. You rarely ever find anybody stress test positive. They're all, so I think we tend to go for calcium score in all patients, except alcoholic. Alcohol liver disease doesn't give you any idea because they will always have a high calcium score. So except for alcohol liver disease, have a look at calcium score, maybe give you an idea. If the calcium scores are low, maybe one can think about. Yes.
One beef about the calcium score.
Yeah.
So we had looked at all of data. So if you look at all MIs, patient who with myocardial infarction come to us, nobody has high calcium score. So the calcium score, all the data is from the West basically. Our people, they develop CAD at an early age. And if you look at their calcium scores, somebody who has acute coronary events, the calcium scores are always low. So there's some problem with using calcium score. The calcium score is useful to predict events over a longer period of time. So here, when somebody is undergoing surgery, the surgeons are more worried about if the patient's going to die in the next 6 months, 3 months, 6 hours. They're worried about a shorter time span. But these calcium score and all, they predict events over a longer time span. So I don't know how useful they are to predict events in the shorter time frame.
Also, I think we also probably need to watch out for inflammatory markers. At least in liver disease patients, we should probably club it calcium score and the inflammatory markers and maybe have a look at that. I agree, only calcium score may not be on its own, but with a NASH coming in, I think, it's all dynamic. I think what you were seeing earlier, the disease pattern has changed. I mean, 15 years back, it was hepatitis B. The scenario is different. I think with the NASH, I think we are going to see quite a lot of change.
Sir, as you are seeing these kind of patients since long,
Yeah.
and prior CAD and now CAD, how easy to manage now as compared to the prior? Because many things has changed in the last 20, 30 years, sir.
I think you're going to see more CAD, more obstructive CAD now with the NASH coming in.
So
This is what I feel. Of course, time is going to tell.
When I say starting the critical care, then first of all, I think say the surgeons.
Yeah.
Surgeons' skill. They used to do a surgery for 15 to 18 hours.
Yeah.
Now the surgery time is 6 hours, 7 hours. Blood transfusions, products. These are the less complicating the post-operatively stress-induced cardiomyopathy and everything, sir.
I tell you what, the problem really comes in the post-op. Intra-op, rarely you will have anything. Patients are vasodilated. You're fine. Once everything is restored, vascular tone is back, that heart is going to be more stressed for the same kind of work it is doing. So I think intra-op, you'll get away. I mean, like you're saying, doing a transplant, you will probably get away with most of them, maybe 80% block also. But problem is going to come post-op when your guards are down, you think you had a successful transplant, everything is coming back, and then maybe also a few months down the line, when they do develop metabolic syndrome, earlier on they will need something doing. But if it's really a very urgent situation, yes, you can get away with significant coronary artery disease, I agree, but post-op is going to be the real problem.
So thank you, sir. I think we are running short of time, and
thank you.
We'll conclude the session here, conclude this talk. Yeah.
For the next talk, the topic is perioperative neuroprotection and neuromonitoring in ALF. I would like to invite Dr. Sweta Singh ma'am to give this talk. She's a liver transplant anesthetist from Venkateswara Hospital, New Delhi.
Good afternoon, everyone. I won't keep you very long from lunch and the next talk. So, thank you, Srini Rajgopal, for remembering me and calling me for this conference. I have been asked to speak on neuromonitoring and neuroprotection in patients with acute liver failure in the perioperative period. So, so I want to just go over the facts. Like we all know what acute liver failure is. Disease which suddenly strikes a person without any background of a liver disease, and there is coagulopathy, encephalopathy, and all this is reversible, and all this is potentially reversible, and there are so many definitions from different groups. We following the INASIL definition, there are different etiologies, and with viral predominating in India, and now we have rat poison coming from the south, and we do not have so much of paracetamol, but we have a lot of viral and hepatitis A emerging from hepatitis E. So, and this affecting the entire systems, all the organ systems. But if you ask me what is it that kills them and what is it that is predominantly responsible for poor outcomes, is cerebral edema. And if we can monitor our patients and pitch in at the right time, taking all the conservative measures which are required, then maybe we can manage a lot of patients with conservative management as well. So as per the Western literature from Europe as well as from the US, the incidence of cerebral edema is coming down quite a bit. But in our practice, we have seen that in each case, cerebral edema needs to be worked upon. We need to monitor it, we need to take care of it, and we need to avoid it, whether we are taking up this patient for transplant or we are not. So the pathogenesis for this cerebral edema is multifactorial. There is cytotoxic cerebral edema. There is a lot of ammonia contributing to it. There is vasogenic. And there are inflammatory cytokines, which are also responsible for contributing. So I will quickly move to the part which is the actual talk. So we all know that as the grade of encephalopathy worsens, the edema worsens. And this has been correlated with the levels of ammonia, and there has been tremendous work in that direction. And so invasive ICP monitoring, which has literally been thrown out of the window, is the accepted gold standard. It is accurate, especially if you put a catheter into the right space. But it has so many complications. It is associated with occurrence of bleed. It's in itself, it can cause infections. So is it feasible? Perhaps not. So how do we monitor these patients? This is the data which has come again from the US group as well as the UK group, which is telling us that very few centers, even high volume centers are now very few high volume centers are using ICP monitoring invasively in patients with grade 3 and 4 encephalopathy. So today is the era of non-invasive ICP monitoring, where we have to monitor our patients in different phases. We have to do 2-3 things at the same time, and we have to see how this patient is progressing. So we have to see the pupils. We have to see how this patient behaves clinically. Is there any localizing sign? Is there any change in reflexes? Is there any change in tone? We have to rely on a lot of indirect markers. There is, arterial ammonia levels. We can see the trend. We can see the optic nerve sheath diameter. This can be clubbed with transcranial Dopplers. This can be clubbed with NIRS, which is coming up in a big way. And I would like to go to each one of them individually. So we're assessing a patient with, and we already know that the level of consciousness is gone. We have to tube this patient. So how do we assess the level of consciousness? We can maybe do a sedation based on BIS. We can assess the pupils. We can do a close monitoring, 2-hourly pupillary dilatation. We observe the patient's posture. We see for any posturing, any seizure activity. But remember, this patient doesn't have to be on muscle relaxants. Otherwise, you cannot tell whether this patient is posturing or not. Unless if you are very sure that you're taking up this patient within the next 2 hours, or you're not being able to ventilate him with the current strategies, you do not paralyze these patients. We used this indirect pupillometer, which was an objective way to remove the subjective variations of pupillary dilatation. We have to see pupil reaction, we have to see pupil size, maybe every hour in these patients. So this particular instrument helps us by giving us the NPI index, which if less than 3 is a problem. So the ambiguity of subjectiveness is obliterated when you're observing the pupils in the patient. So anybody can, as the posting changes, the doctor changes, the nurse changes, you can use the pupillometer to assess for pupillary reaction. But even if the pupils are dilated and fixed, this is our experience from my previous center, where it is seen that these patients can be safely taken up for transplant, because it is important that the pupils should be dilated and fixed for a prolonged period of time. It is not like, it happens and the patient has herniated. So the patient you can do a series of other tests, and you can also remember that although the blood-brain barrier is maintained in these patients, there are situations where you will get pupillary dilatation and fixation and maybe asymmetry, but you do not sign off on these patients just because of that. So The other way of looking at it is looking at things indirectly. So we can do a fundus examination. But again, fundus examinations give you a picture which is very much delayed. So if it has been seen that when you do a CT scan and if you do a fundus examination, the fundus may not show you that much papilledema as the CT scan was showing you, with obliteration of sulci and the ventricles all gone in this particular scan. So the better way of doing things is, when you are managing these patients, is to use a combination of techniques, like I said before. And optic nerve sheath diameter is something which is very practical and very useful and very doable, where on the bedside you put a probe on the closed eyelid and you get a window, and 3 millimeter behind the disc you can measure the diameter, and this can be serially measured. Now there was a meta-analysis and they gave us the cutoff. So you have to know exactly how much is the ICP, is it correlating with ICP? So they gave us cutoffs of 5.6. So basically, if it was between 4.8 and 5.6, then your patient has, not that kind of a cerebral edema that he's herniating. But I, from my experience, would say, and I would agree with this paper from ILBS, where they have said that 4.6 is actually the target. You do not go to levels of 5 and 5.5 and beyond, and look at the trends. If you look at the trends, it gives you more information. Whether the patient is progressing, when do you need to intervene? Because when you talk about neuroprotection, you have to intervene as and when necessary, when the pupil diameter is increasing. The other thing which we can use, and we have baseline data on transcranial Doppler, and Dr. Sushma has worked a lot on this, and she has given us 4 images. You can make a window, a transtemporal window, and through that you can see the flow in the middle cerebral artery. The probes that are available to us nowadays and the software which is available to us nowadays is very simple. And the operator training part, which was considered very tough, is now over. And this technique can be used again for serial monitoring. But you can see things like the flow, you can see the systolic and diastolic flow in the middle cerebral artery, and you can also see the PI and resistive index, and there are normal ranges, and you can monitor and see which way the patient is going and intervene as and when necessary. There is reversal of flow which can be seen, there can be vasospasm which can be seen. So this technique is also something which can be clubbed along with ONST, and the patient cerebral status can be monitored better once he has been tubed. Another thing which we have used in the past is jugular oximetry for seeing the saturation of jugular venous oxygen, the bulb oxygen. So you can do a direct puncture, and in the past we used to have a catheter which could be inserted, and just like a pulmonary artery catheter, this catheter is advanced into the jugular bulb like a central line, and using a fiber optic device, it was possible to take continuous measurements. But unfortunately, this catheter is no longer available. So I believe instead of fiber optic oximetry, we are only left with intermittent puncturing now. So if the catheter should be available in the market again, because there was a catheter from Edwards which was available, I think by the name of Precep, which helped us to do this more serially and continuously. You can see how much, this is an indirect assessment of how much oxygen is being used up by the brain and how much is being delivered. So if you see the value of saturation of jugular venous oxygen, you can see whether it is less than 60 or more than 80. If it is less than 60, perhaps the brain is using up more. Maybe there is some seizure activity, or that the blood flow is not enough. So you can optimize that. And if the SjVO2 is rising and it has gone beyond 80%, probably you need to reduce the metabolic activity in the brain. You can try to give some hypothermia or hyperventilate the patient. So this was an indirect marker, but this was a useful marker. But instead of that, now we have this new tool, which is near-infrared spectroscopy, which is here, and it has been here for a long time, but has been used in acute liver failure. And we really need to work on this technique, because this has been used in trauma, and there are studies which are being done in normal people to show the changes. So I'd like to dwell a little on this. So here again, you just place an electrode on the forehead, and there are 2 light-emitting diodes, and there is a receptor. and it measures the differential absorption of light which is thrown on the, so it traverses the hemoglobin and the oxygenated hemoglobin. Near infrared spectrum light is used, so there have been studies with 810 nanometer wavelength light mostly. So just like saturation of jugular venous oxygenation, here again you're seeing the value through brain metabolism, how much is the blood supply, how much is the oxygen, and how much is the uptake. So again, it's sort of indirect, but again, it helps tell you whether, but it's much more doable than putting a line into the jugular bulb. So it's a simple technique where you put in a probe on the forehead and you see whether the oxygen delivery should be optimized or consumption should be reduced. And similarly, you can improve the blood flow, or you can cool down the patient or reduce the metabolic demand, run infusions which can reduce the metabolic activity in the brain, and measures to reduce the ICP, because these are indirect markers, but they're useful and sustainable over a long period of time. And this was earlier said that, when they tried to measure ICP in a patient with traumatic brain injury and corroborate it with near-infrared spectroscopy, they said it was not good enough. They said it is not a substitute of CT imaging. But here we're not wanting to see CT imaging. Here we are wanting to see whether this patient is progressing towards intracranial hypertension. So NIRS might be the way forward, because in this study, which has come from a physiology lab, they have tried to, they've done it in a small subset, about 16, 17 volunteers. They did not put in a bolt, but they did things which are known and which have been proven that this causes alteration in intracranial pressures, like Valsalva, like Trendelenburg, and they have seen whether it is corroborating with NIRS measurements. So a huge number of measurements were taken, and they feel that it does corroborate. So I think this is the way forward in neuromonitoring in liver failure patients. Then, of course, we can see the EEG, but how many times would you do an EEG to see subclinical seizure activity? But we do need to see it if we want to confirm, because here we have a patient who's been tubed, who's been paralyzed, who's on ventilator, and you really can't rely on anything except ONSD and arterial ammonias. So you can do an EEG to see whether there are any subclinical seizure activities. So using a combination of these, depending on what all you're using, you can use a pupillometer to remove subjective variability in assessment of pupils. You can combine it with an ONSD. You can also have a TCD done every 4 hours or so. And so a combination of these techniques, arterial ammonia, this can help you titrate your management and decide what you need to do. So coming to neuroprotection. Now, like I said before, ammonia was the key reason for this raised ICP. So we need to address that. And anti-inflammatory action needs to be taken, because there are a lot of inflammatory mediators which also contribute to cerebral edema, the cytotoxic part. We need to reduce the metabolism in the brain, and we also can optimize the hemodynamics so that there is adequate flow to the brain, and prevent sepsis at the same time, because again, that will cause inflammation. So in ammonia lowering, we do not have too much in the form of medical management, because LOLA really doesn't work. There is a new drug which is being investigated. This is ornithine phenylacetate, which is in phase 3 clinical trials in humans right now, which works similarly, but has more promising effects seen in animals in reduction of cerebral edema. Then sodium benzoate, which was for urea cycle defects. You could use it, but it more or less doesn't work. And of course, you can try to filter the patient. So this was the trial on LOLA, which anyway says that it has been done and it has been shown that it does not help in reducing cerebral edema. But CRRT, which came in with management of urea cycle disorders in children, has been one modality which can be used if you're relying on ammonia levels, if you're looking that you're having a patient with 400, 600, then low dose, high dose. There have been consistent studies, but this is from King's, this came in 2008, that there is gradual improvement in arterial ammonia as CRRT continues. And as the flow rates improve, in low flow rates, the effects might be slower to come. This was a paper from Andy, and I had the privilege of witnessing this work happening, I had an opportunity to visit. So there was low flow CRRT and there was high flow CRRT, and high flow CRRT helped in filtering the ammonia slightly better. And we have more, this was a meta-analysis. No, this was a study which was from the US ALF group, where they had few patients, 200 odd patients who were not filtered, but the rest, thousands, 800, 900 patients were filtered. And they clearly showed that there was improvement in ammonia levels with filtration. So in children, it has been seen that it really works. Clinically, you have seen children having improvement in their consciousness when they were filtered for ammonia with using CRRT high flows. So there is ample evidence to say that CRRT works. What else can we do? We can maintain the sodium levels. We can there has been this paper where they, they monitored the patients with help of ONSD and with the help of, and the clinical effects, and they found that use of hypertonic saline was more helpful in management of edema as compared to mannitol. So we tend to use mannitol, we tend to use hyperventilation because brain autoregulation is maintained. But we use these as salvage, SOS. When you know that there is some Cushing's triad, or you know that this patient is, you're suspecting that this patient is having raised pressure, you tend to pitch in with hyperventilation or with mannitol. But maintaining sodium levels, where hypertonic saline also tends to help you maintain the sodium levels because this is 3% normal saline. So it helps in reducing cerebral edema. Of course, you need to tube the patient. You need to nurse him in a quiet environment. You do not allow neck engorgement. Do not allow the brain to get overperfused. So you do not put lines in a position where the head is down, as we say, Trendelenburg position. And when the ventilation strategy, if there is no ARDS, then things are simplified for you. Otherwise, it can be total chaos. Low tidal volumes, low PEEP, low pressures, and hyperventilation to target a PCO2. Because the brain has maintenance of blood-brain barrier, and there is maintenance of autoregulation. So washing out of carbon dioxide has always helped. And as I said, I do not believe in paralyzing patients unless and until they're being shifted for a transplant. And hypothermia. So there is, again, so much of literature which tells you that there is no point in really freezing them, but moderate hypothermia. So there is paper from Karavelas where he has clearly shown us that 35 degrees or max 35 is what we are targeting. We do not really cool the patients down too much to reduce the metabolic requirement. And then coming to Plex, which suddenly in 2017 we were all filtering our patients using plasmapheresis because of this trial by Larson, which said that high volume exchanges were helping. But whether it were directly helping in reducing cerebral edema or whether they were helping in reduction, I really do not know, because this data, in spite of being around for a long period of time, most of us were not able to convert our patients using high volume plasmapheresis. So plasmapheresis does help in removing inflammatory cytokines. This paper by Marzaki from ILBS, where they, and in a lot of other centers also, especially in rat poison, it has been used. Every patient cannot be transplanted, even if we want. There are many limitations. So patients are filtered. But does it really reduce cerebral edema? I don't know. Well, high volume plasmapheresis did not work in our setups. The patients were not hemodynamically stable enough. They succumbed to sepsis. So standard volume plasma exchange was offered to them. And when we're not using a dialysis machine, when we're not using centrifugal plasmapheresis, we're anyways doing standard volume plasma exchanges. So standard volume plasma exchanges have also shown to be beneficial in certain trials. I thought I should also share this. This is our work from Max, where all the patients whom we offered standard medical therapy versus those who were given CRRT versus those who were plexed, we found that the outcomes were better in those who were offered standard medical therapy rather than being filtered or plasmapheresis. And we had the maximum survival in this group. So this is this work which we have done in the last 8.5 years at Max in acute liver failure patients. So I think that since cerebral edema is the major killer, if sepsis doesn't set in, then the way forward is to nurse these patients in a quiet environment, secure the airway when you need to, ventilate with an ARDS strategy, maintain moderate hypothermia, offer them some ammonia-lowering therapy in the form of filtration. If the patient is having involvement of the kidney, it becomes a simpler choice, and target sodium levels at a higher level, offer NAC, although it helps better in paracetamol, which we do not see, and monitor them, monitor aggressively, so that you can pitch in with hyperventilation, with mannitol as and when required. So close neuromonitoring, I would say, is very, very crucial so that you can detect and you can timely manage an intervention if needed. And monitoring needs to be done with multimodal therapies. There is no one tool which can be used alone. And we need to look at serial values. So I would like to conclude with that. Thank you.
Thank you, ma'am. As an intensivist, I want to tell only this thing, ma'am. ONSD is a little bit subjective. Because if I am measuring ONSD and he is measuring OSD, maybe a little bit different as USCL, but the TCD definitely will give the better outcome. And we are doing one more thing is a Lindegard ratio, ma'am. If we are doing the MCA velocity, divide by the extracranial interconnector artery, and we are giving the mannitol or the 3% NS, after that just see the velocity, it will reduce. You mean to say you are diagnostic also, you are therapeutic also. By giving the 3% saline or the mannitol, you can see the ICP is coming down. And many studies published, they are saying that ONSD multiplied by 5 minus 14 roughly will give the ICP also. And nurse, I think, is not very well evaluated in the ALF patient. But yeah, we need to monitor regularly or routinely all the neural, because that patient died in the ALF because of the cerebral edema. So the last slide, yours, everything you are telling, everything to manage the how to the high ICP patient, because the monitoring and the management, that is the only important patient in ALF. Any question from audience? Sir, CRRT, I am in the AIG, sir. So if you will say that I am receiving roughly 80 CRRT, sir. So, that is true, sir, because many patients, but in the ALF patient, very unlikely you will find some normal ammonia. Yeah, those patients are going.
Yeah, so when the patient has AKI along with ALF, so it becomes an easier choice that you are needing to do CRRT. But if you do not have a patient with renal dysfunction, then we can use citrate for anticoagulation.
Sir, there is a many benefit with the CRRT, sir. Sir, there is a many benefit with the CRRT. First benefit, it will consistently remove the ammonia. Secondly, metabolic disturbance. Third is the temperature control. So CRRT may manage in better way as compared to the plasma exchange in many way in the ALF patients.
Sir, actually it is both ammonia as well as the inflammatory mediators that is causing the damage. So in CRRT, it is already many studies have shown that CRRT improves the damage of other organs. So that is how we are improving and preventing one modality to prevent the patient going into transplant as such. So that way, definitely CRRT would be beneficial in preventing the other organ dysfunction in ALF patients.
For the anticoagulation, apart from heparin, there is an option of citrate anticoagulation.
Regional citrate.
with the calcium goes down and it requires very intensive monitoring and management.
But sir, normal creatinine level doesn't mean to say the patient, our job is right now to remove the ammonia level because the edema is there. Even though, because now we are receiving the patient of viral hepatitis, which is the most commonly AE that is.
Unless the patient is getting deteriorated, I think usually CRRT is not started.
That's a separate matter.
Yeah, so that is why I shared our paper from our previous 8.5 years of experience, where we do not filter or we do not start CRRT on every patient, but our results have been good. And 50% of our patients were in the standard medical therapy group, and those patients had a better outcome as compared to those who were filtered or put on Plex for whatever reason. So this is our paper, which will hopefully get published soon. This one.
So I think no question from more. So can we conclude, ma'am?
Yeah.
Thank you.
Thank you, Chairperson. So next will be the last session of this conference, and it's a surgical session. I would like to invite the chairpersons, Dr. Tom Cherian sir from South Asian Liver Institute, Dr. Chakrapani sir, gastroenterologist from surgical gastro from Ayush Hospital, Vijayawada, and Dr. Bharat Kumar Nara from Star Hospital, surgical gastroenterologist, and Dr. Madhusudan sir, HOD Osmania Medical College, surgical gastro department. Now I would like to invite the speaker, Dr. Sonal Asthana sir, from Aster Hospitals, Bangalore, past president LTSI, to talk about preoperative prediction of surgical difficulty.
Good afternoon, everybody. Many thanks to Dr. Srinivas Reddy and the organizing team of Star Hospital for this invitation. It's always a bit worrying when you start to get non-clinical topics for your presentations. So that means that it's time for your Lifetime of Achievement Award, and it's time to retire. I certainly hope that's not the case here, Dr. Srinivas. But the good thing is that thanks to the unusualness of this topic, all the slides are very fresh. These are my appointments. I don't have any disclosures, and all the slides have been made the old-fashioned way here. So why is this important? We know that liver transplant is a very technically challenging procedure, and difficult transplants can lead to higher post-operative mortality, morbidity, and hospital stays. But surprisingly, there is no clear definition of difficulty. Firstly, how do we define difficulty? And secondly, can we predict which patients are going to behave poorly? Why is it important? It helps us make better decisions, both when we talk to patients as well as when families are making decisions regarding risk and benefit. It helps us to decide the selection and acceptance of grafts and donors, and most importantly, it helps to decide logistical and resource planning. If we anticipate difficulty, we would probably plan to do it at a time when senior members are available or our entire support system is in place. So I'd like to break this down into 5 points here: recipient factors, donor factors, logistics, system readiness, and surgical skill. What are the recipient factors that may interfere or influence surgical difficulty? Firstly, age. No matter what we say, age is a factor. The older a patient, the more the less able they are to handle complexities and, more importantly, complications. Frailty is coming out as an important marker, and rightly so. Most of the patients we operate are on a sarcopenic, and certainly a patient where we are expecting multiple comorbidities who also has sarcopenia would be somebody in which you could think about difficulties. Obese patients, we are seeing a lot more of these, and certainly this adds to surgical complexity and difficulty. Surgeries, comorbidity, and MELD score is decided. Other recipient factors, the presence or absence of ascites. Sometimes the presence of ascites is actually a good thing because it increases the abdominal domain, makes your dissection a little bit easier, and helps to do an easier explant. However, if you've had multiple episodes of SBP, that can increase the number of adhesions that you see inside the abdomen and make for a complex explant. If you had a TIPS, in fact, TIPS patients are actually more difficult to do explants in because typically the collaterals close up and they tolerate portal vein clamping much more poorly. So certainly the presence of TIPS is actually a relative problem. And the status of the patient, if you have ALF, ACLF. The indication for transplantation. Now, if you have a patient who has cirrhosis and portal hypertension versus a patient who does not have portal hypertension, then the implications are quite different because both these patients handle portal clamping very, very differently. If you have a patient who has an anatomically normal liver, which you then do a portal clamping for, these patients will tolerate that very, very poorly. What other factors are you looking at? When you look at the imaging, if you have a very large liver, for example, in a pediatric situation, in a cholestatic liver disease such as biliary atresia, or a PSC liver, you can anticipate a difficult explant. If you have portal thrombosis or cavernoma, this will come up again and again. These are factors that will make for a difficult explant and an implant. If there has been previous intervention, or if you anticipate the need for cable replacement because of a large chordate lobe. One new factor, of course, is that we are seeing a lot of patients who come to us through the transplant oncology route. Dr. Madhu talked about it very briefly. So there are patients who have had neoadjuvant chemotherapy and radiotherapy who will come to you with fibrosis around the porta, for example, which can lead to a difficult explant. So the first score that I'd like to talk about is a score that encompasses these. This paper actually came out of France. This looked at a difficulty score, giving a score of 0 to 10. And essentially it picked out 5 factors: retransplantation, that is late retransplantation, ascites, a portal vein thrombus, an annular chordate that encompasses the entire IVC, or the presence of TIPS. And as you can see, there's actually quite a nice correlation between the morbidity that you see on the left and the mortality, the risk of mortality as the difficulty score rises. But as you can see, even from when the difficulty score is 0, there is a very wide spread of morbidity and mortality. So clearly, while complexity is one factor that affects mortality, it is not the only factor. Looking at donor factors, of course, it matters significantly if you're talking about a DDLT or an LDLT. The graft size is important. Large grafts are difficult to handle in a DDLT setting, especially if the abdominal domain is small. But also, paradoxically, a very small graft can be a problem. Because after doing a cable if you're not doing a cable replacement, for example, the graft can fall back and cause a kinking of the outflow. Has there been any previous surgery? Is there any aberrant anatomy? Or has there been any damage during retrieval? When we talk about damage during retrieval, this is actually quite a common problem, especially in systems where retrievals are done by teams that are different from your own. This study came from Netherlands. Actually, it reported a 6.6% damage of organs which were retrieved by other teams. And when damage included arterial injury, it caused a heart injury rate of almost 23%. This study was further carried on by the entire nationalized Netherlands system. And over a 10-year period, they identified a high BMI, aberrant anatomy, a DCD donor, and male gender as factors that were associated with damage of the organ during retrieval of the organ. And in fact, this was a significant problem because 4% of the organs that were retrieved with damage could not be transplanted. So there was almost a 4 to 5% loss of grafts because of a damaged organ. I shan't talk too much about the DRI or the European equivalent because these are more generic things. They don't specifically talk about surgical difficulty, which is actually the point of the topic. So what about living donors? Of course, it depends whether you're planning a right lobe or a left lobe, whether it's open robotic, whether there's aberrant anatomy, arterial veins or bile ducts, if there's a complex reconstruction planned, or if there are additional procedures planned such as flow modulation. So a paper from Dr. Srinivas Reddy himself looked at the difficulty score of a right donor hepatectomy, and essentially they defined difficulty as a longer operating time or transaction time, blood loss as well as vasopressis. And they of course found that difficult hepatectomies had significantly more perioperative morbidity. But more importantly, they found that the size of the right lobe, a diameter of greater than 14 centimeters, was the best predictor of a difficult donor hepatectomy. And this is a theme that we see even in the laparoscopic era. This is a paper from Japan that looked at left lateral segmentectomy. So the surface area that people had to transact between the right and the left lobe, obviously the more the surface area, the more difficult the hepatectomy was. So by logistics, again, this is something that I'd really like to get some inputs from the crowd about. There are obviously two aspects to this. When we have a DDLT, where are we doing a retrieval? Are we doing a retrieval in our own hospital? Are we doing a retrieval in a peripheral hospital? Clearly, the systems that are in place that will help you alleviate surgical difficulty are more well developed when it comes to your own hospital versus if you're traveling outside to do a transplant. These things impact the cold ischemia time, which can increase the reperfusion injury. How well are you coordinated between your donor and recipient teams so that you can actually time your transplants better? Now, regarding implant, again, this is something that I know that many teams transplant in multiple centers. Is there a system of triaging that needs to be put in place? For example, if you have a simple implant, a relatively straightforward implant, it can be done in a peripheral center. And if there's a complex implant, whether it should actually be referred to the primary center. This is something that probably teams that operate in multiple hospitals should think about. What is the level of difficulty that they would accept in a home center versus a satellite center? Now, system readiness. This is an interesting paper that I'd like to talk about. This is a paper from Taiwan, covered 14 years of almost 3,000 recipients. Now, it's always the question, isn't it? Is it the dance floor, is it the dancer? Is it actually the surgeon, or is it the system that actually is important? So they actually looked at this in great detail. They looked at high volume surgeons who had done more than 100 transplants versus high volume transplant centers which had done more than 300 transplants. So they followed the system where they narrowed it down to the distinguished patients who were operated between high case volume surgeons and patients who were operated in high case volume hospitals. And surprisingly, or perhaps not surprisingly, both were important. When you look at the high case volume surgeons, they had a much better survival as compared to low case volume surgeons. And the same thing with hospitals. The high case volume hospitals actually had a much better survival as compared to low case volume. So definitely case volume is a surrogate marker for perhaps preparedness to transplant to report complications. There have been a few composite scores that have been proposed in order to assess the level of difficulty of a transplant. We already talked about one from Caetano, that they all have come from France actually. This is another one, this came from Barcelona as it happens, where they've identified 4 factors: retransplant, preoperative PVT, previous upper abdominal surgery, and SBP, 5, and prior variceal bleeding as risk factors for a difficult transplant where you could anticipate difficulty, for example, for DDLT. Another paper from Dr. Azule, where they actually defined difficulty as the number of blood transfusion units used, cold ischemia time, and the duration of operation, where they also identified previous abdominal surgery, ICU admission and use of split grafts, non-standard arterial reconstruction as predictors. The most comprehensive score came from Hospital Saint-Pietre, which was actually a group from France, 987 centers from 5 centers. They actually came out with a very, very elaborate score, which looked at all the different domains we talked about, preoperative, perioperative, and donor and recipient factors, and came out with a score. But just to show the difficulty of these composite scores, the highest mortality was reported in the moderate difficulty level, not in the high difficulty level. So obviously there is no linear relationship, much as I would like it to do. I'm going to spend the last 2 minutes talking about surgical skill. That's a very, very nebulous thing. How do you define surgical skill, and how is it actually quantifiable and measurable? How does it actually contribute to surgical outcome? It's very surprising that there are so many papers across not just transplant, which actually don't account for surgical skill. Like we have all these papers looking at outcomes after colorectal cancer. Nobody talks about surgical skill as a predictor outcome when we know it's such an important outcome. And the first study that I can think about which actually looked at the European data was the Bonnekamp study on D2 gastrectomy, where they actually standardized for surgical experience before they actually did the randomization. So surgical skill, how do you define it? It's like the definition for obscenity, right? I know it when I see it, but it's very, very hard to actually define what surgical skill is. So the definition of surgical skill actually is a very surrogate thing. The operative speed, the number of blood transfusions used, the length of stay, the morbidity, mortality. As the Bible says, right, you should know them by their deeds. Actually, you know them by their outcomes rather than actually as a direct measure. And unfortunately, there is no direct measure of how what surgical skill says here. But what we do know is that surgical skills can be taught. We know that people who are put through a structured training program will improve their outcomes, whether it comes to organ retrieval or when we train transplant surgeons in a virtual setting. And this is something that we have tried to do in the course that we run. We have run the course now for the last 11 years in Bangalore, which actually focuses on organ retrieval. Over the last 2 years, we have developed our own homegrown trainer, which you can see is a plexiglass monitor. These are silicone models of the liver as well as arterial and venous anastomosis. And the plexiglass system is basically to simulate difficulty in suturing, so that you can see here, this trainee is actually bending over to actually do a cavostomy. Somebody is retracting the liver for them, and they are actually replicating their movements. So they are trying to do a side-to-side cavostomy. The red tube and the blue tube are actually the donor and the recipient cavas, not the aorta and the IVC here. So we looked at the results, the satisfaction results of these 25 patients, of these 25 people who went through training through the simulator. Most of them felt that the anastomosis replicated real life. The vessels were easy to suture. And although a lot of people disagreed on whether it was close to normal tissue or not, everyone agreed that this should be included in future courses. To summarize, surgical difficulty can be anticipated. Anticipating difficulty is preferable, because if you anticipate difficult cases, you need to have your best team on the job, make sure that you're operating at a time when your resources are available in a center that can support complexity. Most measurement tools are surrogate. Measuring skill is difficult, but what we know is that surgical skill can be taught. Thank you so much for your time.
Thanks, Sonal. As usual, a very comprehensive talk. I think I tend to divide difficult transplants into the ones that are difficult at the time of doing the operation, like previous additions, and the ones that are difficult for the entire future life of the patient and the graft, like, for example, a portal vein thrombosis. And I think the key is, as you grow, the technical difficulties become less. But I remember losing a patient because I could not get portal flow because I had not prepared well enough. So complete portal vein thrombosis, have a backup plan as a, for example, a renal portal, have a backup plan to that as a cable transposition. Otherwise, you'll end up in a situation where you have a warm graft, no inflow, and things like that. So I think what you said is the key, preparation. Great talk. Any questions?
If you look at pancreatic surgery, initially Vipul's giving very high mortality. Then there are landmark trials came, high volume center, give a less mortality. Look at the same way, this is also one of the complex surgery. When you see that recipient factors and donor factors indicating it is a high risk case, that type of surgery should be done a better high volume center or better experienced surgeon, that it will give a good results. So
Sure.
look at always as a overall, recipient factors, donor factors, and surgeon or hospital volume, it decides. if your center is not at all a high volume, at least senior surgeon should do that type of high-risk cases.
Sure. Now, I think one of the things that the reason why I think this talk was given is because we are planning a study called the Living Donor Risk Index using the Indian Liver Transplant Registry, where for the first time we are trying to look at adding the element of skill and surgical complexity as a variable. Like, for example, the data that we capture is number of arteries, number of veins, number of reconstructions, high volume versus low volume center. So we are trying to incorporate that into an AI model that will tell us what is the risk for an individual patient. And certainly as the LTSI, I would like to see perhaps a preceptorship model set up where if we can identify such patients in advance, people can call out to centers that are more experienced to perhaps ask senior surgeons to come in and help. And that would probably be a much more enabling model ecosystem for all of us.
Thank you.
Thank you.
Next, I would like to call Dr. Abdeep Chowdhury from transplant surgeon from BLK Max Super Specialty Hospital. He's the president-elect of current LTSA, and his topic would be on managing portal vein thrombosis in liver transplant.
Hi, thanks for the invitation, Dr. Srinivas Rajgopal. And continuing from the last talk, it is actually important in all those aspects to get a safe surgery. If you are prepared well, you know what you are dealing into, and all the surgical and hospital factors. And this becomes even more important when we are dealing with something like portal vein thrombosis, and because getting the right amount of portal flow is very important for that liver to work. Particularly in live donor situation, the right amount is even more important because too much of flow can actually damage. But here in the situations of portal vein thrombosis, the problem is trying to get the adequate flow, preferably a physiologic flow, which I'm going to talk about what I mean by physiologic flow and how we can achieve that. So it is a significant problem in terms of liver transplant, and the reason because of that, till 80s, it was thought this is a contraindication for liver transplant. Anyone having a portal vein thrombus should not be transplanted. Till 1985, the first case of portal vein thrombus was done by Professor Starzl, and he published. And after that, people started looking at doing more and more complex situations. But you know what? How much is the problem of portal vein thrombus? In a well-compensated cirrhotic, obviously, the incidence is less. But as the cirrhosis advances, around 7 to 15% of these patients end up having portal vein thrombus. And to the surprise, at times during the surgery, you get an unexpected thrombus which was not there when the patient was being evaluated, and that is a bigger problem to have. Now, portal vein thrombus has been classified depending on the extent of the thrombus in the vein and how many collaterals and the quality of collaterals around. Most common classification which is used is Yerdle classification, which looks at the extent and how much blockage. Like if it is involving the portal vein with less than 50% obstruction is grade 1, 2 is more than 50%, then extending into SMV, complete SMV. But what it does not tell you is the surgical decision making based on this thrombus. But still it is most commonly used in terms of comparing the outcomes and analyzing what is to be done. Two other classification models, particularly Jemison, and works on whether there are additional collaterals in terms of NAT. So grade 3 and grade 4, according to Jemison, is involving the entire SMV, but with good collaterals available is 3, but with no major collaterals available is 4. But again, all these classifications do not look at another major component, which is SMV thrombosis. Now, another important aspect of portal vein thrombus is it can be progressive. So patients who are cirrhotic being seen in the clinic should be evaluated for portal vein thrombus. And if there is a progressive disease, it should be, or there is a high risk of possibility of getting a progressive disease, these patients should have anticoagulation or a TIPS should be considered. I'll be talking more on the TIPS component in terms of portal vein thrombus, where the role of TIPS is increasing in managing, in correcting the portal vein thrombus as well as in the pre-op settings. So as I said, wherever possible, anticoagulation or TIPS, until unless there is a contraindication. Now, what are the problems of portal vein thrombus when we are doing transplant? Definitely the dissection of the porta becomes difficult. There can be a lot of bleeding. There will be inadequate flow to the graft. Patients who have portal vein thrombus, there is data which suggests they have a higher chance of getting hepatic artery dissections as well, and the length of the portal vein, even if you do a thrombectomy, is smaller. So technically a difficult surgery to do. Now, as I was saying, there are two ways a surgeon can get exposed to portal vein thrombus. One is an unplanned scenario where when the patient was being evaluated, the portal vein thrombus was not there, or due to renal dysfunction and all, the angios were not done and it was a surprise at the time of surgery. Second is a planned scenario where you know there is a thrombus and you know the extent of the thrombus, which is comparatively, even if it is a higher grade, you go planned and you are able to handle it well. So most important thing is going planned whenever you are doing a patient with portal vein thrombus. Now, what are the goals? What do we want to achieve? Is an adequate portal flow? The best way to do it, somehow recanalize the portal vein, either pre-operatively using a TIPS, or on the basis of scans, you can assess whether you can do a complete thromboendarterectomy, or you can somehow get a physiologic flow coming in through the splanchnic circulation. And for this, very important thing to have a multidisciplinary team with involvement of surgeon, hepatologist, and intervention radiologist work together to make sure the decisions are done when you're managing a complex portal vein thrombus. Now, going grade by grade 1 and 2, most of these cases you would be able to do a thromboendarterectomy and able to get a good flow. And these patients should be continued on anticoagulation for at least a few months after the surgery to make sure there is no rethrombus. There are various operative techniques which have been defined. You can remove part of the vein along with the thrombus and suture it, or you can do a eversion thrombectomy where you can remove the thrombus from the vein, and for that various ways, various techniques have been designed. There can be eversion. You can use a spatula. Most commonly, what we do is we use a Watson chain instrument to separate the thrombus from the wall, and you keep on going down and take a proximal control using either by finger pressure or mobilizing the vein and get the thrombus out. In some situations, you might have to add on a balloon to remove the residual thrombus as well, which our intervention radiologist helps us in doing it ultrasound guided. So similar thing can be done in 3, but in some situations you are unable to remove thrombus or the portal vein becomes atretic. You can use a jump graft from SMV if the SMV is patent, or a graft from splenic to get the inflow. If you have a cadaver graft, a recent cadaver graft that can be used in our center, we do mainly LDLTs. We end up using the Dacron graft in this kind of situation to take a graft that goes in the mesentery of the colon and anterior to the pancreas, and that is used for anastomosis. So as I said, residual thrombus can be removed by the intervention radiologist on table using either a Foley catheter or a ERCP balloon. The Fogarty balloon is usually soft, unable to remove those thrombus, but ERCP balloon works very well in these kind of situations. And you make sure you get a good flow by doing that. And so doing this on table is a little challenging, but then once you get adapted to these kind of technologies, it is still possible. Now the most challenging ones are the grade 4 when the entire SMV is gone. Now you have to look at the options where to get the flow. So either you have a major collateral, which in 30% of the patient you might see a nice pericholedochal collateral which is there, which can be used, or there is a prominent coronary vein. These are the two major inflows which can be used. The coronary vein can be directly joined with the portal vein, or you can use a interposition graft to do that. This is one such case where the coronary vein was divided and was implanted. And the Verix is something which is very important in Verix is when you're using Verix, you make sure you do not separate it from the bile duct, because the surrounding tissue actually becomes the supporting wall. Otherwise, the varices are very thin. If you try to separate it, you might not be able to use it. So keep the ductal tissue around intact. What we do is we avoid doing a duct-to-duct anastomosis, although some centers still use the duct to do duct-to-duct anastomosis in those situations. We prefer to do a hepatococcygeostomy in these situations. Now, there are situations when there is a significant splenorenal collateral which is there, or you can use a left renal vein in those situations to provide inflow to the graft. Or if there is a small segment of renal, splenic vein which is patent, you can put in a graft between the splenic vein and the renal vein, and then use the renal vein as a graft in particularly Yerdle 4 portal vein thrombosis. But somehow you have to make sure there is inflow going on. Although the results are pretty decent when you have a major splenorenal shunt available, only problem in these situations is the correction of portal hypertension takes a longer time, ascites remains for a longer time, and slightly higher incidence of renal dysfunction which happens in these patients. But the problem happens in the situation where there is no major flow going to the left renal vein. Although there is an entity which has been described as a siphon effect that happens if you use a renal vein, the collateral slowly, gradually, but then that is playing with the luck. Might happen, might not happen, and these patients might end up not doing so well. So these are some of the alternatives. So whatever we have done till now is physiological, where we are able to divert the splanchnic flow to the liver. But in certain situations, particularly in unplanned situations where you get in and there is nothing of that sort available, either you do a cavoportal where there is no major mesocaval shunt is there. If there is a good mesocaval shunt, the cavoportal anastomosis works well, and which Zakis has first shown in 1995 that had worked very well in first set of patients, but later on in their own series, they showed all the grafts had a graft failure after that. So it is only when you can demonstrate a good collaterals going in, it works well, and other than that, it's a problem. And last and salvage situation is portal vein arterialization, which hardly works. It is basically playing with fire. If you're lucky, you might get away with it. And these are again the unplanned situations where you get in, because a lot of arterial flow going into the portal vein lead to more of fibrosis. So in these situations, if you know this situation well, the role of tips becomes very important, and which Shanavas was showing some of his cases like EHPVO, the similar thing can be done in these patients planning for transplant. Even if you have a small segment of splenic vein, you can go transsplenic, open up the splenic vein and portal vein using multiple balloon angioplasties, and then put in a tips, and you can actually do a transplant 4 to 6 weeks later, and which is much better outcome compared to going in with no major collaterals available. So this is one such patient where only a small segment of vein was there, splenic vein, transsplenic, and the stent was placed, and the portal flow could be achieved. Now, the last resort in these patients, when you know there is extensive thrombus involving everything like SMV, splenic, the desperate situation is a multivisceral transplant. That is the only option to actually salvage these patients. So to summarize the portal vein management, this is actually a good table which Prashant has published in Journal of Hepatology, where looked at what are the preventive modalities which can be done, and if those preventive modalities, they have included tips also in that. And if there is a failure, depending on what grade, I mean, I pretty much talked about all these potential options. But this is one chart I felt could be a good reference chart to be kept in when taking up patients for portal vein thrombus. Another important thing to be kept in mind is you have done a good surgery, you've got a good flow, but these patients have a higher chance of recurrence of portal vein thrombus, whatever you have done. More so in those cases where you have done an extra anatomic inflow. So recommendations are, if you're doing extra anatomic inflow or there is a procoagulant stage, put them on a lifelong anticoagulation. Otherwise, you can have them for a short-term anticoagulation, and you can have the outcomes pretty decent. Only in 3 and 4, the overall outcomes are pretty inferior compared to the patients with no portal vein thrombus. In 1 and 2, you can actually have the outcomes similar to patients with no thrombosis. So we looked at our data as well, 5 years, 860 transplants. We looked at 800 transplants. 138 had portal vein thrombosis. Most of them 1, and Yerdle-4 was in 7 patients. Most of these patients we could get away with removing the thrombectomies. And but when we looked at our long-term survival, other than Yerdle-4, our survival was same as patients with no portal vein thrombus. In 4, we had a 3-year survival of 71%, which is actually comparative to the literature. But then I feel going further, more and more, if the TIPS is being used, we can have even better survival. So my takeaways from today is advanced portal vein thrombus is no longer an absolute contraindication. Important thing is you have to customize the inflow reconstruction techniques, and a multidisciplinary team approach with hybrid endovascular and surgical approach is most important thing to manage advanced or complex PVTs. And then post-op care is also important in these patients. And I would like to invite you all for the upcoming annual conference of Liver Transplant Society of India in November in Delhi this year. Thank you.
A very nice and comprehensive talk, sir. It's completely covered the entire spectrum of portal vein thrombosis and the management. Preoperatively, when you said you want to, when you are evaluating such patients, do you get a clue from the imaging, like whether there's soft thrombus or a hard thrombus, and then plan accordingly, during surgery?
So if there is evidence of chronicity, if there are a lot of collaterals around that area, if you see a calcification, you know it is going to be tough. But if you see a vein which is pretty much on a scan, if you see a normal thickness of the vein, you know it is a recent thrombus, and it will be easy to remove that.
Yeah, just one comment. During our Pittsburgh time, Professor Stargell has given one on-table measure to get away low portal
You are not
flow.
audible, actually.
Yeah. So whenever you do a coronary vein as an inflow to the liver graft, if the portal flow after putting a Doppler is insufficient, so searching for a collaterals ligation in the background of Yardel's grade 4 portal vein is very dangerous. So he has given us some trick, we still follow that. What he used to say is partial clamping of the IVC with and without clamping. See that portal flow with the this what is called coronary vein flow. If the partial clamping of IVC, the coronary vein flow to the liver graft is increasing, means there would have been a significant shunts are there. He used to recommend us to do routinely ligate the left renal vein to augment the collateral flow. So we still follow. That is easy because we have seen some of the time searching for collaterals in the background of extensive, making a bloody areas in multiple areas and coagulopathy, and you have to start anticoagulation. So he used to put a partial IVC clamping see that portal flow is increasing, that means you ligate. If it is not increasing, don't do anything.
That's actually a good way when you have not done a scan preoperatively, but if you have done a scan preoperatively, most of the time any major shunt you would be able to see, and you will go plan and make sure you ligate those collaterals to get adequate flow. And one of the reason of portal vein thrombus, if we look at that virtuous triad, is the slow flow, and somehow you have to make sure it's adequate to the extent that people say that you should ligate as many collaterals so that there is no chance of any diversion. Just in case there is a graft edema happens, it should not lead to diversion of the flow, and that to give an optimum amount of flow to the graft.
I have a question. With these tips, these are all CLD patients. Are you not having much incidence of encephalopathy?
Sorry?
With the pre-operative tips technique, are you not having much encephalopathy issues?
So it is like when you're doing in this kind of settings, and your aim is to do the transplant in next few weeks. And so even if, so this kind of tips, and Shanawaz is here, he can also talk about it. Even if someone has a history of encephalopathy, this tips is still advisable to get, because getting a good portal flow is most important thing. Another thing which is said is, if you see a patient with a portal vein thrombus and has a major shunt which is there and is going into encephalopathy, don't ligate those shunts, because those shunts would be the only flow which is going to be available for you when you have to do the transplant. So I think even if someone has a grade 1 encephalopathy, you still go ahead and do those tips, because getting a portal flow would be more life-saving than...
I understand. One of the things that... sorry.
Yes. So depending on what is the platelet count, how much is the coagulopathy that exists, and what are the variceal status, that is something we'll look at. So most of the time after tips, the variceal status comes down, and if the platelets are pretty low, INR is high, you don't need to anticoagulate, except on table single dose of heparin that can be given. But then if you're planning a transplant few weeks later, it is not required. Unless someone a platelet count is higher, you might have to, or a procoagulant state. You'll have to balance the pros and cons. Not really, not really. Sir, you were saying something. Sir, you were saying something. So, sir, I think only situation is if we can't see any potential vein which can be used to give physiologic flow, and my IR guy says he cannot do any stenting, maybe that would be the only exceptional situation. Sorry?
No, there is one Brazilians given this question answer. What they say is that Yardell's grade 4 portal venous thrombosis, where preopacity not showing any significant collaterals or shunts, but patient is having a mesenteric pain, additional. So what we are thinking about gastroesophageal varices territory only, but SMV territory. So what they say is that Yardell's grade 4 portal venous thrombosis plus no significant shunts or collaterals. In addition, patient is having abdominal pain, typical like mesentery. Such cases, they have listed for a multivisceral transplant.
That's understandable.
One of the new things that I don't know how many of you are doing it, the portal face of the CT, now I'm getting 3D reconstructions. Because if you look at it on an axial or a coronal, sometimes you don't know which is actually entering the renal vein. So if you do a 3D recon, you can keep rotating it and make sure in all planes the anastomosis is where you think it is and the shunts are where you think it is.
So that is what I say. This is actually a multidisciplinary thing which has to be done. Your radiologist, your interventional radiologist, I would say, is the backbone of doing these kind of cases successfully.
What would be your post-op management protocols in looking at when you are doing a shunt, or when you are trying to do anastomos with a collateral, let's say, how worried you would be in the post-operative that the shunt would be functional or non-functional, and how would you monitor those patients?
So in terms of anticoagulation or
in terms of anticoagulation, also in terms of Doppler studies or imaging?
Dopplers are as it goes as per the protocol that we follow, and but anticoagulation, yes, we start anticoagulation if there is something zonal. We'll look at the TEG, and if permits, then we'll start the anticoagulation on table. And but if there is obviously a lot of ooze and all, we'll wait till next day. And as soon as possible, our protocol is we start the low molecular weight heparin. Fragmin is our preferred drug, and we start this on an IV infusion. So we started as for an adult 2500 IU over 24 hours. That means around 100 IU per hour. And then I mean the advantage of using Fragmin infusion is you don't have to look at APTT monitoring, and it works pretty well in these situations. And then maybe then shift to Xarelto after.
Sir.
So if I mean if I use collateral, I wouldn't use the bile duct. I would rather do a hepatogenostomy. Yeah. So what? Yeah. So in patients who have a lot of collaterals, particularly large linorenal shunts, these patients usually till the end do not have significant bowel edema. So kind of working very well on that.
Dr. Abhideep, see, when this is very, very practical issues that we face when we use these collaterals. Like you said, you're doing hedges in these patients. The bowel function itself is very delayed. If you see in these cases, they go into that bowel edema is there, and they don't tolerate feeds. We need to put them on TPN. There's a lot of translocation happening, sepsis, blood cultures become positive without even any surgical issue. So do you face these kind of things in patients when you use these coronary veins as inflow for?
Actually, if I have to tell you, we are a very low threshold hepatogenostomy unit. It is not just this. I mean, if you have two ducts, we'll make sure one is joined hepatogenostomy. I wouldn't use the duct for PSC. And if the recipient side of duct size is smaller than the graft, I would do a hepatogenostomy. So I have a very low threshold of going hepatogenostomy, and that has worked very well. And that is something which our anesthesia team has actually worked very well on that. So what they do is they keep on a very low fluid anesthesia, and that is something which is now submitted for publication as well. And all the boluses are given after the hepatogenostomy is done. So that actually helps significantly in keeping the bowel edema under control. So we actually are able to get a significant non-edematous bowel in most of these situations.
In the post-op period also, I mean, in our experience, we have seen there's a lot of, I think some amount of mesenteric is like congestion is always there in these kind of patients, and they give a lot of trouble post-op. I'm sure you faced it also.
So, I mean, as I said, the IV fluids, which we have seen a drastic change which has happened, and secondly, early portocable shunts. These are two things which, in a routine case, so that has worked very well.
And Dr. Abhideep,
no, I wouldn't say bad anesthesia. I would say fluid-restricted anesthesia.
I thought all complications are anesthetic.
Dr. Abhideep, any insights on doing a recipient hepatectomy in people with grade 4 PVTs and all? Recipient hepatectomies in people with grade 4 PVTs. Do you have any special techniques? Because they are very frozen portas, lot of collaterals, very difficult recipient hepatectomies. What do you practice in your
So, particularly in situations like the collateral, my preference is to go around the pota, and this is something I have seen people from Seoul National doing that. So I just passed a elastic sling and twice and just pull it and just cut and then try and separate the artery after that. Because if you are doing the dissection on an early phase, it bleeds a lot.
I think if there are no more questions.
Yeah. Thank you. Thanks a lot.
Next, I would like to invite Dr. Professor Subhash Gupta, sir. Liver transplant surgeon from Max Hospitals and past president LTSI, to give a talk on complexities and complication in arterial reconstruction.
This is not my talk.
This one.
Thank you very much for giving me this opportunity, Dr. Metu and Dr. Rajgopal, with whom Rajgopal particularly works for so many years. And good to see Dr. Ravindranath here on a Sunday. He's a very busy man. Thank you for being here Okay. So I think complexities in liver transplant and complicated liver transplant is side by side. I think liver transplant and complexity and complication cannot be separated. So this is the basis of my talk. So this year we completed 5,000 transplants, and most of my talk is from what we have learned. So the outline will be changing perspective, disease donor liver transplantation versus living donor liver transplantation, adult versus pediatric liver transplantation, microscope versus loops, techniques and prevention, single versus multiple reconstruction, arterial dissection, which is the bugbear of liver transplantation, particularly when you are coming to the end of the operation, our own experience and a summary. So the perspective is that hepatic artery thrombosis used to be a devastating event for the patient, but I must say it was more devastating for the surgeon because it was clearly a technical event. So you could feel sorry for days or, would not be happy for many days. The quoted incidence is varied between 2 to 9% with a graft loss of over 50% and patient mortality of 30%. And technique, I said, is important. So what has happened over the years? Now, it used to be an indication for retransplantation, as therefore included in the super urgent list. But many of these patients have been salvaged by surgical OIR revascularization. However, even with prompt revascularization, biliary necrosis and abscess will occur. And this is because the blood supply to the biliary artery is predominantly from artery, and prolonged hospitalization is the usual course. Fortunately, with experience, the incidence has come down. Now, with DDLT, you have advantage of big, long arterial branches and bigger anastomosis. You can do a continuous anastomosis, which Dr. Sudhi, my friend, always keeps saying that you should do continuous, not interrupted. And in LDLT, the vessel diameter is smaller. However, you can occasionally create a patch with the cystic artery. And the interesting thing is that centers which do living donor liver transplantation as well as DDLT thrombosis rates have also come down. And LDLT experience of vascular reconstruction has been extended to reconstruction of vessels in gallbladder cancer and Klatskin tumor, which Dr. Madhusudan, I see him present in all the meetings, showing how you can use technique from one into another area. So what about right lobe versus left lobe grafts? Right lobe grafts usually have a large artery, but it's important to recognize intercommunicating arteries, which Professor Rajan Saxena, when he was in Cambridge, he showed them very nicely, that you often have a suprahilar vessel connecting the right to left side. Also, it's important to remember that segment 4 artery will never come from a replaced right hepatic artery from SMA. And occasionally, what you think is one artery actually branches early and goes above and below, anterior and posterior to the bile duct. And so you have to be careful to recognize that. And this is what you can see here, that there is early bifurcation and it's going above and below the bile duct, and you will end up with 2 arteries. On the left side, it's the norm, I think, to have multiple arteries. You're very lucky if you have a single vessel there. And this is one example of an intercommunicating artery that you see between the right and left systems. And it would be wrong to think of this as supplying a particular segment. So multiple arterial anastomosis generally we prefer, and I read an interesting paper from the Asan Medical Center which showed that 0 thrombosis rate when they reconstructed all the arteries. So that's amazing, I think. And that's why I think we buy insurance by reconstructing all of them. What about adult and pediatric recipients? Traditionally, pediatric recipients were thought to have a higher thrombosis rate. That may be true in non-portal hypertension cases, but generally if the transplant is for a portal hypertension indication, then the hepatic artery would be hypertrophied. The donor is an adult, so you actually have good caliber vessels to join. The portal vein thrombosis in these small children are a bigger problem, and of course we as a group connect all arteries, but really, I mean, you can not do it as well. We do a large number of domino transplants, and sometimes this poses a big problem because these are usually from MSUD recipients, and if you divide them distally, then you may end up with multiple arteries to join. And also in the domino the MSUD child, you may end up with a very short stump of recipient artery because you were tempted to take both the right and left as a single artery. What about impact of donor quality on hepatic artery thrombosis? Older donors will affect whether it's from the artery is wrong or whether the graft function is poor, diabetes mellitus, steatosis, and smaller grafts I think probably have a high incidence of hepatic artery thrombosis. Unfortunately, this has not been studied much, but I think it does happen. And the factors such as cold and warm ischemic time of the graft, donor recipient artery size mismatch. I think this is the fundamental to preventing hepatic artery thrombosis, size mismatch. Recipient age less than 1 year, low weight of the recipient, and of course ABOI, living donor liver transplantation. But really, although it gets quoted in literature again and again, but in our own experience of huge ABOI liver transplantation, this really has not been a problem. What about size match? One area where you have to be very careful is people who, when you're transplanting for alcoholic steatohepatitis, they have really large and thin arteries. They're actually like portal vein, and your stitches can cut through and you can get into a lot of difficulty. A variety of techniques have been described for size matching, fresh mouthing, spatulating, and we have not used any one of them because you often will have a variety of arteries of appropriate size, left hepatic, left to right gastric artery, gastroepiploic artery, to get a size match. Sometimes if you carefully trim all the sort of tissue around the artery, you can thin it and you can get good size matching. And if you really have a short stump, then you can extend it on the back table using the recipient's hepatic artery alone. What about etiology on hepatic artery thrombosis? Pediatric acute liver failure are predisposed to higher incidence of hepatic artery thrombosis because obviously these are without portal hypertension. Similarly, metabolic liver disease in children are prone to portal vein thrombosis, to hepatic artery thrombosis because the lack of portal hypertension prevents arterial thrombosis, and domino sort of recipients have to be very careful, plan it well, otherwise you can end up with hepatic artery thrombosis. What about minimally invasive technique? In the beginning, we had a sort of increased incidence of hepatic artery thrombosis, and then I took a cue from Dr. Sudhindran, and we started flushing these hepatic arteries with heparin, which we were not used to do it before, and that seems to have come down. And also important to recognize favorable anatomy to help you in reconstruct. One of the important things is that when you are, for example, if you replace right hepatic artery and doing a retransplant to somebody with portal vein thrombosis, then it's important to factor these in so that you can join it easily. Now, if you divide the artery distal to the branching, then you're going to avoid dissection, and also you may allow for a patch. The patch is not important to increase the size, but what the patch does is that at that point the artery tends to remain open, so it's easier to take stitches from that. You will prevent backwalling. So This is a very important point actually, and we will spend some time in finding a branching of the vessel so that you can take the stitches easily. And if you're retrieving from a donor, you have accessory left artery from the left gastric artery, you can take that, you can go down to the left gastric artery so that you get a bigger vessel to join. So multiple arteries, as I said earlier on, are very common, and in our pediatric, this is 2024 data, we did 59 pediatric transplants. 17 of the donors had multiple arteries, and in fact 4 cases with 3. And overall, out of 473, we had 10% had multiple arteries, and we reconstructed all of them. Then you can, if you're careful, you can look at posterior sector vessels, and there you can see nice artery, portal vein, and biliary, which is separate. And these situations, if you recognize them, then you can decrease your arterial complications. What about microscopes and loops? Both, I think, give similar results, though the literature seems to suggest otherwise. But there's a sort of a difference in philosophy. Very high volume centers, particularly in Korea and Japan, the senior surgeon will leave after reperfusion. Whereas here in private sector, where most of the transplant is, you need to stay till the bile duct stitches have been placed and or the last stitch has been placed. Otherwise, you might give the wrong information to the relatives that operation has been a success. So you have to stay. Therefore, loops become a logical way to deal with it. And in the beginning, when we involved plastic surgeons, it was, they were unwilling to come at late hours, so we had to learn to do it ourselves. But you look at the literature, then obviously microscope scores better than loops, but I think loops are a good substitute. Poor recipient artery quality in high-risk groups, those who have had TACE, multiple TACE, single TACE probably will not do anything, SBRT. But the difficulty we have in this, in the combined liver and kidney transplant, because that's the only group where the hepatic artery can be sort of diseased. And preparation of the artery is the mainstay for successful reconstruction. Avoid holding and crushing the intima with microforceps. Sharp cut to align all the layers. And staggering stitching technique has been suggested, but I don't know. I have no personal experience of it. So this is somebody scanned from somebody with a combined liver kidney transplant. As you can see, even in the sort of this calcified artery in the hepatic artery, that's the only group where you can, and you magnify it again, you can see every single vessel of the artery was calcified. So this required real special technique to deal with it. Now coming to arterial dissection, recipient side, I think complete portal vein thrombosis, this is where it happens the most. Stitching a bleeding point on the artery, hepatic artery, without proximal control. To recognize quickly and clamp proximally. And when you're tying it, bear it, so that when you tie with a minimal force, you don't crack the intima, because usually where you crack the intima, it goes sort of retrograde and makes it worse. So in the past, it used to worry us a lot, but now we just go and just stitch it to the dissected artery, and we publish this as well. And it seems that the important thing to realize here with dissection is that particularly with donor arterial dissection, it's a disastrous complication. Prevention is very important. And I think when the donor artery is dissected, we tend to join without cutting back because it becomes almost impossible. Now, one important thing that we learned from our experience that if you join to a dissected artery, your Doppler signals are going to be absent because there's stagnant blood on the flowing blood and the Doppler signals won't pick it up. So if it's pulsating outside, be happy with it. And in one case, we arterialized it, and I think one of the speakers said that it's not a good option, and I agree with that as well. So hepatic arteries is spared in atherosclerosis and vasculitis, but long-standing CKD, you're doing combined liver and kidney, then you have to be careful. Large hepatic arteries of alcoholic steatohepatitis, and of course, there can be sometimes technical difficulties, a oozy field, a lot of depth, sutures are cutting through, and sometimes this is a bigger problem. What about reconstruction in retransplant? There are additional challenges, but the most difficulty happens in early retransplant for hepatic artery thrombosis, and that's where you have the biggest problem, and you have to really plan it well so that you know you have an alternate inflow. And occasionally, while you are operating, you may have a non-obstructive situation, low flow, weak pulsation. Intraoperative Doppler does not, pick up flow. So think of technical causes and solution. And what we would do is promptly redo it, even if it's going to add another hour, we'll redo it rather than try and of course you could ligate splenic artery, gastroduodenal artery, and sometimes that increases the flow. Splenic artery steal syndrome is first reported by Neuhaus from Germany. And actually, it is not such an uncommon situation when we started looking for it. And we find that some of them been associated with small grafts. And here you can see there's no flow. And Dr. Shanawaz has embolized the splenic artery, and the flow is returned. So that's something to keep in mind. So what about technique? Size matching, I think, is fundamental. Bearing of all peri-adventitial tissue carefully. Fine sutures, interrupted versus continuous. I think most GI surgeons who have progressed to liver transplantation use interrupted. And we've used the same technique in over 5,000 cases. Left hepatic artery, better size match at a branching point, does not bear the bile duct. So we do the right layer, interrupted, then we turn it around, left layer. So usually all, irrespective of the size, 2 corner stitches and 5 stitches in each layer. So these are results for pediatric transplant, 517, and we had 4 out of 9 developed HAT, 3 underwent re-exploration, re-anastomosis, 1 was IR guided, and I think, and similarly for domino transplants, we had a good number of domino recipient and 1 child with acute liver failure. Long time ago, I think when Shiraj used to be here with us, we showed that with time it improves. So the adult rate has come down a lot, and we published this in liver transplantation long time ago. What about conduits and extra-anatomical anastomosis? Generally not a good idea in LDLT. You have a variety of other vessels, left gastric, splenic, gastroepiploic, and occasionally we use the inferior mesenteric vein, for, a graft for an extension between, this is an error written here, and conduits and DLT are different matter. What about bailout procedures? Not really much. Stenting, I don't think it's a good idea. But the real problem happens when you have a biliary leak and a failing graft. And in the past, that used to be a big problem because of the bile leak. Then you did ERCP or stenting, then you would end up with bleeding vessel. Luckily, that complication, bleed from a hepatic artery following bile leak, has reduced now. Otherwise, it used to be a big problem. Whenever there used to be bile leak, I used to worry that there would be a bleeding from the hepatic artery. Pharmacological prevention, antiplatelets, anticoagulants, prostacyclins, nothing really works. And I think I have a strong view of using aspirin with CNIs in the early on period, because you have press that turns into a disastrous intracranial event. What about management of hepatic artery thrombosis? You need obviously to restore the flow. Both surgical and IR can be effective. If you're busy, then your IR colleague can help you out. If you're free, then surgery is the best approach. We don't actually have an algorithm depending on how it works. But if the IR person is doing it, you must have theater backup, because occasionally they may puncture the vessel, and then you have to take them to theater. And what we've done, and Dr. Shanawaz, I think is left now, he is that we will thrombolize with TPA and heparinize and remove all catheters. In the past, used to keep catheters there for sort of constant irrigation. That's not a good idea, but that eventually results in disaster. And of course, retransplantation. So here's somebody who had a thrombolysis with TPA and recovered. So in summary, therefore, hepatic artery complications can be prevented with good technique. Anticoagulants have little role, I think. Perhaps better to reconstruct all arteries by insurance, and can be managed by IR or surgery. Thank you for your attention.
Vast experience, sir. Sir, any time did you face donor side of the, or graft side of the arteries, complete dissection occurred up to inside the liver? And did you, what you have done, sir? Any renal portal, arterialization of portal vein or something else?
Yeah, I think what happens is that in the past I lost one patient right in the beginning, because I was trying to cut back and get a nice. I think the trick is to just do it at the dissected site. do not try and, that's what I believe in. And after that, you know, particularly somebody's had cholecystectomy, lap cholenol, and you will often find that the intima is separated from, but just do it there, do not try and cut back. But of course, it can, you know, the trick is to sort of see where the dissected artery lies in relation to the outer wall. So you stretch it and then take a stitch at the corresponding points. And usually it works. But your Doppler signals won't be there because there's stagnant blood all along the vessel. And it prevents Doppler signals.
So, as you said, hepatic artery thrombosis is an emergency. And the faster we try to reperfuse, the better it is. So what's your protocol for post-transplant Doppler monitoring?
So we currently do it, we have a very good Doppler service, and they will do it as soon as we call them. So in the first 10 days, we do it twice. And after that, they still do it well. If they're in hospital, they'll have one done every day.
Questions?
Do you use antiplatelets in all patients?
We don't. The reason is not because I think I mean, all of you will share that intracranial events happen after surgery. And if you use aspirin, then you cannot salvage these patients. Hepatic artery you can salvage, but if they are intracranial bleed, you can't salvage them. And actually, we had a couple of patients who had DDLT, and they were given aspirin to prevent thrombosis. And the graft, they had intracranial bleed, and we reused that graft successfully in 2 patients. Unfortunately, reused transplant. I think we got good publicity. I think we published it, I think, as well. So again tells you that if you get intracranial bleed and using aspirin, then it's a disaster.
I mean, I think protocols, we've used 75 milligrams aspirin for all recipients.
Yes, yeah.
That's something that I've learned from Australia, so every recipient gets it. In terms of Doppler, I mean, one thing is everybody doesn't have the luxury that Gupta has in terms of radiology. So I think it's good for all surgeons to do a bedside Doppler. In our unit, everybody does better. In fact, now our anesthetist does the Doppler and says results are okay. So
that's a good point. All our surgeons do it now as well. They all do it now. That's a very good point.
And a small point, I think we had a case about donor artery dissection, but we won't have time now to discuss that. Like Dr. Gupta said, I think the aim should be that you should go proximal to the dissection point. Even proximal dissection point, there'll be some separation of the intima and the thing, but you can still get away with doing an anastomosis there. But if you anastomose distal to the dissection point,
then,
the dissection will
then a problem. That's the point, the very important point. That's right. Very important point. Do it there and at that point itself.
Last point I wanted to make is for cadaver transplants, much easier than a living donor. But I just want to say it is so important to do the retrieval properly, because if you don't retrieve and you have a stretch injury, because you can't detect it, it's not visible, it just presents 4 days later as a hepatic artery thrombosis. So all retrieval surgeons, especially in the cold phase, should make sure that the artery at no time is stretched, especially against a connection or a junction. I think time to close.
Thank you very much.
Thank you so much.
Inviting me.
Next, we have an interesting case on paroxysmal nocturnal hemoglobinuria with Budd-Chiari syndrome. And I would like to call the panelists for this, Dr. Narendra, HOD, Consultant Hematology, Star Hospitals, and Dr. Ganesh Chauhan, Anesthesiologist, KIMS Hospital, and Dr. Sashidhar Reddy, Surgeon, Continental Hospitals, and Dr. Anand Gupta, Intensivist, TAG Hospital. I would like to invite the speaker of this session, Dr. G. Srinivas Reddy, Hepatologist, Star Hospitals, to discuss about the case.
Surgery is not. Oh, okay. So this is we'll discuss a case, vascular diseases in liver. He's a 32-year-old male. It was 2021. He was evaluated for anemia and thrombocytopenia. So that time bone marrow showed hypocellular, which was aplastic anemia, treated with steroids plus cyclosporin plus L-Trombopac. So in 2024, his CT was showed there is absent flow in right and middle and left hepatic veins. Evaluated outside for thrombophilia. The workup was negative. And he has presented with upper GI bleed in 2025 and he was recovered. So on evaluation, his hemoglobin is 6.6 and counts were 4,000 and platelets were 80,000 and INR is 1.56 and his total bilirubin is 11.94 with the preserved albumin 3.4 and rest of the kidney functions were okay. This is his CT, which was showed there is a complete, the 3 hepatic veins were showed block. So Dr. Shashidhar sir, what could be the probable diagnosis in this case?
So the complete block, it should be hepatic venous outflow obstruction. You can see marked cardiac hypertrophy also in this.
So in CT showed there is a cardiac hypertrophy also, along with the 3 hepatic veins were blocked. So it is suggestive of HUOTO. So our diagnosis is likely portal hypertension, non-bleeder, CLD, likely HUOTO, decompensated previously in the form of ascites, now jaundice. His current MELD is around 19 with CTP of 10, so with hemolysis. So what will be the next step of evaluation for these patients when the patient has some bone marrow involvement with some vascular involvement in the liver? Dr. Naren sir, what is your approach for thrombophilia workup?
See, in 2021, he had cytopenias with hypocellular marrow, and he was given a treatment with the cyclosporin and L-Trombopac. So it's most likely to be an acquired aplastic anemia, and he has responded to the treatment. If not at least a complete response, he became a transfusion independent. And with that, he was okay. And when he came back, he had as I remember, in 2024-25, he had a abdominal discomfort. And following that, when his counts were done, he was found to have a thrombocytopenia. So, because his thrombocytopenia is there, he was given L-Trombopac again. So at that time, probably the thrombosis would have occurred at that time, but it took for some time to recognize. But again, giving L-Trombopac at the time with the patient of thrombosis, it was not a good thing to do because that itself is the thrombogenic. So I will think because of the thrombosis and cytopenia, that is one of the in hematology, that's the indication to evaluate for a PNH. So for the reason, that's why we evaluated, and he was found to have a PNH. On the flow cytometry, we evaluated for a CD55, 59 antibodies, and they were negative, so he was diagnosed PNH.
So what will be next line of management in this patient? There is a patient has preserved synthetic function with hemolysis, with liver cirrhosis. So what will be the line of treatment in this case, Dr. Naren sir?
See, he had anemia, which is requiring a transfusion. I think before coming to hospital also he received CD5A antibody eculizumab. That is the treatment of choice. But unfortunately, it is not there, and we have to import it, and it's very costly. So as a second measure, we can start steroids. Actually, now the book says that don't give steroids in the PNH with hemolysis. It is dangerous, but I don't think we have a choice. So still it works, and we started low dose. It's not. We should start low dose steroids. It should not be more than 20 milligrams per day. So for the hemolysis and the cytopenias, with overall this thing, we started the steroids for it.
So he was started with low dose of steroids with Visalon of 20 mg. His bilirubin has came down to 2.94 and preserved albumin. So he has came out from hemolysis at this point of time. But he has underlying HVO-TVO with cirrhosis. He has sarcopenia, and his weight has not put on. So should we go for liver transplant alone or combined liver transplant and BMT alone with this?
See, I mean, combined transplant is a very risky with the cytopenias and the amount of, I don't think any reports are, if you look at the condition of the patient of aplastic anemia, cytopenias, infections, and requiring platelet transfusions, I don't think we can go for a combined. Only thing is whether we have to choose between liver transplant first or stem cell transplant. So between those things we have to choose, and based on the condition and etc. we can choose. Initially I was thought that we should give a chance with the steroids. If there is an improvement, probably then we can, the coagulation parameters, they will be better. So we go to liver transplant, and after that probably we can think of a stem cell transplant.
So suppose this patient is not improved with steroids, there is ongoing hemolysis is there. The patient has donor, with the same donor, should you think about first BMT, then followed by liver transplant?
Yeah, if there is no improvement with hemoglobin or the platelets or any hypocellular is not recovering, probably we can think of it. Will be high risk stem cell transplant, but again with the modification of the newer conditioning regimes, probably we can do a allogenic stem cell transplantation first.
Okay. So is there intraoperative challenges in these patients with the coagulation monitoring, with the risk of thrombosis and the balance hemostasis balance between thrombosis and bleeding in these patients, Dr. Anand sir?
This is one side is behaving like a CLE, thrombocytopenic, chances of bleeding is high. Anotherly, there is a thrombotic state.
Yes.
So pro-anticoagulant and anticoagulant, we both are fighting here. And once you will go to the induce these kind of patient and then will bend up to the anapatic phase or the pre-anapatic, where they are not able to synthesize the factor 2, 8 and fibrinogens, their chances of bleeding is high.
Right.
So there is a routine test like PT, APTT, INR or platelet, they will not give that because they are static. So you need a global coagulation. So TAG, ROTAM or TAG6S, they can give the better because overcorrection also will complicate in the post-operative period.
Thrombosis.
So basically, definitely there are chance of, secondly, itself etiology. These are the outflow obstruction and then IVC thrombosis are there. Surgeon will take definitely more time as compared to the other routine cases. So chances of bleeding is high. So tag waist correction is the important things. Don't overcorrect, and that is the only things we can say.
So tech-based correction is better than.
Can I have?
Yes, sir.
See, I'm just reading that. The eculizumab, the new drug which has come in, then one of the important thing is about it, it's able to prevent the thrombotic tendencies. So the lifespan and the survival increase with eculizumab. So when they have done a few studies where the PNH with any surgery, any cholecystectomy or any surgeries, what they have given is even though they were taking the regular medicine, they were able to give just before the procedure the eculizumab, and again after a few days post-op eculizumab is given. With that, whatever the few case reports are there, they could able to achieve without any major thrombotic episodes. So I was just thinking, because his counts have improved, probably, of course it's a costly, we can't give him for lifelong, but at least we can give eculizumab for before the procedure, and another dose is a few doses, not many doses, 2 doses, and prevent the complication of thrombosis.
So in this case, what are the challenges for liver transplant, Dr. Seshidhar sir? So the patient has underlying PNH with vascular thrombotic episodes. The risk of recurrence, likely most of vascularity, inflow and upflow obstruction like portal vein thrombosis and hepatic vein thrombosis. So is post-transplant also hemolysis, if the ongoing PNH is there, So there is a chances of hemolysis, hemoglobin drop, or persistent thrombocytopenia. So what are the take-home these things?
There is definite chances of recurrence post-transplant if it's not managed well. In selected individuals, even eslizumab, there have been reports which can cure better control of PNH, because in these patients, definitely they suggest the long-term, like lifelong anticoagulants are better to prevent the recurrence of these thrombotic events, even post-transplant. There have been instances where hepatic artery thrombosis, portal vein thrombosis, and even the need for retransplant also was there. So I suggest better for long-term anticoagulation in these kind of patients, post-transplant.
Okay. Any take-home points from Naren sir?
Yeah, if only transplantation is done, we need to go for anticoagulation. I think if you do the stem cell transplantation, the clone will not be there. So then we can stop. But again, if only we've done a liver transplantation, then we, at least for a time being, when we take up for a transplantation, you still have thrombotic tendencies. Probably we need to continue anticoagulation.
So Anand sir, is these patients has more of thrombotic patients? So how will you manage fluid management in perioperative periods? Is it same like standard patients, or is different in this case?
So if you will discussing about the fluid management, mostly in intraoperatively we have advanced hemodynamic monitoring. If you are going with the PICO or the volume view, that will tell us, because definitely if you are giving more volume, it will complicate in the post-op part. So I think the advanced hemodynamic monitoring can be addressed in this kind of patient.
So what are the experience of eculizumab, this C5 antagonist with in PNH with liver disease? Naren sir, what is your experience in this case? Because in routine practice, we not seen, maybe in 5 years of experience, maybe this is second case what we are seeing. So what is your experience, how to deal these cases?
See, if the eculizumab is available, it is cheap, that is the best thing to happen. But I could able to use only one patient. Basically, he's a film producer, so he could able to get, he got the medicine and came to me, sir, give the injection. So he is a patient of aplastic anemia who turned into PNH, who had developed complication of PNH. We gave few doses, about 4 to 6 doses, and in that period he was transfusion independent. He had some liver dysfunction also, but he could able to tolerate, and it's a reasonably very good drug. At least it works for about 80% of the patients. So actually, when compare in the beginning, see when in 2021 itself, the treatment of acquired aplastic anemia, which incidence about 5 to 10 per million. So the best chance would have been given, whether he was given an ATG therapy, the first choice would be, most likely would have been, non-severe aplastic anemia or severe aplastic anemia. So in the first instances, we should have gone for ATG or transplant. You would have not have these kind of problems. So most of the patients which I have seen, acquired plastic anemia patients who developed PNH, most of them are partial responders. So the stress of hematopoiesis will be there, and because of that, the PNH clone comes up. So that is propensity to develop a PNH. But who had a very good response with the ATG, of course, post-transplant, they will never have these complications. So probably if you had given a full treatment for him in the beginning itself, so probably you would have developed these complications.
So as you told, one case you have given eculizumab. How you are monitoring? Suppose before giving, we need to do that flow cytometry. Even after giving injections, are you monitoring with this flow cytometry, or is there any role?
Only thing it works is whether you become transfusion independent or not. So that was the main criteria, whether it's working or not. But generally, I don't have that. I'm monitoring the CD50 activity, the complement activity. So I was mainly looking at whether he's becoming a transfusion independent. That was the main activity.
So previously, maybe around 10 years back, if the PNH is there with the ongoing hemolysis with the liver disease, they told it is a contraindication for liver transplant. So what is the take-home message from you, Dr. Shashidhar sir? Is these cases, whether to tell now even it is a contraindication, or you can go for transplant with standard precautions?
Yeah, before definitely it was a contraindication for transplant, but now there have been reports with in selected individuals with stem cell transplants who have PNH in the context of BCS. There are good outcomes, and then we can go for a liver transplant. Or with if eculizumab is available very readily, as it's a complement inhibitor, in PNH, what happens is the regulatory proteins, complementary regulatory proteins are deficient. It causes excessive platelet stimulation and makes the red blood cells more viable for attack from the complements. If this is available, then if PNH is controlled, then the transplant becomes very feasible in selected individuals of this, in context of BCS.
So do you want to do for every patients with vascularity of diseases with liver involvement, do you want to do every case for PNH panel for all liver cases? Naren sir?
So PNH, generally any unexplained thrombosis, we work for a PNH. PNH without cytopenias can be, it can present just as a classic PNH, where there is when you do for workup for a PNH, one is that where you don't, hemolysis, no cause was there, so you do that. And there are cytopenias with thrombosis, or maybe unexplained thrombosis also, we should do the workup for PNH. Generally now with unexplained thrombosis, we do APLA workup and the acquired causes, acquired APLA and PNH. And generally we stop doing workup, extensive genetic evaluation for thrombosis.
Thank you, sir. Any questions?
Are there any cases of combined bone marrow liver transplantation published so far for PNH?
So there are.
I just checked, Srinivas, but doing at the same time it's not there. But most of the cases where the kidney transplant has done, liver transplant has done, who has given after for other reasons, it's a reasonably good reports. But combined doing at the same time, I have not seen.
It's not this.
But again, after a solid organ transplantation, doing a stem cell transplant were done and almost with a similar success.
Same.
Thank you.
Any questions from audience? Thank you, sir.
Thank you.
Okay, I've got this this long list of vote of thanks. I think this was a major undertaking for us as a team, probably the first undertaking as a team, and there are many people whom I have to thank. But first, I'd like to really thank my team. Where is Rajgopal? He's gone for lunch, huh? I think Rajgopal, Raghuram, Prasanna, Srinivas, Sunil, they've really worked, and Karthik and Sushmita, they've really worked hard, and without they working for the last 1 month, none of this would have been possible. Can I ask all of you to come onto the stage, please? Guys, come. Come. So this vote of thanks is actually from all of us as a team. I think first I'd like to thank the hospital management, Dr. Gopichan, Dr. Ravindranath sir, Dr. Ramesh Kodapati, C.V. Rao sir, Dr. Rahul and Mr. Venkatakrishnan from the hospital management who took up on our idea of having a meeting at a national level and agreed to put in their efforts and more importantly the money behind this. Because we really weren't sure whether we're going to actually get any funding for this. I really like to thank them, and without that, it would have been absolutely impossible even to actually conceive a program like this. Like I said, the faculty, we've got an exceptional quality of faculty for this meeting. Very senior people from across the country had agreed to accept our request, and they've actually come in the morning, given the lecture, taken part in the discussions, and then left the same day, which is actually remarkable. And I'd really like to thank all of them who agreed to come. The delegates who have got delayed lunches and delayed dinners, and still stayed in the hall and listened and participated in the discussions. From the STAR management, Dr. Praveen, our medical superintendent, Shravani, Deepika and team who looked after the nitty-gritty of running the meeting, starting from discussions before the meeting, getting the delegate registrations, the kits and everything sorted out. Mr. Pavan, Shayani, Akhila, Gopi and team, and Prasad for the branding and the design. The audiovisual team, Hari and team the audiovisual was actually perfect. We had no glitches actually for the 2-day program, which is very uncommon, given that we are doing this for the first time. Ms. Sunita, Anirudh and team who were involved in all the discussions with the sponsors and who helped us with the arrangements. Raj, where are you going? Keep it. And to the sponsors who even though it was very short notice, they agreed to support us in this conference and support us financially. Thanks to the Westin team, Ritika and team, the banquet conveners, Ravi, Abhilash, Aditya, the transport desk, Mr. Ramraju, Ajay, team, and Kristen, who made sure that everything was flawless, pickups and drops of all the faculty and some of the delegates was done absolutely well. The marketing team, Balraju, Mr. Anuj Panda, Shabir, Satish, and others who made sure that the message about this meeting reached far and wide across the country, and obviously all the journalists who were able to cover this, and obviously my Chiranjeevi sir, who yesterday you saw, he came here, he gave such a heartfelt talk about the importance of organ donation, and I hope that really is one of the biggest outcomes from this meeting of putting the message of organ donation out in the public, and this is what we need from respected celebrities. They endorsing, and he actually gave his own personal example how his mother-in-law donated her rice after her death day before yesterday, and that's such a strong message, and I really hope that this kind of things really increase organ donation in our states. So thank you very much. Thank you for the patience, and thank you for joining us for this meeting. Thank you.